Good morning, all. I hope all are today fresh after yesterday's celebration. I invite Chairperson Dr. Sanjay Mehta and Dr. Sudhir Mule on stage. Nutrition has always been sidelined in managing children in PICU. I invite Dr. Samir Sadavarte to make us aware of the importance of optimal nutrition for a critically ill child. Thank you.
Okay. हेलो वैसे भी मेरा आवाज़ बहुत बड़ा है तो it should be okay. So first I thanks to the organizing committee of Mahapedicriticon in Solapur, and with us organizing chairperson Dr. Dayanand Nakate sir, chief of the patron Dr. Sunil Vaidya sir, and rest of all my friends, and with Dr. Vikram, Kundan, Keyur, Samir Khan. There are so many names, so I will not take all the names because if I forget someone, then they will kill me next time I remember it. So let's see here. आगे कैसे जाता है? It's not going up. Okay. So optimizing the nutrition in the PICU. The topic is vast, and I will talk about something here. Just as a disclaimer here that you know Walt Disney. He always used to say, just don't talk, do something. So here also I am trying to do that way. As you know that working in the PICU, our always aim is what? To reduce the hospital stay, reduce the hospital cost. And believe me, one of the part of this is optimizing your nutrition. Just keeping the nil by mouth or nil per oral for even one day, the cost will increase in the tertiary care hospital is almost by 30 to 50,000 rupees. So restricted financial support with us, we have to think about is the nutrition, that too early nutrition, and for this we required a team. The team which should be aware of how to utilize the way to optimize the nutrition to reduce the number of stay in the hospital. So as per conflict, no conflict of interest, from personal practice, from PubMeds and from the international guidelines, from the various groups, there are multiple groups are there. That's Hispanic, ISPAN, ASPAN, American Society, and also the Society of Critical Care Medicine. So from this, I tried to mop up my presentation. So as you know, the nutrition plays the vital role in the recovery and outcome of a critically ill child. And to my best practice, what we do, we try to mobilize all the things together. What actually nutrition do is actually helping our immune system. We know it's made up of multiple things like macrophages, neutrophils, all these required energy to get it. We have the immune system which help us to prevent the bacterial, viral or other types of infections. Nutrition has some role. Reduce the number of stay in the hospital. Yes, we have the role here. And in sick child who is in the catabolic phase, for this also we need to have nutrition. So it's very important that we should play aware of this part. The child as a vulnerable population. So why we talk it like a vulnerable population? So there are certain things which are patient because of pediatrics and also because he is in the ICU right away. So they have a small energy reserve. They are dependent on someone so that they should give feed to the child. Child has low immunity, has higher basal metabolic rate. Quick starvation can occur within 24 hours if you don't feed such crickets. And of course, obviously, the other possible things that might be additional part, apart from the ICU, that's the poverty and child abuse, where you see optimum growth is not happening. So we have different types of scenarios. You have seen the patient comes in the ICU, the child requires resuscitation, the child is in the cardiac arrest. Child may be in the secondary level ICU where are multiple patients or 2 or 3 patients on one bed. That is also part of ICU we have in India. This is a modern structure like a tertiary care or quaternary care, and we have monitors with us. So ICU is a busy unit, and always everybody thinking about the how to make the child survive. But it's not just like a survive, but how to reduce the number of stay in the hospital, how to decrease the number of things which we are doing as a concern for a child, doing interventions. So initial steps, what we do as like any child coming in the ICU who is sick, very sick, the most important thing is a part of nutrition also is to provide oxygen and give some energy or oxygen to the tissue level. And that's what is the reservation for the organs to get the perfusion well. So in the acute phase, when it happens, there are a lot of changes that happens. One are like endocrine causes, there are certain metabolic things happens, and immunological reactions. All together, combined together, that causes a complex thing, complex approach in treating such patients. And the smaller energy reserved there, and there is a high metabolic demand to counteract. So we have compromised energy and compromised protein delivery to the peripheries. So mechanism, whatever thing we need a glucose or we need something for the immediate result, and for that we use gluconeogenesis and glycogenolysis. So gluconeogenesis is what? For anyway, whether you have amino acid in your body, whether you have carbohydrate, we have proteins in the body, all this converts to the glucose. So it is just happened because it's a life-saving thing to maintain the glucose level, to maintain some energy in the body. So this has been utilized. And that's actually what happens with that. It causes insulin resistance, it causes stress hyperglycemia. So overreaction, and we have hyperglycemia now, which is also equally important where you have hypoglycemia to worrisome about. So to happen with these ones as a mechanism, initially as a primary came to improve the oxygenation and improve the glucose, certain profound catabolism happens over the next few days. And thus it causes the severe malnutrition. So we ever talk about the protein-only malnutrition in the general population, but what happens in the ICU stay, actually we are more worrisome for this one also, because it increases mortality as well as the morbidity over the prolonged phase of illness. So different cases, we have different problems. Every person, every child in the NICU or PICU, it's a tailor-made way we have to do so as to optimize the nutrition in such cases. So I will say within first 48 hours, we have to stabilize the patient, and at the latest, at the least is by 48 hours, you should be on some feed to the child. That is the most important goal, and that is the integral part of pediatric critical care. I already mentioned about individualized role, because the child may come with, the child has burns, the child may be with a nephrotic syndrome, the child may have different varieties. Pediatric ICU is actually made up of CVS, cardiology, CNS, endocrine, rheumatology. Sir is also speaking here. So every child is individual, and that's why we have to do a tailor-made approach or case-by-case basis approach for tackling with the nutrition. If you don't pay attention to the malnutrition itself, actually causes 25% cases additionally burden later on. So everybody now realize that we need nutrition for the immune function to work, for the wound healing, for the prognosis of the overall of the critically ill child. So malnutrition, as everybody knows about this, I will just keep this slide in the way of having less time with us. Nutritional assessment. So when you comes the child in the ICU, few things which we should do and never forget, whether it is a tertiary care, whether it is a primary care. You must do some anthropometry, biological measures, some clinical evaluation, and of course ask about the dietetic history. And early and ongoing assessment is also important. So first thing is initial stabilization, maintaining the perfusion, maintaining the blood pressure, preventing or reducing the shock state. Immediately comes your assessment and early diagnosis. Nutrition assessment, there is a strong kids. If you put this word, you will see a lot of literature on this part. So anyway, whatever thing is there, whatever way you chart presents, you have to assess the child for the dietary history, for functional status, and find out the screen tools that reduces the impaired nutritional status. But believe me, there are so many scales are available in the market, or even like people are doing. None is 100% guaranteed to tell about the exact way. The most important finding what they notice nowadays is by doing the ultrasound muscle mass. But again, that is for the therapeutic purpose. Rather than that, it is for the purpose of investigations and do certain studies further, which is required. Anthropometry, obviously, you are doing like a weight, height for length. Just age is not the matter. We have a child who is like 1 year, who might be like a 4 kilos to 12 or 13, 14, 15 kilos also. So it depends upon actually the weight of the child along with the height with length. Body mass index should be calculated in all the cases. Mid-arm circumference, particularly the places where you don't have the facilities available. So for 1 to 5 years, we take it as like a mid-arm circumference, where a less than 10.5 taken as a malnourished child. And if the child is less than 3 years, you should preferably also go for the head circumference. What is the nutritional goal? So there are different terms, small terms, they are just intermingling with each other. I'm just trying to highlight. My presentation is not for the hi-fi. I just realize that we have the crowd which is most of the medical students and general practitioners. So not talking too much about the ICU and ICU studies, but we'll go for the basic things to be added here. So goal obviously is to achieve the balance, support for your growth and development, and prevent the deficiencies. So to achieve my goal, I have different types of nutrition available with me. That's one is obviously enteral nutrition. So enteral nutrition is the most important thing compared to the parental nutrition. Our goal is to start as early as for early nutrition, that is the enteral. So in the enteral nutrition, we have different types of formulas available with us, particularly if your child is NICU or like an infant who is not tolerating the food. It may be because of the intolerance, it may be galactosemia, it may be secondary galactosemia, it may be secondary intolerance, it can be because your flora, gut flora has changed. Whatever reason is happens, your body is not able to utilize the actual food. So in such cases, we have something called like a hydrolyzed formulas, and you have the elemental formulas, where you have only just like a basic amino acids which you require, you are giving that too. So it should be easily digested. So that's what important is. Standard formula is the best, but obviously if it's not getting digested, you have different types available. Different methods. If you are able to take orally, that is the gold standard, yes. But sometimes you have child with a very small, there is a chance of getting aspirations. The child might have GER, GERD. So in such cases, we can use, instead of giving the feed, we can give NG or other ways to calculate and make the child nutritionized better. Bolus feeding can also be tried, or sometimes just giving the continuous feed is also okay. So enteral food may be in the form of liquids or maybe in the form of semi-solid way. We can try off. You can have some things like having the parental nutrition or nutrition along with parental partially way. So oral way, it is the best. If not possible, then NG feeds. Even sometimes in the NG feeds, you can have GERD like diseases where you have problems with stomach getting not getting emptying and vomiting can happen. So in such cases, jejunostomy and gastrostomy can be done, and which way we can feed this child. So ultimate aim is to feed the child. And it's a complex way. It also involves the liver to get utilization of the food. That's the enteral nutrition. Advantage, it supports intestinal immunity, which is not happen with the parental nutrition. Improvement in the immune competence can happen. It also helps for the mucosal barrier against the pathogens, various pathogens that can be gets interacted. By giving enteral feeds, we can counteract that. And thus, it improves the intestinal perfusion. But sometimes it's a contraindication, not an absolute contraindication, but relative contraindication. So relative contraindications which might have something like acute bowel obstruction, a child who is already in the decompensated shock. So first thing is to treat the decompensated shock, and our aim to start by 24 to 48 hours the enteral feeds. If you have uncontrolled GI bleed, sometimes you have the high output fistulas, certain types of cases where we have. So in those cases, we are not able to enterally feed such kids. So we have to go for parenteral nutrition there. Side effects I already mentioned. By feeding orally, you might go for overfeeding. That is also more dangerous because overfeeding itself can cause vomiting and aspirations. So parenteral nutrition, it is also one of the part where you are not able to give the enteral feeds to the child. We have something where we have direct passage into the systemic circulation. So here we don't require the liver and liver way to go, but there are a lot of problems by using the parenteral nutrition. patient can get metabolic complications, more chance of getting infections because you need some invasive lines here, and sometimes putting the invasive lines, keeping for more days, actually it causes more of infections. What is mentioned in one of the Pepanic trial, where they tried giving enteral feed and then also the parental nutrition, and they comes with certain guidelines, and what it mentions that if the child is otherwise clinically stable previously, before admission in the ICU, so in such cases you can wait even as late as like for 7 days before starting the parenteral nutrition. And they have noticed and they found out with the studies that it improves the clinical outcome and in fact reduce the hospital stay if you insist on the enteral feed and postpone the parenteral nutrition for few days. So now we'll go for some extent how we give the feeds and what exactly we give. Because optimized nutrition is not just like giving feed. What type of feed, what type of proteins, calories, and you require to give him carbohydrates and fats. So it generally it's mentioned something around like say 100 calories per kg body weight. That's a standard formula. We have something called as Holiday-Segar formula. Everybody knows about that. I will not go in details. As the age advances, your per kilo weight wise calorie requirement is lesser. So for the adult or like adolescent cases, we have something like around 25 to 30 calories which required per kg body weight. So calorie requirement, as we know, 100 I told about in the infants and goes slowly down. But child who is in the acute phase in the ICU, sick child, you really don't require to target or trace to the actual requirement. Even as low as like a 1/4 of the feed is also just sufficient. So like in acute stage, 20 to 25 calories per kg, it should be okay. And of course, it depends upon how much actually is your demand, and more demand if the child is lesser age. Like suppose for neonates and infants, you require per kg more requirement of the energy. So energy demand equations, how you calculate the indirect calories ways, so that's a gold standard. We should actually try for this, but actually this one requires non-invasive way in the ICU stay, where you do indirect measurement of your oxygen, your carbon dioxide, out are the gases coming out. So you measure it accordingly. You also analyze with the gas way, non-invasive way, calculate the metabolic rate, and your calories what actually you burns. So it depends on all these ones. So it is not a very easy way, but that is the only gold standard where we can use this way to mention exactly how much you require the energies. So other way is also measure the VO2 and VCO2. Yesterday you heard about this part. Certain types of reactions are there or equations are there as Harris-Benedict, and then you can have hypocaloric target. So not go for 100%, go for 50 to 70% of the calorie requirements. So hypocaloric nutrition, that means should not exceed more than 70% of your regular body weight. You should progress it over next 3 to 7 days to achieve the 100% goal, and postponing the parenteral nutrition as per the SPAN guidelines, particularly in the first week in the PICU. So what exactly is the protein demand? As you know, in the NICU, we start with like say 0.5 grams per kg per day to up to maximum of 3 grams per kg per day. In a children, we require around like say 1 to 1.5 grams per kg per day. And obviously, your requirement should not go beyond the 3 grams per kg per day or 2 grams per kg, because it will increase the solute load on your kidney and cause kidney damage with that. So 1 gram of proteins give approximately you 4 calories, which is equivalent in the carbohydrate as well as in the proteins part. Carbohydrates, approximately 1 gram will give you 4 calories, and the intake is approximately should be like between 40 to 60% of the intake. Different types of carbohydrates available and which your body is utilizing. They might be like monosaccharides, you have oligosaccharides, you have polysaccharides like starch. And your requirement of glucose should be like 0.5 to 10 mg per kg per minute. The best is around like say 4 to 5 mg per kg per minute. Lipids, we know it is a more significant way because it gives more calories. So 1 gram of lipid actually gives you 9 calories of energy. Also required that you require the lipids not only just for the calories, but also to absorb some solute absorbable like A, D, E, K vitamins. It's a part of your phospholipids so thus creating the cell membrane. So it is utilized for most of the things as a lipid part, and we have different types of fatty acids which are essentials like omega-3 and like omega-6, that is linolenic acid. So parenteral nutrition, you should have around 10 to 20% of the emulsion fat in your energy intake. So 10 to 20 for the lipids, 20 to 30 for the proteins, and 45 to 65 for the carbohydrates. Don't forget about the essential elements in the form of copper, zinc, selenium, and also the vitamin C. Vitamin C, one time it was the most important medicine was taken as a part of a survival sepsis campaign, where additional to the nutrition, vitamin C was considered as one of the vital part. But the new study has come out, it is not like that essential now. Important also, when you are feeding the child, most of the times you are only on the DNS or glucose type of therapy. But only giving glucose and not feeding this child actually causes a lot of catabolism. So how glucose helps here? So there are two ways. One is hypoglycemia, one is hyperglycemia. Both are dangerous. And it happens because you keep sometimes called as a fish trial, where it was make tight glycemic control, where to keep the glucose around 80. And they thought that it might help. But actually what happens with giving this way, the child getting more of hypoglycemia, and that's why the study was stopped. Other way around, if you give too much of glucose is available, it increases your free oxygen radicals, it increases chance of getting sepsis, and sometimes even thrombosis. So we have to balance ourselves how to give your glucose to the child. So hyperglycemia, it also causes increase in the CO2 production if you give too much of the glucose to the child. There are a lot of different ways, mechanism. I don't have time right now to explain this. And also, I already mentioned about the increased infections. Nice sugar trial, it's one of the important things we should know about this, where they notice that if you have hypoglycemia, increase the risk of death happens. I need 2 minutes more. And tight glucose control risky because it causes hypoglycemia. And they realize that hypoglycemia causes more mortality if it happens particularly in the first 7 days of the life. So if you see this curve, you have hypoglycemia on one side, you have hyperglycemia on the other side. So less hypoglycemia, less than 65, your mortality is more. If it goes beyond 200, mortality is more. So monitoring adjustment, you always track and check about the weight, lab values and clinical signs when the child is in the ICU. Thank you. So challenges, we have something called as like feeding intolerance, which can happen in the ICU. Interruptions, because of certain times you do some procedures, and sometimes somebody assume that the child may get a lot of gastric aspirates, or he feels the child is not looking good, or somebody say abdominal distension. So actually it may not be the contraindication, but if somebody says like that, no, the child has distension 2 hours back. Now it was 2 hours back. Now the child is stable, you start feeds again. But we are not starting, and that's causing the challenges. And that's why we need some multidisciplinary approach. So conclusion, optimizing nutrition in ICU is very crucial. Tailor-made, it is individualized basis. Person to person changes happens to ensure each patient gets optimum nutrition demand effectively. Supportive therapy should be started immediately. Check for the admission time, the stabilization of child is more important. But once it's available and once it's done, you go for the early nutrition. In absence of contraindications, like what are the contraindications? Decompensated, unresolved shock, gut ischemia. Apart from these ones, the child must be on the enteral feed, that is through gut or through oral way. Take home message, start and initiate your thinking early. Enteral feeding is critically ill neonates. It's good, we should start it as early as possible. And sometimes you can have something called as polymeric formulas, which are easily available, and utilize those to get the immediate energy and protein to the child. So is the ICU, is the intensive care, is the expensive care? Yes, it can happen as an expensive care if you don't pay attention, keeping the child more in the hospital. And one of the reasons for this is because you not started your nutrition or starting enteral feeds early. And that's why it can become the expensive one and difficult to rehabilitate later on. Thank you very much.
Thank you, sir.
Thank you, Dr. Sameer Sadavarte. For our next topic on metabolic encephalopathy in this symposium, I invite Dr. Abhijit Bagre on stage.
Good morning, everyone. Today we'll be talking about a topic called as metabolic encephalopathy. And many a times when we think about it, we always think, is it some inborn error of metabolism? Are we going to talk about some complicated stuff? So I think it is much more broader term. It includes many more things. We'll look at them step by step. Because IEM per se is an important topic, but yes, for most of us it is difficult to understand. Okay, so these are the topics which I am going to go through. What is encephalopathy? What are the different etiologies of encephalopathy? Then we'll talk about this metabolic or a broader term called as toxic metabolic encephalopathy. Then we'll speak about approach and evaluation. And most important, we'll see some common examples which we see often in our ICUs. So encephalopathy is a condition where there is basically acute global cerebral dysfunction resulting in alteration in sensorium, consciousness, cognition and behavior. Okay, so it's a very broad term and there are multiple causes. Metabolic or toxic metabolic is just one of the subset, and it can be present or it can manifest with heightened state of behavior in which agitation, confusion, irritability are the features, whereas it can come with depressed features like depressed encephalopathy like lethargy, drowsiness and inattentiveness or even inability to recall. Also convulsions can be part of it. And why I put this children versus adults, because in adults assessing sensorium especially is comparatively easy, but for smaller children there might be various confounding factors like age, stranger's anxiety, hungry child or sleep pattern which is slightly difficult to understand, and hence encephalopathy may be difficult to pick up. Now when I say metabolic encephalopathy, first we need to understand what are the other etiologies, because nobody comes with a label of metabolic encephalopathy. We need to rule out other causes, and they include infections. More and more commonly what we are seeing is inflammatory, that is ADEM or autoimmune encephalitis or post-infectious inflammatory diseases. Then hypoxia, ischemia and hypercarbia, again common causes. Seizures and post-ictal problems, again epileptic encephalopathy, and then the toxic metabolic, we'll see it later. Trauma and post-trauma problems, vascular problems like stroke, hyperviscosity syndrome may be seen in early in neonates, then pressure problems or raised ICP like SOL or hydrocephalus, and then rarer causes which are more common in adults like migraine and psychiatric problems and paraneoplastic syndromes. Now, when we enlist so many things, we need to understand how are we going to approach them, and the easy way to do that is look at how they present. So, hyperacute, acute, subacute and chronic. Okay, there are no specific days or dates or duration definitions here, but what we need to understand, hyperacute is typically metabolic derangements like hypocalcemic seizure or hypoglycemic encephalopathy. Trauma, seizures, HIE, drugs and toxin, press, again a common problem. Infections like bacterial and viral, then stroke, ADEM, these are coming with acute. Subacute are more like hydrocephalus or TBM, fungal infections, vasculitis, CNS vasculitis, and the chronic ones are typically IEM, genetic syndromes, SOLs. These are the things which we look at, chronic encephalopathy. Now, let us understand this word metabolic encephalopathy, which was coined by Samuel Alexander Kinnear Wilson, a British neurologist in 1920s, when he discovered basically Wilson's disease. So, it's a clinical state of global cerebral dysfunction induced by systemic stress, and the word comes in picture after ruling out the infection, inflammation, HIE, hypoventilation, all those things. And a broader word which is used more in adult is called as toxic metabolic encephalopathy, where we not only look at metabolic derangements, IEM, that is inborn error of metabolism, endocrine organ failure, but also include the drugs and toxins. So it makes the word toxic metabolic encephalopathy. Now let us look at the etiologies. So we have electrolyte disturbances, very common, hypocalcemia, hypo or hypernatremia, hyperphosphatemia and magnesemia. Then septic encephalopathy, many a times we see that a septic shock patient has come, you do LP, he was altered sensorium. It turns out to be some other sepsis, CSF is normal, but the child had encephalopathy. So this is typically septic encephalopathy, which is related to the cytokines related to sepsis. Then inborn errors of metabolism, we have a separate slide on that. Then the organ failure. I have put this word that if there is hepatic encephalopathy or there is a uremic encephalopathy or even respiratory problems like hypoxia or even hypercarbia, what we see typically for various reasons, if there is hypoventilation, say post-trauma, the trauma may be minimal, he had a seizure, the seizure also has aborted, but hypoventilation causes the encephalopathy. Then the metastorage disorders like Wilson's or the hemochromatosis. Endocrine problems, we typically know of hypoglycemia, but we also see DKA going in cerebral edema. Then hypo and hyperthyroidism, again in extreme of cases, and even adrenal crisis. Then PRES, progressive reversible ischemic encephalopathy syndrome, and then the nutritional one, Wernicke and refeeding syndrome. Have you seen refeeding syndrome anytime? So I remember one of our liver transplant child who we started with TPN because he was NPO for a good amount of time for some surgical problems in abdomen. And after starting that, suddenly lactate started crying, he started becoming very drowsy. We did not know what was happening. We ruled out everything else, and finally it was the TPN what we had started. Now let's look at the drugs and toxin. Again a big list, and the drugs could be accidental or suicidal in content or intention or homicidal, recreational. Then you have iatrogenic and more important idiosyncratic also. Like metoclopramide or domperidone, if you do it too much, we have seen a child with developing extrapyramidal symptoms. So commoner ones are antiepileptics, sedatives, antipsychotics, chemotherapy-induced methotrexate and all those things. Again, the common drugs are tacrolimus, cyclosporine, steroids. These are the common drugs which cause this. And then drug withdrawal like alcohol and opiates. Many times our ARDS child, when you extubate, for those next 2 to 3 days, very irritable, drowsy, we don't know what is happening, and those are typically those withdrawal of opiates and benzodiazepines. The toxins, again, commoner ones are OP poisoning. We may not see in big cities, but yes, rural or suburban areas we do see them. Camphor poisoning, naphthalene, again very common in children. Carbon monoxide, where the child got exposed to burns. And then the cannabis, marijuana, these are all recreational drugs. Snake bites, scorpion bites, and then lead and mercury. So various etiologies which can present with metabolic encephalopathy. Now this is a difficult one. We need to understand there are many various types of inborn errors of metabolism, but can we understand them? So neither I am metabolic expert and many of you are also not. So those diseases are often difficult to understand. So I think this is one easy way to look at that. How is the child presenting? If it is hypoglycemia phenotype, then they come with early neonatal age group, apathy, dull, feeding problem or seizures. And then there are etiologic like hyperinsulinism, then glycogen storage disorders, fatty acid oxidation diseases. These are the common things with which it presents. Then the intoxication phenotype, where the urea cycle defects and organic acidemia come with. So the child develops nausea, vomiting, dehydration, coma, muscle tone abnormalities, and these are often triggered by a precipitating event like an infection or a fasting. Then the cellular energy metabolism defect. These are basically mitochondrial or respiratory chain defect, and they have multi-systemic involvement. So there might be involvement of heart, a liver injury, a kidney injury, muscle injury, and again they are precipitated by the stress. And the rarer one and more difficult one to diagnose is the neurotransmitter defect phenotype, where it presents with more of developmental delay, organomegaly, infancy, childhood problems, convulsion, tone, coma. And they are MSUD, then Menkes disease, and pyridoxine deficiency seizures. Okay, so we'll see 3 important and simple flow charts which you can get it from any important article. So if it is hypoglycemia, what we look at is it happening just after a meal and it was unexpected? Then we are looking at hyperinsulinism. If it is some hours of fasting, there is liver which is enlarged and raised lactate. It may be GSD. After full night of fasting precipitated by infection or stress and high lactate, it may be fructose 1,6-diphosphatase deficiency, and ketone negative, but again precipitated by full night fasting is ketone, then it is fatty acid oxidation defect. These are difficult to remember. I also look at articles because they are rare diseases. Then looking at only ammonia and acidosis. So if you have, let's look at the three down these things. If you have high ammonia, normal anion gap, no metabolic acidosis, but high ammonia, we are looking at urea cycle defect. And if it is metabolic acidosis with high ammonemia, then that is organic acidemias. Approach to lactic acidosis, again few diseases, lactate pyruvate ratio to remember. You can look at PDH deficiency, respiratory chain diseases. Just look at the charts because they are difficult to remember. Okay, so how do we approach? Approach is look at the age, then the onset, the development of this child, the consanguinity, because they will tell us what age group and what diseases are common at this age. Second, also look at the progression. Is it hyperacute versus acute or chronic? Then look at the history of drugs, toxins, any animal bite or travel. Is there any bad obstetric history and what is the growth and development? And before labeling the metabolic encephalopathy, we need to rule out infection, inflammatory, stroke, psychiatry, migraine, epilepsy, and the list goes on. We have seen it in a slide before. So then the question, so evaluation of etiology comes with ruling out of these problems, and then looking at examination, we need to look at again, is there any dysmorphism, any organomegaly, any developmental delay, any failure to thrive, assessing the liver, kidney, heart, eyes, fundus. These things often guide us what we are looking at. So the evaluation includes the simple investigation like CBC, CRP, LFT, RFT. The neurological evaluation which is often done includes MRI, CSF, also take always extra samples because neurologist may have had a few tests after certain point of time, then doing a EEG. Then these are critical samples, the cortisol, thyroid function test, growth hormone, insulin, C-peptide level, and these are for metabolic diseases, the endocrine problems, whereas ABG, sugar, ketone, lactate, pyruvate, and ammonia. These are the tests if you are thinking about a metabolic disease, or then during the stress level, these two samples should be taken. Especially if you are looking at any toxic manifestations or exposure, then urine toxicology and serum drug levels also can be done. Serum drug level is difficult to do because you don't know what drug has been, unless you know the child has been exposed to which kind of drug. And for evaluation of the metabolic diseases, then you have TMS, urinary GCMS, MRI with spectroscopy, and the metabolic disease or geneticist opinion. And nowadays, what we often do, if we are not sure what we are dealing with, taking an extra sample and storing it for DNA storage is one important stage or step which you can do before giving any Paxil transfusion to this child if he has come in any crisis. So before giving any colloid, please take extra sample for the clinical exome sequencing. Okay, look at the treatment. Treatment is based, it's a multidisciplinary team approach because there are lots of people involved and lots of organs also involved. So there is a pediatrician, intensivist, a neurologist, a IEM expert, a nephrologist if you need renal replacement therapy, endocrinologist or a genetist, and the list goes on. So there are, the supportive treatment includes the ABC, then optimizing the oxygenation, carbon dioxide, the perfusion, blood pressure, optimizing pH, fluid, sugar, all those things. Fever control, again very important, which reduces your metabolic rate, and the cerebral anti-edema measures if you are looking at cerebral edema, like 3% in SCL. If there is a suspicion of even seizures, you could start anti-epileptics, controlling the irritability with this antipsychotic medicine, at least for short duration, and optimizing hydration. And the treatment of primary cause, that thing depends on basically labeling the disease. So if it is ADEM or some autoimmune, we need to start steroids, controlling BP for press, and the list goes on, like ALF, you need to treat the ALF. If it is uremic encephalopathy, treat starting with renal replacement therapy. Okay. So again, how do we manage IEM shock or any IEM suspected in crisis? Hydrating, maintaining sugar, stopping amino acid protein intake, controlling ammonia with sodium benzoate and ophenyl butyrate, Sodium benzoate is easily available and renal replacement therapy if required. If there is metabolic acidosis, starting bicarb or bicarb-based PD, and these 5 metabolic supplements, carnitine, biotin, pyridoxine, thiamine, you can click a photo of this slide because, or they are easily available on IEM articles. Okay. So having said that, let's look at some 4 or 5 common examples which we see, and you will understand how common it is. So this is 34-week baby, slightly IUGR, 1.5 was birth weight, NISTF 1 week, child was okay, no, did not have any problems, picked up to 1.8 by day 18, and this child was sent home. On day 25 comes with multiple vomitings, very irritable, very drowsy. Weight has gone to 2 kg now, so within 8 days he has picked up 2 kgs. There is mild tachycardia, the skin is dry, otherwise he looks okay. So what is this? Sepsis, the first differential in our mind, but there was no fever or anything. Is it IEM coming at this age? Is it feeding issues? He was on some medicines. Did they give some extra doses of some medicines? Is it reflux? Lots of DDs. So we admitted this baby to NICU, center routine things. And what we find out is sodium is 165. We asked the parents, how were you feeding? Now these parents were in hurry of increasing the baby's weight, and they started adding extra formula to the water, and that led to this problem. And again, we need to remember, though this was slightly acute in presentation, never correct hypernatremia aggressively. You need to remember those Nelson textbook guidelines. Do not correct hypernatremia more than 12 milliequivalents per day, otherwise you will end up with central pontine myelonosis. Okay. Another case, 20-month baby at 10 kg, normal development, came with some fever for 2-3 days, vomiting, high sugar, pH is 6.9, bicarb is 4, lactate is 6. Typically DK, right? So we start with our NS bowler, ISPAT guidelines, all those things have started. And HbA1c also sent. In the picture you can also note that lactate, by and large DK should never come with lactate, that's a rule, unless proved otherwise, unless that is septic shock. So this child had high lactate. 4 hours later the pH has dropped 6.8, GCS has dropped, lactate has gone to 10. What is this? HbA1c comes from lab, sir, sugar HbA1c is 5.5, it is bang normal. So we sent this TMS, GCMS and everything. After 5 days we get report, this is organic acidemia, propionic acidemia, and child died the same day. So remember DK, the other differential and the closest differential is organic acidemia. And this case we saw a year back. And had we not sent the sample, we had completely missed the diagnosis. Okay, another child, 4-year child, had fever, loose motions for a week back, then recovered, just treated with symptomatic medicines. He was irritable for last 2 days, 4-year, poor feeding, and now comes with not urine passed for 12 hours. He's been little drowsy for 6 to 8 hours. When we see this child, he was pale, well grown, tachycardia, no shock, GCS is 8 or 9. So what is this? The infection was almost a week back, and why is he looking pale? So typically we think of viral meningitis or post-infectious encephalopathy, edema, or any missed trauma. So labs show HB of 6, low platelets, BUN and creat which are high, sodium and potassium again deranged, peripheral smear shows cystiocytes. So this is HUS with microangiopathic hemolytic anemia with uremia coming as encephalopathy. The presentation of HUS coming as encephalopathy. Rest of the things were easy to miss by parents and even by us. Okay. Another child, 4-year, a normal vaginal delivery baby, birth weight of 3 kgs. 1 month now comes for follow-up. Weight gain has been slow, and for last 1 week he has been vomiting. Irritable for last 2 to 3 days. Child is also drowsy, cranky. Examination shows very slow weight gain. They are good from good family. Feeding was not an issue. Liver is okay. Rest of the things are also okay. So what is this? Sepsis coming at 1 month, but again, why slow weight gain? Sepsis should have come with normal weight. Are there any feeding issues? Unlikely. Reflux? Unlikely. But what comes at 1 month? Yes, CAH comes. Congenital adrenal hyperplasia. Congenital hypertrophic pyloric stenosis comes with recurrent vomitings. And is this IEM? Again, CHPs do not come with really low weight. Okay. So we ruled out sepsis, we ruled out everything else. ABG showed high lactate, low bicarb, metabolic acidosis, high lactate, ammonia, HGOTPT high, and this we sent TMS and GCMS, and that showed urea cycle defect to be managed by special diets, and this child did very well. Okay, last 1 or 2 cases. This 14-year child comes to ER with GTCS, absolutely normal till yesterday, controlled with benzodiazepines and levetiracetam, no trauma, no fever, no drug exposure, nothing. The child has been clean. On detailed inquiry, the child had 2 weeks before some URTI, nothing else. And that day also said we managed with home treatment, Aliride and paracetamol were used. Big child. So just during the examination we found the reflexes are exaggerated and the BP is high. So our first interpretation is it status which has caused this tachycardia. We control the status, again after half an hour, 1 hour the BP is still high, the child is still drowsy. We decide to do a MRI, and the MRI shows this. This is press. The BP continued to be high. We looked at, by then another 2-3 hours we got our results. The BUN was 100, creat was 6. We got our nephro on board and it showed the PSGN. The child had URTI, probably very likely streptococcal, that, just a minute. And that showed this post-streptococcal glomerulonephritis. And we just started RRT within 3 or 4 cycles, BP control, and the child went home well. Okay, last case. This was again our 1 year back case. 2-year child comes to ER extremely irritable. For last 3 years he has not stopped crying. No trauma, no poisoning, no bite, nothing. Good family, old patient. So heart rate at 180, he's non-stop crying, saturation is not allowing. So finally we put and saturation was not visible only because we are just howling in the bed. So we pricked him for ABG and the labs. Ear was okay, X-ray was okay, ECG was normal, saturation was in between coming 85, we did not know why he is coming like this. I have put another picture because this is not a 2-year child, but this is from internet. IV was secured, septic parameters were sent, we looked at UAG abdomen, we thought of sedating this child, urine, LP, we looked at scrotum, everything else we looked at, we couldn't understand what is this. The ABG showed by this time, pH of 7.48, low CO2 because he's crying, PO2, he's on oxygen, it is on 220, lactate is 2.2, but saturation is again 85. And what is this? This is methemoglobinemia. Detailed inquiry showed the parents had done their car painting 2-3 days back and they had got those sprays at home. This child was playing with that and something went in his mouth. No color, no smell, but that's what the parents later on realized, it came from that car paint. We started him on methylene blue and this child went home well after 72 hours. So the take home message, encephalopathy is acute global cerebral dysfunction, may manifest with decreased in the sensorium features or increased or heightened features. Etiologies may be multiple from infection to inflammation to stroke. Metabolic plays an important role, and not to forget, metabolic encephalopathy doesn't mean it's only IEM, there are lots of other things. Presentation always helps to pick up what is the possible etiology, and prognosis is good if we diagnose the etiology and the parents also reach to you on time, you diagnose it rightly, and then the primary disease, if it is treatable. If this was, say, hepatic encephalopathy, then it is difficult to treat unless you do transplant or reverse the liver injury. Thank you.
Thank you, Dr. Abhijit Bagre. Early recognition of liver cell failure and referral to proper center are the cornerstones in managing liver diseases. I invite Dr. Vishnu Biradar to enlighten us on this topic.
A very good morning, and thank you IIP Solapur branch for giving this opportunity. And I feel this is the branch where I started my career as a presenter, and this is the closest branch which I have in my mind. So, so the outline of my topic would be the definition, etiology, examination, the cause of mortality, goals of treatment, what is new in CRRT and the TP, which is a plasma exchange, what is the role of liver transplant, and what if it's dengue? Is it something differently managed, and what is the prognosis of acute liver failure in children? So to start with my talk, I would say the prognosis of liver transplant in last 2 decades has not changed much, in spite of having a good medical care in the ICUs, in spite of the availability of the liver transplant in Maharashtra and in nearby to the Solapur in Pune and Mumbai. But that is one thing which has changed the prognosis, and that I am going to discuss today. And this is probably is the watershed moments, because in 2024 now we have plenty of literature which is suggesting role of plasma exchange, and we will discuss that in detail. So definition of pediatric acute liver failure for a postgraduate: no evidence of known chronic liver disease with biochemical evidence of liver injury with hepatic base coagulopathy. So INR more than 1.5 with encephalopathy, INR more than 2 without encephalopathy will label as a acute liver failure. So in this category also comes a Wilson disease presenting first time with INR more than 2 without encephalopathy. So that also constitute a definition of pediatric acute liver failure. So what are the common causes in India? So as we are seeing hepatitis A virus and other viruses, particularly dengue is coming more in last 2-3 years. Drug induced we are all aware about, and first presentation of autoimmune and Wilson also acute liver failure. What are the common causes in neonate and infants? The galactosemia, tyrosinemia, hereditary fructose intolerance, fatty acid oxidation defect, mitochondrial hepatopathies, urea cycle defect, particularly citrullinemias, severe type, and bacterial or viral infection. Particularly neonate presenting with liver failure, we always rule out herpes simplex virus in the neonatal age group. And something called as HLH and neonatal hemochromatosis, which we are all aware about. So when the child with liver failure comes, what specifically to look into the physical examination? So are there any signs of raised ICT like bradycardia, hypertension and shock, evidence of any bleeding tendencies, any evidence of chronic liver disease? Look for the liver span on the daily basis. Look for neurological signs of encephalopathies or increase intracranial pressure. So we all know the early, mid and late encephalopathy, the clinical presentation and the neurological signs, and the EEG also helps in the. So what investigations to be sent in patients of acute liver failure? First and foremost is the screening and recognizing it is acute liver failure. So the prothrombin time is the most important investigation to be sent in any patients of acute hepatitis. So unless and until you send the prothrombin time, you will not recognize the child is in acute liver failure or not. And then the routine liver function test, including the albumin, GGT, the electrolytes and the sugar monitoring is the important. How do you assess the disease severity? So the blood gas and lactates. So any patients with acute liver failure, we should have a ABGA which will tell us that how much is the lactate. Like the previous talk, DK with high lactate. So it is something else. It is not something DK. So lactate helps. Serial ammonia monitoring and blood glucose monitoring. And assessing etiology, that is it a viral hepatitis, is it a toxicological screening like paracetamol or drug induced, is it Wilson, is it autoimmune, and USG abdomen with Dopplers, because sometimes in a rare situation you will get a hepatic venous thrombus presenting as acute Budd-Chiari and acute liver failure. So that patients also comes, so that investigation needs to be seen or sent. So knowing this is acute liver failure, so you want to treat them. So before treatment we should know that what is that causing the mortality. So unless and until we know that what is the reason of mortality, we are not going to improve on the outcome. So what is the cause of mortality? The cause of mortality is majority of the time in the first week it is the intracranial hypertension. So cerebral edema and raised ICP is the most common cause of mortality in acute liver failure in first week. In the second week onwards, then the infection will play and the multi-organ system failure. Bleeding is very small proportion, less than 5% or 10% of the total cause of mortality. So what are the goals of treatment now? It is a multi-organ syndrome. We should maintain the normal homeostasis and continuous monitoring, and we should prognosticate that if the child is improving, deteriorating, same on the daily routine PT-INR and the other tests. So the goals are to stabilize and ventilate this child, maintain the sugar, give antibiotic and antifungal, prevention of bleeding, reduction in the ICP. Is there any role of newer drugs? What is about plasmapheresis, CRRT, ECMO, and what about the liver transplant? So when to ventilate, we all know, we will just skip about this, that when the child is a grade 2 or grade 3 encephalopathy or the respiratory difficulty, decrease in PO2s, ARDS, we ventilate them. But ventilate electively, not when the child crashes. Antibiotics and antifungal, we all give this. So third generation of cephalosporins along with the antifungal cover, along with the gram-positive cocci cover, because we are going to put the lines, put the patient on the ventilator. So antibiotic and antifungal cover is important. How to tackle the coagulation abnormalities, the bleeding? So coagulopathy, in spite of the prothrombin time more than 3.5, 6.5, 9.5, these children don't bleed. Why? Because the procoagulant and anticoagulant ratio is maintained in them, and that is why it is not justified to give FFP even though the prothrombin time is 9, 7 or 8, unless and until we are going to proceed with some procedures. And if we don't treat with the fresh frozen plasma, then we are going to prognosticate also. So today the prothrombin time is 2.3. So we don't know what will be tomorrow. So it might be 3.5, it might be 1.5. So that will prognosticate that this child is improving or not improving, because we know that it is not going to bleed. If we are going to put the lines or some procedures, then yes. Or if your prothrombin time is more than 6.5 and you want to shift the child, or you want to know that the child is already ready for the transplant, we don't want any complication, that time the fresh frozen plasma is indicated. But rather than residing on PT and PTTK, in our unit we think we send this tag, which is thromboelastography, and that tells us what is happening to the coagulation parameter. So this R means clot activation time. Then the K and alpha angles will tell us about clot formation, fibrinogen to fibrin. The milliampere, the MA, will tell us about the clot strength. So 80% will be by the platelet and 20% by the fibrin. And this lysis at 30 minutes will tell us about the what is happening to the fibrinolysis. So if there is a problem with the clot initiation time, then we transfuse FFP. If there is a problem with the clot formation, we transfuse either a cryoprecipitate or a large volume plasma. If there is a problem with the clot strength, we transfuse the platelet. And if there is a problem in the lysis, then you have to treat with the tranexamic acid. So rather than relying on the PT and PTTK, in the liver ICU, we rely more on the TEC. So how to diagnose and manage the HE? So is the ammonia only culprit in the hepatic encephalopathy? So in the pathophysiology, the hepatic damage which is there, which fails to clear toxins, which activates the release of so many cytokines, decrease actin and scavenger, and there is role of something called as we all know about von Willebrand factor. So this large von Willebrand factor goes and obstruct the sinusoids, and that obstruction of sinusoids also leads to a liver failure and endotoxemia, macrophage activation, then endothelial dysfunction. So all this leads to the problem in the acute liver failure. So what we should be doing? Hyperammonia is leading to a brain edema, increased cerebral flow leading to a cerebral edema, and enhanced inflammatory markers also leads to a SIRS and brain edema. So we all do this, minimizing the excessive stimulation, raising the head and surveillance, and avoiding hyperthermia, hypoglycemia, all these are done. So what is next is endotracheal intubation and all these things. But Is there a role of 3% NS? Yes, there is role. We maintain between 145 to 155. Mannitol only in cases of when the child had a surge in the ICP. For the shorter duration only we use mannitol, and hyperventilation for the impending herniation. So this therapy we know. What is role of NAC and rifaximin? It is the same. The N-acetylcysteine is only in the paracetamol poisoning, is really helpful. In non-paracetamol poisoning we are using it, but knowing that the role may not be that good as in paracetamol poisoning. So I wanted to concentrate on what is new, that is the life support system. This is called as plasmapheresis, CRRT, or sometimes ECMO if there is a need. So this is the recent patient of ALF which is admitted in our liver ICU. So what this child is having, the patient is, so 30-degree ventilated, monitoring is going on. This is a newer monitor which sees cardiac output and the systemic vascular resistance and peripheral vascular resistance. And this child, this patient is already on CRRT. So continuous renal replacement therapy removes the ammonia, maintains the fluid balance, prevents them from going into the renal problem. So this is one which is almost to every patient with cerebral edema we start with CRRT. And this is second machine which is called as a spectra optia apheresis system, which is a plasmapheresis. So this is also used simultaneously. So can you see that the CRRT is also going and plasmapheresis is also going, the fluids is going, then there are warmer machines, there are the thermoregulations of the temperature, everything is going at one time to this patient. So this is how the liver ICU differs from the routine ICUs. There is one more thing about this plasmapheresis. So plasmapheresis or plasma exchange is many ways it is been done. So what plasma exchange or plasmapheresis will do? It removes the protein bound toxins, it removes the water soluble toxins, it removes the toxins like copper and something which we just discussed about, von Willebrand factors, and there are other toxins which gets removed by this plasmapheresis, and that will give a chance of liver regeneration to this patient. And this has really paved way in improving the outcome of acute liver failure, and it will also makes the child surge free, because there is a systemic inflammatory response syndrome, and if the surge goes down, the child will be stable. So our the thing is we have seen that those patients who are already on the inotropes, noradrenaline, adrenaline, sick child with INR of 7 and the ammonia of 230, once you put on the plasma exchange, the inotrope requirement goes away. So the child is absolutely off inotrope sometimes or minimal inotropes. The prothrombin time improves to 2 or 3, and if you do 3 cycles, then you know that you are given the adequate time, and meanwhile in these 3 days you can work up for the liver transplant so that the family's other points will get covered, that I will talk to you in a minute. So what I am talking about this plasmapheresis, is there any evidence what we are saying? So CRRT removes ammonia, plasma exchange removes what we have talked about. So what is the evidence of total plasma exchange currently? So in 2024 and 21, this is one first paper which came in 2021. 8 out of 16 children survived without liver transplant, almost 50% survival, which we were having the survival of only 10% or 20% in last 2 decades. Another paper of 14 patients out of 24 survived without a liver transplant, so almost 60%. And we were telling the transplant survival is 70 to 80%. So we are reaching to that survival rate. And this is about the high plasma exchange. So something which was called as initially high plasma exchange is 2 times the plasma volume, but now it is a normal standard plasma exchange, and some people have tried the low plasma exchange also, that is 0.5 times. So how do we calculate the plasma is the blood volume into 1 minus hematocrit divided by 100, and that is how we calculate the plasma volume. Is there any Indian data about this? So there is a paper which was published in 2024, just in last month, which showed almost 65 children in each arm. So this is a propensity control trial. So out of 400 children which came with acute liver failure, the 65 patients opted for plasma exchange and rest did not opted. So if we compare that, then we might get a false result. So what the paper did was the propensity match trial. So those who have not done the total plasma exchange, in that they have matched for the variables. And after matching the variables, what came out was the 50 to 60% of patients who underwent total plasma exchange, that is a green bar, native liver free survival, means liver transplant, without liver transplant these children survived. And those who have not undergone total plasma exchange, the survival is around 20 to 25%. And the same thing with the overall survival. So this probably is something which has changed the management of liver failure. And the machine which I have showed you, the difference between that machine and the other machines are, one way is to remove the plasma, that you remove the 500 ml plasma and then you transfuse 500 ml the plasma. In that, what happens is there is a fluid shifts, and we don't want fluid shifts in the liver failure. So this machine is continuously removing 20, 30, 40 ml depending what setting we will do, and the same amount of plasma will go, so there will not be a fluid shift. So this is something which is not there in many liver unit or many ICUs, and this is the only way which gives the hope for these patients of liver failure. So what if this fails? So when to think of liver transplant? Indications we all know about King's College criteria, we all know about New Wilson index. When not to do transplant is uncontrolled infection or sepsis, uncontrolled intracranial hypertension, or a macrophage activation syndrome. So what if it's dengue fever? So there is a recent paper of first pediatric living donor auxiliary liver transplant done for a dengue acute failure. So this was a 10-year-old girl presented with dengue hemorrhagic shock. After 8 days of intensive care management, the dengue hemorrhagic shock got controlled. Viremia has gone down, but the encephalopathy and the liver derangement stayed. We also had the similar case 2 years back. That child, we did the CRRT, we did the plasma exchange, 7 days she was there, and when we are going to transplant the child, because of the encephalopathy and cerebral edema, the child crashed. And this was the paper published last week only in the JPGN e-journal, which is there, Journal of Pediatric Gastroenterology and Nutrition. And this child is now 8 months post liver transplant and doing well. So even in the dengue, there are now going to be coming with the reports of having the liver transplant. So when to refer for a liver transplant center? So there is no perfect prognostic score. So I would say it all depends on the when the encephalopathy has started. So the jaundice to encephalopathy duration, if it is more than 7, then don't waste time, because these patients are unlikely to improve. Only hyperacute like jaundice to encephalopathy ratio less than 1 day or less than 7 days, they are going to get improved. If there is a increasing trend of PTINR, the coagulation parameter yesterday was 2.5, today is 3.5, again day after it is 4. So we know that this child is deteriorating. If there is an increase in bilirubin, any bilirubin more than 10, you should not waste time, because these are the patients which are likely go for a need for the liver transplant. And before transferring, please talk to us. So how to transfer, how fluid should be given, what ventilatory parameters, and everything we need to discuss on day-to-day basis or hour-to-hour basis before the transfer, during the transfer, until the child comes to the hospital. Why to refer early? Why we are insisting that all acute liver failure should be referred? What we told you about the pediatric ICU management has really geared up, but the management of acute liver failure is different in the liver ICU than in the PICU. PICU management is different and liver ICU management is different, because you require a lot of gadgets. you require optic sheath nerve diameter monitoring daily basis, you require a cerebral, the carotid flow monitoring, you require a CRRT machine, you require the plasma pheresis, you require a fluid warmers, you require a good monitor which knows about in and out of the patient, which is not there in every PICU. And the other point which is important, the last slide, the other point which is important is, so, let's say if the child is ready for a liver transplant. So child parents, if you say, they say yes, we want to do the liver transplant. So we need to find the donor. So donor blood group, matching of the donor blood group, then stage 1, the basic test, then stage 2, the cardiac assessment, respiratory assessment, psychiatric assessment, CT scan, MRI, MRCP, all this takes at least 24 hours to 36 hours. Once that is matched, then we need to approve from the government. So that takes, you require a police verification, the papers, which requires another 24 hours after the assessment is done. And after that, then there is approval from the hospital committee and the government committee. Then it requires at least 72 hours to 96 hours. So for that 96 hours, we need to be sending them early, so that by 96 hours, means if 4 or 5 days later, if the child is not improving, we should be ready with the plan that yes, this is the donor and we have the papers. If the child improves, we will not go ahead with the transplant. So that is why to refer early for acute liver failure. So prognosis, poor prognosis, mortality is high 70 to 90%, survival with natty liver is only 10 to 30%. Now this is not the case. The survival is 50 to 60% with the CRRT and the total plasma exchange, and survival with liver transplant in those who doesn't improve after giving this management is 60 to 80%. Thank you.
Thank you, Dr. Vishnu Biradar. Thank you, Chairpersons Dr. Sanjay Mehta and Dr. Sudhir Mule for presiding over this session. All please proceed for the felicitation. To chair the next session, I invite Dr. Neena Fade and Dr. M.S. Kumhare. Once upon a time, an unthinkable procedure, liver transplant today has provided hope to many. I invite Dr. Manoj Srivastav to present the state-of-the-art knowledge on liver transplant.
Okay. So, good morning everyone. First of all, thank you Pediatric Critical Care Association for giving me this opportunity to discuss pediatric liver transplants. Now transplant is much acceptable in the community as compared to what it was before. But you know, pediatric transplant is the, you can say, the most difficult part of a transplant. Doing an adult transplant is easier, but once a unit is performing pediatric transplant, I think they have done the best whatever can be done. So, slide. So this is the first slide which shows where liver transplant journey started. So liver transplant started in 1963. This was in US. The picture here is of Professor Thomas Tarzell, who started this transplant journey. For first 5 years, there was no successful transplant. First 5 to 7 transplant, all the patients died. There were some kids, but in 1967, it was the first successful liver transplant which was performed. The picture on the lower part of the slide is the picture of an operation theater, which there was so much of bleeding during the first transplant that the whole floor was wet with blood. And because it was considered as an experimental procedure, it was stopped for some duration. This is live donor transplant, which for 1967 to 1999, it was all cadaver transplant. Whatever pediatric transplant was done was from split liver, that is a liver from a adult was split into two parts and one part was utilized for the kid. But in 1999, the live donor transplant started. This was when the mother donated to the child with biliary atresia. It was done in Australia. This is the first transplant which happened in India. It was in 1997. Again, this was done in Delhi, a child from Chennai. It was a cadaveric transplant. This child has grown up and has become a doctor now. He is practicing in Chennai. So, whoever has a doubt about transplants, whether they are successful or no, these are few examples which will really tell you that transplant makes a big difference. And in fact, the maximum advantage of a transplant is in children rather than in adults. This is again one more example where we can understand how transplant can change. Now, this girl was transplanted at day of 5. So, 5-day-old girl was transplanted. This was in 1998, done by Professor Ella, where I was trained, with whom I was trained with. He is in Chennai now. This transplant was done in UK. This girl has grown up after 20 years. She had visited Chennai. She is a law student in UK. So you can see with transplant at day 5, she has still grown normally. She is a good student. She is studying law. That means she has to have an average, or you can say a good IQ level. So transplant in children means it is the best thing you can say if the patient is requiring transplant. Now, indications we all know, Dr. Vishnu has already, so the commonest indication is again biliary atresia, post-Kasai. A lot of metabolic disorders are there. And now with tumors also, with more number of cirrhosis being diagnosed and HCCs, tyrosinemias, tumor has also become one of the common indication for a transplant. One thing which I want to mention here and people should remember is hepatoblastoma. This is only one tumor where transplant is advised even in a metastatic disease. So even if you have a metastasis of a hepatoblastoma, this child can be still cured with a liver transplant. Normally you don't transplant anybody who has a metastasis, but hepatoblastoma is an exception. Again, contraindication, same thing what Dr. Vishnu has already said. Most of the time it is sepsis or increased intracranial tension and mitochondrial disease, extrahepatic malignancies. PELD score is calculated. This is usually for allocation of organs. We don't have that much robust pediatric cadaveric program. Most of our pediatric transplants are live transplants, but still for organ allocation, this is used worldwide and also for listing. It is a very simple calculation. All can calculate this score on their mobile phones. So now we come to commonest indication, biliary atresia. We all know the incidence is like 1 in 15,000, and 40% of the transplants, pediatric transplants are done for biliary atresia. All are pediatrician intensivist here, so they know that, and in literature this 3 months period is given where if you can diagnose them, you can do a Kasai and you can buy time to get them transplanted, because the progression of the disease will happen over a period of few years and then they will need transplant. Transplanting somebody at 2 months and 3 months is a very challenging task because of the sheer size of the abdomen, plus you can know the hemodynamics monitoring and everything. So Kasai, if once it is done, maximum, I'll say around 40 to 60% patients will do give you time for 2-3 years and then they will decompensate. Normal indication for a post-Kasai is always cholangitis. They'll end up into a lot of cholangitic episodes, failure to thrive, lot of sepsis, and that is the, again, for portal hypertension. And then if somebody is getting recurrent cholangitis, it will not be like what you find in adults, that they will have a lot of ascites or an encephalopathy or a hepatorenal syndrome. But they will be having a lot of septic episodes which will push them for transplant. So why post-Kasai is important? Because it is a commonest indication and these surgeries are not easy because there are a lot of adhesions due to previous surgery. There are a lot of infection issues which have happened. So the bowel is inflamed, the liver is enlarged because of bile, you can say non-drainage of bile, and also a lot of cholangitis. So this is one of the pictures which will tell you how bad the liver is and how bad the intestine is. Now when you have to operate on this patient, you need to remove this liver, separate all the adhesions. There are a lot of times where there are going to be serosal injuries. You need to trace the bowel completely from DJ flexure to terminal ileum, suture whatever serosal injuries happen. And in transplant, post-transplant bowel perforation is a very common complication. And this is because of adhesions only. So normally we say कि first 3-4 days of post-transplant survival, if it is there, normally they will not land up into serious problem. But in children, that is not the story. In children, they may perforate after 7-8 days. They may have a recurrent perforation also. So you need to be very careful about these children whenever we are transplanting them. Acute liver failure, Vishnu sir has already covered most of things. Prognostication, he has said, but again, ammonia is one of the very important factors in prognosis. Slide. So if you maintain the ammonia less than 150 and you transplant them, they will normally have a good prognosis. But if the ammonia is more than 150, then the prognosis is not that great. And again, ALF is like sitting on a time bomb. The earlier you transplant, the better. We may transplant 1 or 2 patients more who may have recovered with, you can say, conservative management. But you know, the cause of death in acute liver failure is mainly the intracranial pressure. Sepsis and all those things, they set in quite late. And most of the children will get transplanted by that time. This is King's College criteria. This is usually for allocating organs for an acute liver failure. This is very well there in literature, and almost all the guidelines go on this basis. These are few other criteria. This is mainly for Wilson's. So if you have a score of more than 11, the prognostication is high mortality. 2 things we need to again, I will add here is Wilson's disease and autoimmune hepatitis. Even if they come to you as a chronic liver disease and it is a first presentation, they can still be listed for liver transplantation. Normally you don't give an organ on emergency for a chronic liver disease, but first presentation of acute Wilson's and autoimmune disease do fulfill criteria for ALF. So it is not a contraindication, or they cannot be not be allocated organs. Transplant is not one person's job, so even surgeons maybe do the main job in the operation theatre, but there are a lot of people working around them. So even pre-transplant and post-transplant, so this is basically a list of all the people who are involved, and every unit will have this number of people to run a successful transplant program. So types of transplant, what we do is either a cadaveric or a live transplant. Live transplant is very straightforward. Because of the weight of the child, you don't need a lot of liver. Even 20% of the liver from father or mother is sufficient enough for the child. That is a left lateral segment. Auxiliary transplant is a special transplant. I'll come to that. Cadaver transplant in our country is there, but you know, split liver transplant is not that much common. We need to split the liver into 2 and give it to 2 people. It can be 2 adults or it can be 1 adult and a child. Normally, split liver transplants have been picking up now. We did one last week. Surgical challenges, again, you know, the kids are very small, so positioning them on the operation theatre is equally important. Because once you cover them with drapes, you don't know where the hand is, where the leg is, and you only have the operative field. Second thing is airway maintenance, because neck position, change of neck position will call kinking of lines, will call kinking of the tube. These children have uncuffed tubes, and this surgeries goes on for 9 to 10 hours. So these are very minimal, means you can say important points which need to be taken care of, and this can be only taken care by very experienced people. It is not a routine surgery or not a because 10 hours you need to maintain all this. Again, putting up lines in children with coagulopathy is a challenge. Now again there is a debate how many times one can be allowed, because you know how number of time you prick them and you fail to get into the line, they become coagulopathic, and even during surgery their INRs will be very high because they will be aneuphatic. So they may form hematomas. So when you finish the surgery and you take the child out, you see that there is a big swelling in the neck, there is a big swelling in the groin. So these small points, but they are very important points for a successful transplant outcome. GRWR is graft recipient weight ratio. Now this is basically coming for adults, because in adults what liver we give is usually less. When we give half a liver to the patient, if you give full liver, it doesn't make it, it's normal. But in children it is opposite. Normally children weigh 10 kgs, 5 kgs, maybe 15 kgs, and the amount of liver which you are giving a left lateral segment is around 200 to 300 grams. So there is excess liver which is given to children, and there is a problem which is called as large for size, because with a bigger liver the blood volume is small, it is not going to get perfused. So if the liver is not perfused, again you will have high enzymes, problems related to that. So the cutoff is, if your GRWR is more than 4, then we will have to reduce the graft. What is reduction? I will come to that. So this is standard reconstruction, hepatic vein reconstruction. Because earlier days hepatic vein anastomosis were a big concern because they were getting outflow obstructions. Because when you feed the liver and it will slightly move, the outflow will get kinked and it will cause secondary Budd-Chiari. So with this technique of triangulation, though that problem is taken care very well, now it is very rare to get a outflow obstruction in a pediatric transplant. Portal vein challenge is very important because all biliary atresias have atretic portal vein. So when you join the portal vein to an adult portal vein, there is a size mismatch and kink will happen. So, and the blood volume is not that. They don't have that much portal hypertension. So easily portal vein thrombosis is a very common thing, one of the second most important complication in biliary atresia or pediatric transplant. So if the portal vein size is less than 3 mm, we need to do a modulation. You can say we extend the portal vein and put an interposition graft. So normally with cadaver transplant, we harvest the vessels, iliac vessels, and we preserve those vessels and use them during these surgeries. So this is one of the pictures. It's a very complex thing. I'll go ahead with this. Again, arterial reconstruction. Children artery size is 2 mm, 1.5 mm. Reconstructing them under loops with ATO, it is a very skillful thing. Hepatic artery thrombosis per se is now become a very, I'll say, less in number, hardly less than 1% incidence we have. And in biliary anastomosis is always a hepaticojejunostomy because most common indication is biliary atresia where there is no bile ducts. You have already created a Roux loop. And in children less than 5 years, I still prefer that we should do a hepaticojejunostomy because if you do a duct to duct and when the liver will regenerate, it will kink the bile duct. And again the child may develop jaundice. With hepaticojejunostomy, that problem is not there. And second thing, the vascularity with the bowel and the bile duct is very good as compared to bile duct to bile duct. So chances of stricture from bile duct to bile duct is higher as compared to when you do a bowel anastomosis. So we prefer less than 5 years to do a hepaticojejunostomy. Now this is a problem which is faced in very small kids. You can see the abdomen of the kid, we have put in a liver. The abdomen is not, we are not able to close the abdomen. If you forcefully close the abdomen, there will be compartment syndrome. Airway pressures will go up, you will not be able to ventilate the child. So to buy time to let the edema settle down, we put a PTFE patch on the abdomen. We wait for 7 to 10 days. You can see the next pictures, the edema reduces. We are able to close some edges. Subsequently, we may able to close the whole skin. In a situation, you may leave the muscle, just close the skin, let the hernia develop. After 1 or 2 years, you can go in and correct the hernia. But if you forcefully try to close the abdomen, you will lose the graft, you will get portal vein thrombosis, you may not be able to ventilate. So these are some practical challenges which are faced in pediatric transplants. Again, PICU, we have a very standard PICU. Vishnu has already shown a picture of one of our sick patients. But in a post-transplant, what are the goals? As we said, gentle ventilation, avoid higher PEEP. Early extubation is best because children do maintain their airway nicely. And as I said, these tubes are smaller. Once they have secretions, it is very easy for it to get blocked. They are uncuffed tubes. Aspiration is very high. So earlier the extubation, better it is. Surgical prophylaxis, antibiotics, antifungals, all are there. BP, Vishnu sir only takes care about all the hemodynamics, so we don't get into that. One thing which in all transplant patients we do is do Doppler twice, because any vascular insult is going to lead to graft loss and finally mortality for the child. So in pediatrics, we do 2 days Doppler every day for 5 days, and subsequently as and when required. Immunosuppression is very standard. Methylprednisolone is to start with, tacrolimus is added. TAC is maintained around 7 to 10. And if there is altered sensorium, which is very rare to happen after the transplant is done, you may have to do a imaging, see ammonia, and if required, you need to support them with CRRT, particularly if they are with acute liver failure. Most important complication, as I said, perforation, need to be careful for first 7 to 10 days. This is one of the commonest problem post-transplant. Diaphragmatic nerve palsy. This is one thing which not many people know about this, because whenever you are transplanting, you are clamping the cava completely. There is a complete cross clamp. The phrenic nerve travels through the diaphragm near the cava, and there is injury to the phrenic nerve. So you may try to extubate the child, but there is diaphragmatic palsy. So your extubation may fail, or there may be a child who is getting recurrent intubation. So one of the reasons, we may all be looking into lung, but the problem is in the diaphragm. So this has also happened. We also had a child who was almost for 20 days on a ventilator, and subsequently we had to go in and plicate the diaphragm, and then the child was extubated. Techniques for OLT, as we said, is orthotopic, auxiliary transplant, monosegment, split. These are for smaller children. Auxiliary is mainly indicated in acute liver failure or where you have the etiology which can be reversed. Now the benefit with auxiliary transplant is you can come off immunosuppression. So this is a picture which shows a right lobe auxiliary transplant and the lower down is a left lobe. So we are giving the new liver to the child only to buy time so that the old liver regenerates. Once the old liver grows, we will withdraw the immunosuppression, the graft can be taken off or it will atrophy. Now this is one example you can see. The first picture shows the native liver is small and the graft is big. So over few months you can see the native liver regenerates, and the last slide you can see the right lobe has become bigger and the left lobe is almost shrunken. At this stage you can withdraw the immunosuppression. The graft can be taken out or it will undergo autohepatectomy. Monosegment grafts are usually for smaller children, less than 5 kg. Abdominal cavity is very small. So this is how segment 2 and 3 are divided. So normally segment 3 is taken off. You can see the marking done on the top slide and lower down the reperfusion. So only single segment is given to the child. And as they grow, this liver will grow and it will be sufficient. It is not that it will be less to the child. It will be sufficient even it grows to an adult state. Split liver is again slightly complicated anatomy, but normally for a children, left lateral is sufficient. If there are two adults, one like 60-70 kgs and one is like 40-50 kgs, you can split it into right and left lobe. But normally for children, left lateral is sufficient. This is one of the examples where we had done a split transplant. It was given to 2 kids, both did well. So our team as till date has done around 44 pediatric transplants. So cadaverics are 3, 2 splits, 1 live donor auxiliary transplant, 3-year survival is almost 88 to 90%. These are the various indications for transplant, biliary atresia being the commonest indication. Same thing, and difficulties encountered with recently is one is intraoperative cardiac events. These two happens, and in children we need to be very careful, particularly if they have an atrial septal defect. So if somebody in pediatric, again in biliary atresia, they do have all these malformations. Air embolism is a very common thing. You may suddenly find an asystole in the child. So need to be careful about this. Extubation failures, as I said, because of pulses. Post-transplant hemolysis we have seen in one child in acute liver failure. We really don't know what was the cause for this hemolysis, but plasma exchange is again a therapy for this, and rituximab is a drug which can be used, but again it is very costly. Severe HPS, we done one child. Unfortunately, we lost this child because the HPS worsened. Normally, HPS is supposed to reverse after that, but it takes around 6 weeks time. The thing which we did not do here is we did not have an ECMO as a backup. If we could have kept ECMO as a backup, I think we could have saved this child. And again, sepsis is the commonest problem with all transplants. So, taking them to transplant sepsis free is the key. And early extubation, early delining, early enteral nutrition. This is video of one of the child which we had transplanted. Now this is the, you can play the. So just 1 minute more. So this child was a pediatric transplant, biliary atresia, Kasai done at age of 2 months. She survived post-Kasai for 8 years. After 8 years, she started developing cholangitis, so she was listed for a transplant. Now she has received a full liver. A 10-year-old child was brain dead, where parents willingly donated. Now this is one of the child only in the state which has got a full liver. Normally in children, you need to give a part of the liver because of the space constraint, but the size for this girl and that donor matched. So we put in a full liver for her. This is again an acute liver failure, came to us as viral hepatitis, managed but INR not improving. Finally we went ahead and transplanted, he was discharged. This is again Bud Chiari, at present at 1 year of age. Left vein was stented because that was patent, middle and right was not there. But after 2 years she started developing refractory ascites. Father donated, we went ahead and did a transplant. She also doing very well. These are few of the kids which we have transplanted. We have almost all indications, but maximum again is biliary atresia. Thank you.
Thank you, Dr. Manoj Srivastav. Optimal fluids are the key to smooth recovery. This is not as simple as it seems in the PICU. To deliver his talk on fluids in critically ill child, I invite Dr. Sheikh Minaj Ahmed.
Morning, friends. Me again. From complex back to basics. And the basics are fluids. And one must understand fluid is life. Whether inside the body or on earth. Earth is 2/3 or 3/4 of fluid. So the body. And fluid has to be fluid therapy not only in ICU but in everywhere, whether it is ER, ward and ICU is very important. Concepts are very important, and before I go into the details, what's most important in ICU nowadays, less is more. So what has gone inside cannot come up, so we have to be careful how much we give inside, right? Okay, so with this preamble we start. Fluids critically in child. This is my pet topic, so I will try to as possible as. So what are the indications of fluid therapy? We know it's resuscitation, replacement and maintenance. There are three major indications: replacement, resuscitation, replacement and maintenance. And for what? To normalize hemodynamic instability, to return to ICF to normal. This is very important. We tend to start the fluid maintenance, we volume resuscitate, but we often tend to not to give the ongoing losses. So I always say to my patients or my residents, what is debit has to be credited. It's very simple. जितना ऊपर से नीचे से गया उतना मुंह से देने की कोशिश करो, whatever. So what is debited has to be credited with regard to replacement, ongoing losses, and provide glucose to brain, dextrose, and maintains the insensible loss. Okay, so this is what I've talked about. What are the indications of fluid therapy? Resuscitation phase covers deficit in restoring volume. Ongoing phase, sodium, potassium and all. Maintenance covers need of body, electrolytes and glucose, and fluid creep. We'll talk about fluid creep. What is this fluid creep? Okay, so why we need fluids? The fluids are required, at the end of the day, the fluids are required to sustain life, to deliver substrates. And what is the substrates? Two important substrates: oxygen and glucose. Because we have to see from the cell point of view, cell, tissue, organ and the human being. So this is what the fluid is required. And then don't overlook the basics. Basics are basic, independent of whether I am in a general ICU or any ICU, or for that matter ward. So we have to understand, as I said in the beginning, fluid is life. Okay, हर जगह water को लेके लड़ाई झगड़ा होता है. The same in the here. So total body fluid is 60%. When the child grown up, total body fluid is 60% of the body weight. And simple to remember the rule of 2/3, 1/3. 2/3 is intracellular, 1/3 is extracellular, right? This is basics. And of the 2/3, of the 1/3 of the extracellular fluid, interstitial fluid is 15%, that 3/4, and intravascular is 5%. Understanding intravascular fluid is very important, because whatever fluid we give, it goes to begin with intravascular. So volume resuscitation, preload optimization is in the intravascular, then it goes in the other way. So this is very important, knowing the intravascular compartment is only up to 5 to 8%. So this is the basics of body fluid composition. Having said that, before we go beyond, we must understand what is osmolality and tonicity. We often tend to interchange, but we must understand the basics of this. And what are the clinical implications? Clinical implications are many. So what are those things are there? So what is plasma osmolality or osmolarity? We must understand the body plasma osmolarity is 275 to 295. Some may get to 305, but generally speaking, 275 to 295. And what is osmolality is number of osmoles, or otherwise solutes or particle dissolved in plasma. This is simple osmolarity. Then you can say osmolality or osmolarity. So what is osmolality? Is milliosmoles per kg of plasma. Here per kg of plasma is osmolality, and we say osmolarity, it is osmoles per liter of the plasma, right? And how do we calculate it? We calculate by 2 into sodium. So remember, sodium is life. Remember, sodium, potassium, ATPase pump on the cell. So 3 sodium, 2 potassium. That's the life. If this ATPase sodium potassium pump goes, life is on the verge of go. So that is the basic of the entire sodium potassium complex. So sodium is important. Then you have glucose and burn. The role of glucose is also important with regard to osmolarity and understanding tonicity. We'll see how it has been there later on. So let us understand osmolality and calculation of, remember this 2 sodium. Why it is important? I will give simple example. When I say enormous line, 154 per milliequivalent. 154 into 2 is how much? Around 308. So that is what is, you have to have the osmolality, tonicity to, close to your plasma. While, what is tonicity? Tonicity is effective osmolality. So tonicity is not osmolarity. Tonicity is effective osmolality, which actually causes the osmotic gradients. So you have to have the osmotic gradient between the intracellular and extracellular compartment. So based on the tonicity, the gradient changes. And the determinant of this is sodium. Remember, sodium is very important. Okay? So 2 sodium. Understood? So this is osmolality and tonicity. Well, so why tonicity is important? Because it is responsible for movement of water across the cell membrane. As I said, sodium, potassium, ATPase pump on the cell membrane. So across the cell membrane, under this osmotic gradient, the fluid shift takes place. So if you have hypotonicity, that means ECF, the fluid will go from ECF to ICF. So all body tissue is vulnerable for expansion. Whether it is heart, brain, kidney or liver, whatever. But we are more worried about the brain because there is not much space for expansion. Other places we have space for expansion. So this, if you have hypotonic fluid, ECF will go to ICF and will have brain edema. So this is the concept of having a no hypotonic fluid, which will come subsequently. Okay. And then if you have hypotonicity, ICF to ECF, so fluid will come from ICF to ECF. Remember one thing, wherever there is salt, the fluid will go. It is like relationship with the lady with the lamb. Okay? जहाँ पे lady जाएगा, वहाँ lamb जाएगा, जहाँ sodium ज़्यादा रहेगा, वहाँ पानी जाएगा. So it is the osmotic gradient. So lady with the lamb, that is the relationship with the salt and sodium. Okay, understanding this is very important. Why? We have to understand tonicity in free water. As the tonicity increases, free water decreases. So you remember 5% you have the osmolarity but no tonicity. So tonicity and osmolarity are two different things. So because there is a free water, it does not have the sodium. So you have to understand you have 5%, 0.22 yes, all those things, 3%. As the tonicity increases, free water decreases. Okay. So brain is the worried point because there is less space for expansion to the brain. Fine. So this is the comparison of commonly used osmolarity. This concept is important. Remember hypotonic fluids. Avoid these fluids, especially in the brain ICU or neurocritical care. Avoid these fluids. And these isotonic fluid, ringer, plasma, and all these things. And then you have hypotonic 3% saline. Okay. And a word about all this composition, which is with their sodium chloride and all those things. So free water, see the free water 100% over there. DNS free water is how much? 100%. So we are giving the water, but it is osmolarity free water, no sodium. Fine. Coming back to fluids, very important. Which fluid, why, when, how much, duration, should I give rapid, should I give slow, when to give rapid, when to give slow, all these questions, case to case basis. In that particular case, time to time basis. It's not I customize the fluid now and we'll see in the tomorrow. No, it has to be on the regular basis. So what are the principles of fluid therapy and management, right? So these are the principles. What are the concepts of fluid management critical ill child? These are the which has now come in. What is called as 4D. D stands for drug, dose, duration, and de-escalation. This is fluid stewardship. As we have antimicrobial stewardship, we have a fluid stewardship. Fine. Then 4 phases of fluid, you must understand, this is called as ROSE concept. Resuscitation phase, optimization phase, stabilization phase, and evacuations. So 4 Ds and ROSE, this is the recent concept which we have to take into account. So what is all about? So drugs, fluid has to be treated as drug, like we do for antibiotics and all. Doses are not defined. You have to customize based on what happens during this phase. So what happens, this is ROSE, where we give where we give early adequate fluid management. So you may give little bit extra because you want to optimize. Patient may be in hypotensive shock or patient may be in non-hypotensive shock. So you have to optimize the preload. So you give the fluid and you bring it there. You make a little bit more over there. Accept it because you are in the process of acute care. Then you have the optimization phase, and the next is your late conservative fluid. So once your child is stabilized, then go slow. Go what child needs, what I don't need. So go by the child, and very important is evacuation. Important thing is that if your kidneys are normal, fluid will come out. But if the kidneys are not normal, you have to do intervention. Either the diuresis or renal replacement therapy based on the degree of fluid in and your clinical status. As I was talking about last presentation, the plasma exchange, Birada. So plasma exchange, one indications of fluid in your liver failure. So these are the aims for resuscitation phase, aim to fluid treatment, resuscitation and correction of the shock, optimization to administer according to individual needs, time to time, not in that particular point, stabilization and evacuation. Evacuation is very important. So this is what the goal of ROSE. The resuscitation, you may have positive fluid balance, the neutral fluid balance, the negative fluid balance, and then you have to negative fluid balance. At the end of the day, one concept which is very important, which I always take into account, above diaphragm, heart, less fluid, below diaphragm, kidney, more fluid. So this is what is the way I think about, but you have to customize based on your need. Okay, now the practicality. So fluid in septic shock, how do you customize? So let's have a case, a 2-year-old boy, 10 kg, has had fever, loose motion for 3 days and altered sensorium 2 hours. His last weight have been 10.6. Always try to have age appropriate 58th centile blood pressure. We have the formula. So 58th and 5th, usually we say 5th centile. So this child has been drowsy, tachypneic, tachycardic, hypotensive with all signs of septic shock. So what is the initial assessment of this child? He is in hypovolemic shock, hypotensive septic shock. So what all we do? So what is important is that not all the child will present with hypotension. You have to treat the child, identify the child in what is called as normotensive shock. So don't allow the child to go into hypotensive shock. Hypotensive means kafi aage badh gayi bas. So we have to, that hypotension is late event, not early event. Okay, so at 5 to 15 minutes, what are the things that required to be done? IV access, 100% oxygen, give oxygen, it's very important. Collect samples for all those things and give first dose of antibiotic as appropriate and fluid. Now what fluid which you have to give on what bolus? So these are the few questions. What fluid would like to give? 0.9 saline, Ringer, DNS. So what important thing is you only give first 2 as a boluses. No bolus beyond 0.9% the Ringer lactate as so far as crystalloid is concerned. I'm not about colloid, crystalloid. So these are the things, never all those things because it causes free water. So there is no, it will space out. Okay. So fluid boluses, rational. The type of fluid, how much to be given, how rapid, how slow, and how many boluses. So in this particular case, you can give crystalloid or colloid, 0.9 normalized and Ringer lactate and or Ringer lactate. You can give 10 to 20 ml per kg. People say 20 ml per kg, but the recent guidelines, if you read, it says 10 to 20 ml per kg. I said in the beginning, less is more. What has gone inside will not come out. So you can go slow and go about. So 5 to 10 minutes for 20 the maximum. And once you reach 40 to 60 ml per kg, then you can start early introduction of vasopressors. You can use noradrenaline. People are using adrenaline. My choice, cardiac ICU, adrenaline, non-cardiac ICU, noradrenaline. It is up to you. That is what? Okay. So should we bolus or not? Yes, in this case we have to bolus. And how much bolus is very important. So this is important trial which has come up to 2012, which is called as FEAST trial. Mortality after fluid bolus in African children with severe infection. Not like that, but close to our population that has been there. In this particular trial, the recruitment was the patients who were like malaria and anemia, and they received no bolus versus albumin bolus. So the importance of this particular trial is you have to give less fluid. Less is better. They have given the more fluid and higher chances of mortality and morbidity. So this FEAST trial has changed our practice. Earlier we used to give 20 ml, 20 ml, 20 ml, no. Unless the patient is in shock, give 10 ml, bring to lows, and early introduction of your vasopressors. Okay, so you have to be careful with regard to, so what
what fluid you have to give. Normal saline, ringer lactate. So these are the composition. pH of normal saline is 6 as normal saline is 4.5 to 7. What's important is over here is have a look on your osmolarity and sodium. Ringer lactate 130, normal saline 154, and lactate 28, no lactate, and potassium. So people are worried about the potassium and the lactate. So why? Because suppose the child is having some acute kidney injury. So people are worried that 4 milligram potassium se gadbad to nahi hone wala. No. In resuscitation phase, you can give ringer lactate, which will take care. Subsequently, you can handle your potassium. So there is no problem in giving the ringer lactate as volume resuscitation, even in cases who have risk injury of your acute kidney injury. Okay. So normal saline, the problems are, it may cause, high doses may cause hyperchloremic metabolic acidosis, can cause afferent renal vasoconstriction, may induce acute kidney injury, can cause hyperkalemia, dilutional coagulopathy. And what are the, I won't say contraindication, but you have to be careful when you give ringer lactate when a liver failure, excessive vomiting, and severe renal disease. Having said that, there is no head-to-head, what is better, you can give either subject to availability and affordability. Okay, so why do we prefer either of these? Is because it is economical, easily available, and osmolarity is close to what is prescribed. So what is normal about normal saline? Anybody? So nothing is normal about normal saline. This is what has been the paper which is said normal saline is neither normal nor physiological. Okay, why? Because the sodium is 154, our plasma is 130 to 145. Chloride is 154, it is 95. So as we said, excess of normal saline may cause hyperchloremic metabolic acidosis. And osmolarity, the osmolarity normal saline, as I said, 154 into 2, 308, here it is 275. So nothing is normal in normal saline, physiologically. So, however, we give normal bolus, it can cause hyperchloremic metabolic acidosis and your strong iron is 0, reduction in hemoglobin concentration, and as I said, renal afferent vasoconstrictions. This is all about normal saline. So, nothing is normal in normal saline. However, the important part is that it does not affect the cellular volume and cellular integrity. Okay, so fluid boluses, this is important. This has come about the recent sepsis guideline that if you have no ICU, compensated shock, no fluid. If you have ICU facilities, 10 to 20 ml per kg. Hypertensive, you have to bring hypertensive normotensive, so you can give the fluid boluses in either facility. And total fluid balance, we have to have 40 to 60 ml per kg. Once you have this, then consider giving the early inotropes. So this is another important. When we give volume resuscitation, over time, the fluid, fluid response decreases. So it is your luck at what point of time the patient has come to us. If the patient is coming early, you are giving early volume resuscitation, fluid responsiveness has been there. As the patient is going late, probably your patient is not responding. So you have to, early resuscitation. So while giving fluid, what all things you have to give, this is therapeutic endpoints of volume resuscitation. You have to have CFT less than 2 seconds, normal pulses, warm extremities. Important urine output. Urine output is a very good marker for perfusion pressure overall the body. So urine output around 0.8 to 1 ml per kg per hour, normal mentation, lactate normalizing, and if you have facility, SCO2 and cardiac impulse going for normalization. So how we can understand fluid overload? This is important, what I have said. So before we talk about overload, volume depletion, which can have postural hypertension, tachycardia, absence of GVP, all these things in the volume depletion, and what is there in the signs of volume overload, pulmonary edema, worsening distress, enlarged liver, increase. So all these things have to be taken into account when you give the fluid therapy, especially volume resuscitation. Okay, so this practically all organ can affect it because of the excess volume. So these are there is respiratory, pulmonary edema, pleural effusion, hepatic congestion, gut edema, cerebral edema, all body parts are affected because of volume. So you don't want anything which is more than 4 to 8% total fluid body, your positive fluid balance. So you have to have, as you look at credit debit balance of your money, the same thing have to be looked at in your fluid with regard to fluid therapy, either in the ward or in the ICU. Okay, so fluid overload have to be looked at, and then what is to be done is that we have to have, this is what is restrictive approach where you have increased hypovolemia, organ dysfunction, impaired oxygen delivery, and if you have liberal approach, increased risk of fluid overload, hypervolemia, organ dysfunction, impaired oxygen delivery. So what is required is this. So optimizing fluid, that you have to be around over here, not too much, not too less.
So I stop over here because there's too many things. With this, my message is that one important thing is when we use no hypotonic fluid. So isolate P, no hypotonic fluid. In fact, the NHS in around 2007 said we should not use hypotonic fluid for fluid therapy. This 0.18 Baxter has been banned. Okay, so the philosophy, the fluid of hypotonic and hypotonic, what is fluid creep? I will miss all those things. So the key message is the philosophy of fluid therapy is run them a little sweet and little dry. As I said, upper diaphragm and below diaphragm. It took them a while to go this away. It's okay if it takes them while it to get better. And this is what are the key messages. Follow 4 Ds of fluid therapy. Isotonic fluid, no more hypotonic fluid. Balanced fluid, still under consideration. Hypotonic fluid, no longer recommendation. I am done. Do not forget about extra fluid, fluid creep, and post-session fluid overload to be taken care of. So this we have to have a maintained balance, not only in the fluid, but in the ICU, in our life as well. Thank you. These are my acknowledgement, Dr. Boucher, Dr. Uma Ali Madam, and the place which I have been trained at Gangaram. Acknowledgement to all those things. Thanks for the patience hearing.
Thank you, Dr. Sheikh Minaj Ahmed. At all times, an intensivist must be rational in management of sick children, especially while choosing the blood products. I invite Dr. Sara Dhanwade to throw light on this topic.
Good morning. Again, we are going to do another very basic topic, which is useful for generalists as well as for the specialists. Just like we are talking about stewardship programs, we have antibiotic stewardship now, diagnosis stewardship now, fluid stewardship. We need to have even transfusion stewardship in our practice. So as we know that there is a growing recognition about the adverse events regarding blood transfusions and the need to practice safe transfusion guidelines. We see anemia in more than 50% of the children at some point or other in PICU will develop anemia. And there is also a clear association of anemia with mortality. Transfusions, however, remains the fastest way to increase the oxygen content in a patient with severe anemia, but they are not that safe and benign. So we need to always weigh the risk, benefit, and alternatives, and also I will add one more thing, cost effectiveness when we think about transfusion. So the blood transfusions have come a long way over the centuries, I must say, and they have made several advancements to its safety. However, it is not completely safe. We don't see transfusion-transmitted infectious diseases these days. That has become a thing of the past, but we now worry more about NISHOT, which stands for non-infectious serious hazards of transfusion. And most of us sitting here at some point or the other might have come across this, TRALI, TACO, TRIM. It can be either an early reaction or late. Early we call within 24 hours, delayed when it happens after 24 hours. Delayed are like graft versus host reaction. Then we see the hemolytic and non-hemolytic transfusion reactions. So they are not that simple. So let's go through a couple of cases. This is an 8-year-old boy ventilated for acute encephalitis syndrome on 2 vasopressors with increasing dose. Blood pressure is still 88/60. Hemoglobin is 7 gram. So your resident is calling and asking, should we arrange for Paxil transfusion? So how many of you will transfuse this child? My question is, will you benefit from Paxil transfusions and what are the indications? Case 2 is a 10-month-old girl weighing only 6.4 kg, mild respiratory distress, O2 by mask, heart rate 160, BP 94/60, CRT less than 3 seconds. She has severe pallor, bilateral crepes, liver 3 centimeter, hemoglobin 6, PS showing hypomicro. Does she require transfusion? Will most of you transfuse this child? So this is a malnourished child with severe iron deficiency anemia, not in failure, hemodynamically stable. Will you transfuse? The previous child was not hemodynamically stable. So what is the optimal transfusion threshold? Is it on a clinical scenario or is it just a hemoglobin number? And is it safe to give less blood? We have been hearing from yesterday in intensive care practice now, less is more. The same is true even with blood transfusions. So this is a landmark study, the last answer to the last question. This is the landmark study which was published in 2007. This is called the TRIPICU study. Even before the TRIPICU study, in adult the study, the TRIC trial was in 1999. So that is way back when they first proved that the restrictive transfusions are as effective, if not superior, than liberal transfusions. Then came the landmark study in non-pediatric patients. Here they have included neonatal age group up to 14 days. So this was a multicenter trial. You can see what happens. There are two arms. One was in the restrictive group, the other was in the liberal. Restrictive was hemoglobin threshold of 7 and liberal is 9.5. And you can see about only 54% in the restrictive group did not receive any blood transfusion, whereas only 2% in the liberal group did not receive transfusion. And when it came to mods and death, it was equal. There was no difference in the two groups. So what did the study? This was a non-inferiority trial. What did it conclude? It concluded that the hemoglobin threshold of 7 significantly reduced to nearly half of the transfusion in stable, the word is stable. They have taken only stable critically ill children without increasing any adverse events. Despite this evidence that the restricted transfusions are good, the surveys and studies show that in practice we use much higher threshold. So even the pediatric intensivists have only partly adopted this threshold of 7. So this is another study which is, they have come with, this is the Transfusion and Anemia Expertise Initiative Consensus Conference Guidelines, which was published in PCCM in 2018. They have come with guidelines even for critically ill children who are hemodynamically stable and not hemodynamically stable. Some of the good practice, there are two good practice statements in these guidelines. One is while deciding to transfuse a critically ill child, it's not just the hemoglobin, but you need to take into context the overall clinical content, that is the symptoms, signs, physiological markers, and lab results. The second good statement is that measuring hemoglobin concentration is preferable and recommended before prescribing RBC transfusion, but knowledge of hemoglobin level is not required prior to transfusion whenever there is life-threatening bleeding. These are some strong recommendations from the guidelines. Post-transfusion hemoglobin, the goal should be to relieve the indications of transfusion and not to reach any kind of normal hemoglobin level for the age. A reasonable target would be to reach up to 7 to 9.5 gram per deciliter. In non-hemorrhagic shock, consider all possible strategies to augment oxygen delivery and decrease oxygen demand and not just PRBC transfusion. In respiratory failure, do not transfuse if the hemoglobin is at or around 7 gram if there is no acute hypoxia, no cyanotic condition, or any underlying hemolytic anemia in a hemodynamically stable child. In sickle cell disease, the aim is generally to achieve a target of 10 gram rather than say hemoglobin S of less than 30% prior to surgery requiring general anesthesia. However, no such recommendation for surgeries requiring local anesthesias. In congenital and acquired heart disease, optimize all components contributing to oxygen delivery before initiating transfusion. And this is very important. Adoption of blood sparing guidelines should be implemented whenever possible. So this is how the taxi decision tree looks like. It's very crowded. I have split it up in the next slides for your easy viewing. So the taxi guidelines start like a critically ill children into two groups, whether they have hemorrhagic shock or whether there is no hemorrhagic shock. So whenever there is hemorrhagic shock, you need to transfuse RBC plasma platelet in the ratio of 2:1:1 to 1:1:1 until the bleeding, until there is no longer bleeding. So whenever there is a no hemorrhagic shock and the hemoglobin is less than 5, the guideline says always transfuse. But between hemoglobin 5 to 7, the guideline does not say always transfuse. They say use your clinical judgment. And when there is hemoglobin in a non-hemorrhagic shock more than 7, and if the child is not hemodynamically stable, again you use your clinical judgment whether it's to transfuse or not to transfuse. But this is important. When the hemoglobin threshold is 7 grams, child is hemodynamically stable when you don't transfuse. In these situations, you do not transfuse. That means general critical illness, post-operative patients, respiratory failure except in severe ARDS, sepsis or recent septic shock who is hemodynamically stable, non-life-threatening bleeding, and those requiring RRT. There is no need to transfuse. I think many of us do transfuse in such indications. I'm sure it is being done, so this is something which we need to take care of, how to avoid unnecessary transfusions. Then when hemoglobin is more than 7 and hemodynamically stable, there are some indications where you need to transfuse. One is acute brain injury. Acute brain injury, hemoglobin threshold 7, hemodynamically stable, you will still consider transfusion. Then oncologic disease and those those undergoing stem cell transplant, you will transfuse. And in hemolytic anemias, severe ARDS, those with ECMO, you always have to use your clinical judgment. So there are some special guidelines TAXI has given for the heart disease category, where the hemoglobin is at the threshold of 7. In uncorrected congenital heart disease, you transfuse to maintain a hemoglobin of between 7 to 9, depending on their cardiac reserve. When they undergo biventricular repair, there is no transfusion required if the hemoglobin is 7. Single ventricle stage 1 palliation, no transfusion if the hemoglobin is at 9, and adequate oxygenation is maintained. Single ventricle stage 2 or 3 palliation, no transfusion if your hemoglobin is 9. Congenital and acquired myocardial dysfunction and pulmonary hypertension, it is written use clinical judgment. There is no evidence to say that transfusion would be beneficial at hemoglobin levels above 10. So generally, even in cardiac conditions, if you say they're coming to around 9 or, other than going up to 10 and beyond. So you think this 7 is really a magic number? Yeah, it looks like that. 7 seems to be a cutoff limit now for the patients. So there are only very few indications to transfuse when the hemoglobin is more than 7. That is, one is the patient is hemodynamically stable. That means even in a septic shock, if the child is maintained on low dose of inotrope, you need not rush and give blood. So you can always wait, but if there is increasing requirement of inotropes, you can always decide about transfusing. Like the first child of ours, on the encephalitis child on ventilator who had escalation on his inotropes would preferably benefit from Paxil transfusion. Respiratory failure, again, the criteria very clearly says that only if there is acute hypoxia, underlying cyanosis, or there is chronic cyanosis or chronic hemolytic anemia or cyanotic conditions. Acute brain injury, remember, is one condition where you'd like to see your hemoglobin up. Uncorrected heart disease, because they may not tolerate anemia. So we need to take care of the anemia. Oncologic disease and transplant, and then of course hemolytic anemias, especially with sickle cell and acute chest anemia. So what are the types of blood used? The standard blood we use is the citrated blood, which has a shelf life of 42 days. We get leukocyte reduced ones that decreases cytokines and WBCs, and it decreases the transmission like that of CMV. Then saline wash, which we normally use in our thalassaemic patients, which removes plasma and increases hematocrit. We also have irradiated, which is costly. It kills the WBCs, decreases the GVHD. But there are two disadvantages of irradiated blood. It can damage RBCs and cause increased free hemoglobin and potassium and increase the storage lesion. Always RBCs have something, when we give the RBCs, stored RBCs, there is something like storage lesions, which can cause the adverse effects in blood transfusion. And the shelf life of irradiated blood is also not 42 days, it is only 28 days. So does the age of the blood has any impact on the outcome? There is again 2 trials. This is the ABLE trial, which was done in adults published in New English NEGM in 2015. They showed no difference in the outcome. Fresh means, which is less than 7 days or less, versus standard blood. The ABC PISU study, also the recent study which is published, they have also found that there is no difference between fresh or the age of the blood. So to summarize the guidelines, transfuse when hemoglobin is less than 5 gram in all circumstances. When hemoglobin is between 5 to 7, use your clinical judgment. And there are only few indications to transfuse when the hemoglobin is 7 and above in a stable, critically ill children. More attention should be paid to NISHOT, and always choose wisely and stick to restrictive transfusion policy. Thank you. I finished well in time, before time. It was short and sweet. It was.
Thank you, Dr. Sara Dhanavade. Now I request Dr. Hiren Panwala to proceed for his next lecture. His topic is neuroimaging in PICU settings.
Good morning all, and thank you organizer for allowing me to talk on this topic. So next 20 or I can take 5 minutes more because madam has taken less time, so I can take that liberty to take 5 minutes more. So it will be more case-based, it will be more interactive. I don't want that monologue from my side. So what we'll do, I'll be showing the images and some brief clinical history, and we can go about what you should think in that kind of scenario. Right, so I'll be showing some cases in which the child might require the PICU admission, and as a PICU intensivist, you should be able to identify those kind of red flags that requires immediate treatment, right? So these are the available tools when we are dealing with pediatric neuroimaging. It leads from MRI brain, CT brain, X-ray skull, neurosonogram, but the gold standard or the most frequently used in the pediatric setup is the MRI brain, and we should encourage the usage of MRI brain in all settings. Now the CT brain has very limited role after immediate post-op, or you want to see for any calcification, or the patient comes with acute trauma and you want to take immediate decision. In those kind of scenario only we are doing CT scan, otherwise everything has been replaced by doing MRI brain. So this is one of the take-home message from the today's session, that whenever you have a facility of MRI and MRI is possible, please go ahead with the MRI, especially in pediatric setting in which the brain is immature, brain is not better myelinated less than 2 years. So your CT is going to give you very false imaging, very false finding. So always go for MRI whenever possible. So by that I would like to start with the cases. Here is a 5-year-old child who had come with the fever and acute onset neurological deficit and encephalopathy. So these are the T2 weighted axial images, and like anybody can want to say where is the abnormality, you can use this mic and probable thoughts with this kind of clinical scenario. So exactly. So what you are seeing here, that the left side is anteromedial temporal lobe that shows swelling hyperintensity. That is also extending into the insula on the left side, and I can see that from the crowd they are mentioning about some sort of viral infection like HSV. Yeah, so basically there are certain viruses which has got this kind of cortical and temporal lobe predilection, in which the HSV is one of the common one which can affect this area. So whenever you see this kind of acute scenario with fever and neurological deficit with encephalopathy, you should think of HSV kind of viral encephalitis. One more thing, when we are dealing with the MRI brain, when you are telling your radiologist to do MRI brain, when you are suspecting infection, please always tell that please do flare post-contrast also, because flare post-contrast is better pickup of meningeal enhancement. The leptomeningitis are better seen on flare post-contrast images as compared to the routine T1 post-contrast images. So whenever you are looking for subtle infection or signs of infection which can be missed on routine imaging, please mention specifically that use flare post-contrast images for the better pickup of the leptomeningitis. So here this is the flare post-contrast images, and you can see this kind of sulcal enhancement in the occipital areas. So that is indicative of leptomeningitis in that case only, in that HSV case only. Somebody can say that swelling can be due to acute stroke or something. So we have got one sequence called SWI. SWI is the susceptibility weighted images. So that usefulness of that sequence is you can detect hemorrhage. One thing, you can detect any minerals like copper and any other iron, those kind of paramagnetic substance can be picked up on this sequence. It's a very useful sequence, and your surface vessels also better depicted on the SWI images. It's a non-contrast sequence, better to pick up the calcification, iron, copper, and those kind of paramagnetic substance. So if it was stroke, then we could have appreciated that the vessels overlying that area would have reduced in size. If it was arterial stroke, but here we are seeing that even the vessels are increased. That means that a lot of inflammation going into that area. That rules out relatively that this is not looking like ischemic stroke. This looks like more of an inflammatory swelling. This is the DWI counterpart ADC image. So when you see dark signal on ADC, that indicates that that area is showing some sort of restricted diffusion. So that means that area is showing cytotoxic edema, which can be seen in many cases of viral encephalitis, can be seen in herpes also, and can be seen in ischemic stroke also. So always consider all these sequences when you are dealing with the MRI scan. So just coming back to the case, yes, it was viral encephalitis, and on workup it came out to be HSV positive. So just wanted to give you some differentials. So HSV has got more of a cortical and gray matter pattern, and they can sometimes show hemorrhage in the surrounding brain parenchyma. So this is the SWI sequence which shows hemorrhage in the Sylvian fissure. So that is one of the hallmark feature of HSV1 encephalitis. There are certain virus infections which has predilection towards the basal ganglia. So those are the varicella zoster, Epstein Barr virus, West Nile virus. They can have this kind of basal ganglia involvement, just to include in that list. And there are certain viruses which can have, viruses or bacteria which can have brainstem involvement. So here we can see that this is the Robin encephalitis involving the brainstem of the patient, and these are the usual infection agent that we can see, in which the enterovirus is commonly seen. We can see sometimes Listeria, H1N1, those kind of viruses also with this kind of involvement. In a present scenario where mosquito season is going on, when you see this kind of thalamic involvement and with hemorrhage, always rule out dengue also, because dengue can have thalamic involvement and they can have hemorrhage. And when you see this kind of classical, these are diffusion weighted images and ADC images. So when you see this kind of tri-layer kind of restricted diffusion with thalamic involvement with hemorrhage, this condition is called as ANEC, that you might have heard of, acute necrotizing encephalopathy of childhood. It's a very severe condition which has, if you see this kind of typical white periphery, then dark inner, and then innermost white signal intensity on ADC, that is called tri-layer pattern. This is hallmark feature of this this condition called as ANEC, acute necrotizing encephalopathy of childhood. Okay, so just look, keep in mind about this diagnosis. These are some few more areas. For example, in the spinal cord, when the ventral part or the anterior horn cells are involved, in which the enterovirus, poliovirus, they are the usual ones, and so on. I am not going to detail about those things. Then another condition that you should be knowing about, that is the tuberculosis, right? So the hallmark feature of tuberculosis is that it should show T2 hypointensity. So these are the T2 weighted Excel scans in which we are seeing this hypointense tuberculoma, and sometimes you will be wondering that whether it's a tuberculoma or a tubercular abscess. That's the many a time dilemma on imaging. So these are the diffusion weighted images which helps us in differentiating between it is a tuberculoma or it's a tubercular abscess. When it does not show restricted diffusion, that means it's not showing low signal intensity on ADC images. So these are the ADC images which does not show darkening. So that indicates it's not abscess, it's just a tuberculoma, right? If it was abscess, it should have shown low signal intensity. And typically the tuberculoma, they can show conglomerated lesions, they can show ring enhancement, as you can see here. These are the post-contrast ring enhancing lesions. The other thing that you should be aware about, that in tubercular infection you will see a lot of basal exudates. That basal exudates sometimes can cause narrowing of the vessels. So here we can see that bilateral MCA. These are the MR angiogram images. So MR angiogram images, you can see that there is narrowing and irregularity of the bilateral MCA. We have come up with another one more sequence in present era, which is called as vessel wall imaging. So when you are in dilemma that you are dealing with some sort of non-inflammatory vasculitis versus the infectious cause or inflammatory cause of vasculitis, this sequence is called as vessel wall imaging, in which we are focusing on the wall of the vessel. We are not focusing on the lumen, we are focusing on the wall of the vessel. So when we see enhancement along the wall of the vessel, that means that it's active inflammation or infection. And you can see this is the same case. You can see along the walls of the bilateral MCA this circumferential enhancement, which is positive vessel wall imaging. So that indicates that there is active infection or inflammation going on. So this is very useful in a case of viral encephalitis with stroke, or you are not sure that whether it's like some sort of non-infective or genetic origin of vasculitis or versus some sort of inflammatory or infective cause of vasculitis. In those kind of scenario, you can do vessel wall imaging. Then you should be able to identify and differentiate NCC from TB. I know that sometimes it's very difficult to differentiate between the NCC and TB, but 70-80% or 80-90% of cases you should be able to differentiate. The classical hallmark feature that you will be seeing T2 hyperintense or cystic lesion with have this kind of central dot, which we central or eccentric dot, which we call it as a scolex. So that is the vesicular stage of the NCC. This is the calcified nodular stage in which you will see only faint calcification without any perilesional much edema. This is the T2 weighted image in which you will see that T2 dark lesion but without much edema. And this is the colloid vesicular stage in which you will see lot of edema surrounding the lesions. So there are different stages of the NCC. So when you do imaging and you are seeing multiple images in the images, if all lesions are in different stages, that also gives you confidence that this is more likely to be NCC than the TB, because usually in TB infection all the lesions will be on the same morphology. So that will be one of the important distinguishing features between NCC and TB. NCC can have various stages and different lesions can have different stage. So based on that we can differentiate. Always look at the clinical history. Here is one 7-year-old child who had relapse case of ALL. Patient was on post-chemotherapy and came with low-grade fever for 15 days, altered consciousness for 15 days. Now, what we are seeing here that there are mass-like lesions in the bilateral cerebral hemisphere. Few are there in the basal ganglia thalami, few are in the peripheral in the left frontal. Now, imaging can help you what is the underlying diagnosis. So if you see, this is the diffusion weighted images in which you can see that the high signal intensity or restricted diffusion is seen only in the periphery of the wall of the lesion. It's not seen in the center of the lesion. And if you see, this is the susceptibility weighted images. I have told you that SWI images is look for the hemorrhages and other paramagnetic substances. You can see that this kind of galaxy kind of punctate dot periphery punctate foci are there, which indicates microhemorrhages surrounding the lesions. And these are the post-contrast images, which shows this kind of peripheral enhancement. So when you see this kind of peripheral microhemorrhages, peripheral enhancement, peripheral restricted diffusion in an immunocompromised child, so that most likely diagnosis would be a fungal infection, right? So this was fungal, it was invasive aspergillosis. So always take care when you see this kind of mass-like lesions which has peripheral restricted diffusion, peripheral microhemorrhages, so in an immunocompromised state. One more thing I want to highlight, that when the child is immunocompromised, on MRI images post-contrast you might not see significant enhancement because the child was on steroid and all, so that steroid reduces the inflammation, so you might not be able to see the wall enhancement, but you should see the rest of the sequences to come up to the proper diagnosis. This is another a neonate who came with history of high-grade fever and seizures and drowsiness. You can see that there's ventriculomegaly and there are these kind of bilateral asymmetrical multilobar lesions are there. The lesions are having this kind of T2 hypointense wall and central heterogeneous hyperintense area. These are the post-contrast images which shows peripheral enhancement. And here the DWI is very useful. So you can see that the entire lesion, central, most of the 2/3 of the lesion shows this high DWI and corresponding low on ADC images. So this is the classical hallmark feature of cerebral abscess. When you see that entire lesion shows uniform restricted diffusion with this kind of clinical setting with peripheral wall enhancement, that means that it's a cerebral abscess. And in a neonatal child, you can have this kind of cerebral abscesses, and there are few organisms which are notorious for producing this kind of large multilobar abscesses, in which Citrobacter is one of the infectious agents which can cause larger multilobar cerebral abscesses. So this was an abscess. Then this is a 6-year-old child with history of loss of consciousness after cardiac surgery and not referring to command. So anybody? Yeah, you are in, but what is the better terminology? So it's a basically diffuse hypoxic ischemic encephalopathy, right? So it's not following any arterial territory. That's why I'm not using stroke. It's a generalized phenomena. You can see that these are the diffusion weighted images, in which you can see that all the areas, bilateral cerebral hemisphere, all the lobes are showing this kind of cortical high signal intensity. Even the deep gray nuclei, the basal ganglia, the caudate, putamen, they both are showing this kind of high signal intensity restricted diffusion. So it's a global phenomenon. It's not like particular territory so that you can tell it as a stroke or something. It's a global hypoxic ischemic event. So it's very important to identify these changes and the corresponding ADC images which will show low signal intensity, dark area. So that indicates it's a true restricted diffusion, right? And the event is acute to subacute. So based on that, you can give diagnosis and you can tell probable prognosis. If the deep gray nuclei are involved, then the child might have more sequelae as compared to only peripheral superficial involvement. Then this is also very important in a PISU setting. This is a child who was in PISU for some reason. The child became comatose with absent pupillary reflex, and look at the brain. I'll show you few more finding. So anybody wants to comment what this could be? So I just want, for the sake of this thing, this is the MR angiogram image, reconstructed MR angiogram image, and this is the T1 image, and these are the T2 weighted axial images. What this could be with the clinical setting? Yes. Yes. So basically these are the brain dead equivalent MRI images. So what you are seeing that the entire brain is swollen. You can hardly see any subarachnoid sulcal space overlying the cerebral hemisphere. We can see that this is the uncus part of the temporal lobe which is herniating. Everything is like trying to compress each other. The brainstem also is squeezed. You can see here, this is the descending transtentoral herniation. The midbrain is squeezed and going down. Here also the cerebellum also is expanded, swollen, hyperintense. And these are the DWI and ADC image. Entire white matter is showing dark. So that means it's a severe cytotoxic edema, cytotoxic brain injury. Usually on MR angiogram, we should see the branches. Here we are not able to, because of the raised pressure, the brain is so tight that the blood flow is not going up. So these all are features of the brain death. And you can see that this is the tonsillar descent because of the raised ICT. And you can see this kind of medullary kink also. So this was a very severe imaging findings in a case of brain dead child. Right, so this you should be careful. When you see on your conventional sequences only, this kind of raised ICT is there, please tell your radiologist, or radiologist should be aware that we should do MR angiogram just to confirm that there is no flow upward to make the diagnosis and give them the proper prognosis. So these are some different type of the intracranial herniations. Just wanted to show on the diagram. So this is the subfalcine herniation in which the brain herniates through the midline falx. This is the descending transtentoral herniation in which the brainstem descends down because of the upward pressure, and that goes across the tentorium down. This is the lateral descending transtentoral herniation in which we saw that uncus was herniating. This is the tonsillar herniation that we saw in that case. And this is the ascending variety. Sometimes when the posterior fossa has got raised ICD symptoms, the cerebellum can go upwards above the level of tentorium. So that is called as ascending transtentoral herniation. So these are some different kind of herniation that we should see on imaging, and we should tell our clinician that the patient has got some raised ICD and we have to do immediately some treatment in the form of craniectomy to decompress the pressure. Then this is a typical 9-year-old child who had sudden onset hemiparesis of the right side. So these are the typical territorial areas of swelling hyperintensity. This is look like proper ischemic arterial stroke, right? Which is involving the left-sided frontoparietal area. This is basically periphery of the left-sided MCA territory. You can see the sharp demarcation anteriorly as well as posteriorly. The anterior frontal and the occipital lobes are preserved. And these are the corresponding DWI and ADC. So when you see this kind of stroke, your immediate call should be that I should do the MR angiogram to look at where is the level of block. That should be the motto, so that immediate any treatment is required, like thrombectomy or the thrombolytics drug therapy, which we can start. So here we can see that there is total occlusion of the left MCA beyond M1. So these kind of things are very important, and especially when we are dealing with the cardiac condition, we should always include the neck vessel also. When you are suspecting the dissection also you should include the neck vessel, because the dissections are more common in the cervical vessels as compared to the intracranial vessels. So depending on the case, you can modify your MR angio technique. You can only include circumference, or you can include the neck vessels also. This is just too much detail, I am not going to detail. Just wanted to highlight the importance of the perfusion weighted images. So this colorful image is the brain perfusion images, in which we can see that which areas of the brain has got absent perfusion or relatively low perfusion. So based on that finding, we can correlate with the DWI high signal. Is there any mismatch or not? If there is a mismatch between DWI high signal and the perfusion weighted images, that means we can salvage that brain by doing some proper therapy. So these are the advantage of doing perfusion weighted images. It is very useful in a case of stroke. It is very useful in a case of neoplasm also, which kind of brain tumor we are dealing. We are dealing with high grade or low grade. Those kind of scenario we can do. These are some arterial territory that you can read in text. I am not going to detail. This is another one condition which will come often in a pediatric ICU setting with patient with raised BP, hypertension, and this was a case of recent bone marrow transplant and came with headache. And these are the findings. So anybody wants to? Yes. So these are the typical imaging finding of the press. Just to differentiate from the ischemia, that in ischemia you will see in acute setting low ADC values, but in PRES it's a vasogenic edema, predominant vasogenic edema. So the vasogenic edema will be seen as a high signal intensity on ADC weighted images. So that is not a restricted diffusion. In fact, it's a facilitated diffusion. So based on that, we can say that this is look like more of a PRES than the stroke. And the other thing that in PRES you will see more involvement of the white matter. You can see that as compared to the cortex, the white matter is more involved. That's one of the feature of PRES. Usually, typically, the PRES is more in the parieto-occipital region, but we have seen many variant of PRES in recent scenario. So this is the parieto-occipital pattern that we saw. Here is another pattern that you will see the swelling and hyperintensity in the parasagittal superior frontal as well as the posterior parasagittal parietal areas. So that is one of the pattern. You can have entire cerebral hemisphere involvement, that is called hollow hemispheric watershed pattern. Sometimes the PRES can involve only the central part of the brain. It can involve only the thalami, brainstem, those kind of area. So you should be aware about those kind of central variety of PRES also. So that was about the PRES that we should know. In a pediatric population, temporal and frontal lobes are more involved as compared to the adult population. And those PRES who has hemorrhage on imaging, they have caused lesser good prognosis as compared to those who are without hemorrhage, which is not obvious, but that's one of the finding that we can see. Then, another important condition which you should be able to identify on your ICU setting, that a case of nephrotic syndrome who came with sudden onset headache and heavy paresis. So when you are looking at the brain, always look at the vessels also, even though this is a non-contrast plain T2 weighted images. So normally the brain has those kind of dural venous sinuses, right? So dural venous sinuses, they should show T2 hypointensity because it's a flowing blood. So the flowing blood will show T2 dark signal on T2 weighted images. But when you see this kind of hyperintensity in the dural venous sinuses, that means that there might be evidence of thrombus. So that thrombus can be confirmed on DWI images with, it will show this kind of distension and restricted difference in terms of high signal intensity. And this is the non-contrast T1 weighted images. So on non-contrast T1 weighted images, ideally the blood flow should not be bright. So when you see this kind of bright signal intensity throughout the dural venous sinus, this is a superior sagittal sinus on a non-contrast scan. So that indicate that the child might be having thrombus. So post-contrast was done, and post-contrast showed this kind of filling defect within that venous sinus. So this was looking like extensive venous sinus thrombosis, and you can see that even the cortical veins were not showing contrast enhancement. So the thrombus was extending into cortical veins also. So that was the extensive dural venous and cortical vein sinus thrombosis. And in this case, all the venous sinuses were thrombosed. So that's why the medullary veins, you are seeing this kind of, they were very prominent, very bright, which usually we don't see. So these are the MR venogram images of that patient, and the outside extracerebral, the facial vein, they were trying to drain the brain, and you can see that a lot of collaterals would have developed. So that is the normal MR venogram, and you can see in our case, we are not able to see this kind of normal any dural venous sinus, which were all completely thrombosed. So when you suspect this kind of dural venous sinus thrombosis, always perform MR venogram. These are the MR venogram images, which will tell you which sinus is thrombosed, and it's very important. Then another important structure that entity that you should be aware in a pediatric setting is hydrocephalus, right? So when you are seeing that ventricles are dilated, then try to look at that all the ventricles are dilated, or is there any level of obstruction. So these are the lateral ventricles that we can see on which are occupying entire the cranial cavity, and this is the third ventricle in the axial images, and look at the fourth ventricle. The fourth ventricle appears to be normal in this scenario. So there has to be some sort of obstruction at the level of aqueduct or above in the posterior third ventricle, right? So when you see this kind of hydrocephalus, always try to look for is there any obstruction or not. And just to look at that aqueductal area, we have got this kind of dry sequence, which is heavily weighted T2 weighted sequence, which can show this kind of aqueductal anatomy much better, and this was a case of aqueductal stenosis due to nodularity at the region of aqueduct. And we also have got this kind of CSF flow study. So this is very important. When you are looking at the obstruction at somewhere along the pathway of the CSF, you can do this CSF flow study, in which we can hardly see any flow across the aqueduct. So by that you can see that there is a definite obstruction at the level of aqueduct, and treatment can be done accordingly. And sometimes the posterior fossa tumor can cause hydrocephalus. So whenever you are seeing hydrocephalus, always try to look out any malignancy which is causing obstruction of the outlet, the ventricle outflow. So here is the posterior fossa tumor, which is the along the fourth ventricle, and that was causing upstream hydrocephalus. And you will see this kind of periventricular hyperintensity, which is the CSF ooze surrounding the ventricles, which indicates that the ventricle system is under pressure due to distal obstruction. So that was a case of medulloblastoma. Now, last 2-3 trauma case, and I'll wind up the session. So here is one. This is the case which we had, I think, couple of years back in SRCC. So the patient had come with the acute trauma with sudden drop in GCS. I think Kaustup might be remembering this case. In which the child initially presented with areas of only focal hyperdensity in this region. So we were treating the child conservatively, but then suddenly the child was worsening more. Then the repeat imaging was done, CT brain was done, and this was the finding. So anybody wants to comment what is happening in the brain? Pardon? There is some sort of midline shift, and you can see that the brain again here, it looks like very tight brain. You are not able to see sulcal space overlying the brain hemisphere. So there are features of raised ICT. You can see that the hemorrhage has gone into the ventricles also, and you can see that this area shows some sort of heterogeneous density, like a swirling phenomena. That indicates that there is acute ongoing bleeding happening in that region, and you can see this kind of linear defect, that is the fracture after the fall. So when you see this kind of raised ICT with intraventricular extension, you are hardly able to see sulcal space. That indicates that you need to do immediate decompressive craniotomy, otherwise the child will lose his life because of the raised pressure. You can see that hardly you are able to see the sylvian fissure, the basal cistern anywhere around, and the cerebellar tonsil also appears to be descended. So it's very important to pick up this finding that the child had raised ICT feature and with intracranial hemorrhage, which requires immediate surgical intervention. Now, which of this is correct? This is which kind of hemorrhage? It is subfalcine, epidural, subdural, or what? Correct. So it's a subdural hemorrhage. So how you do identify subdural hemorrhage? Usually are crescentic in shape, and they can cross the sutures, because since they are subdural, they can cross the sutures. That is one of the hallmark find, and they are limited by the dural diffractions. And in the contrary, this is the epidural hemorrhage. So epidural hemorrhage are usually biconvex instead of crescent shape, and they are limited to one suture only. They will not usually cross the suture. And usually epidural hemorrhage, when you are seeing, try to see the bone window. You will be able to see fractures which are more commonly associated with epidural hemorrhage as compared to subdural hemorrhage, right? So by that I would like to conclude, and would like to say that we should be aware about the normal anatomy. We should know the sequences and their usage in particular scenario, and we should always look for the features of raised ICT and their importance. And I have shown you some common cases that can occur in pediatric ICU setting, and we should know about the imaging features of that. So by that I would like to conclude this session. Thank you so much.
Neuroimaging plays a vital and decisive role in pediatric neurocritical care, but has never been a part of the curriculum. Thank you, Dr. Hiren Panwal, for his presentation on neuroimaging PICU. I request Chairperson Dr. Neena Fade, Dr. M.S. Kumare, and speakers Dr. Manoj Srivastav, Dr. Sheikh Minhaj Ahmed, Dr. Sara Dhanwade, and Dr. Hiren Panwal to proceed for felicitation.
Dear delegates, now it's a time for prize distribution of papers and posters. I invite Dr. Nakate and Dr. Sunil Vaidya sir to do the honors. I invite Dr. Amruta Godi to declare the winners.
Good morning.
I request Dr. Pratibha Patil to be on the stage.
Start with paper presentation. I request Dr. Vikram Hirekur sir to be on the stage for the honors. Okay. Paper presentation. The first prize goes to Dr. Swapnil S. Sarode. I request Dr. Swapnil to come in. Dr. Swapnil. टॉपिक दिलेस का?
एक माइक दे, एक माइक
My topic name is P-Sopascular discord and its use in patients in critically ill childs.
Second place goes to Dr. Rishabh Singh Deo. Dr. Rishabh.
Combination of midazolam and ketamine in procedural sedation analysis in a tertiary care.
Third place goes to Dr. Asta. Dr. Asta Pramod.
Thank you, sir. My topic's name is prevalence of undernutrition and its short-term outcomes in critically ill children, which is a prospective cohort study.
Fourth place goes to Dr. Nilesh. Fifth place goes to Dr. Shravan.
to assess adverse effects and seizure control in drug monotherapy in children with epilepsy.
First place goes to Dr. Mrunalini. Dr. Mrunali. She's not there. Okay. The second place goes to Dr. Suraj.
Topic was acrocollagen syndrome.
Third place goes to Dr. Tasneem. Dr. Tasneem. Fourth place was shared by Dr. Pranita and Dr. Maz.
My topic was connectivity dots to reach diagnosis on a case of myasthenia crisis.
The fifth place goes to Dr. Saujanya.
Please encourage them with good round of applause.
snake bite induced acute kidney injury in a patient who has undergone peritoneal dialysis.
Thank you. Thank you all. Thank you for the judges.
Judges for the poster presentation, Dr. Chakre and Dr. Samir Khan. Thank you very much.
It's a time for quiz winners announcement. First was Dr. Amit Kumar. He received his prize yesterday only. And the second prize was for Dr. Aditi Palai. She's there, she can collect the prizes from us. And we thank all the quiz masters, Dr. Jay Bhandarkar, Dr. Tank, Dr. Mohnish Bolli and Dr. Sandeep Kade. Please collect all the prizes from us.
For the next session, I call upon the chairpersons, Dr. D.S. Tite and Dr. Nilofer Bhuri and Dr. Suresh Unmane. PICU stay affects physical, cognitive, emotional and social health of the child as well as the family. PICSP is a complex entity. To address this condition, please welcome Dr. Sameer Dalwai.
Shall I begin? Can we begin? Yeah, okay. So, Sarvapratham Namaskar and my regards to Dr. Sunil Vaidyaji, Dr. Dayanand Nakateji, Dr. Anna Saib, Dr. Kundan Chopde, Dr. Samir Khan, Dr. Keyur, all the respected seniors, Dr. Vinay Joshi, all of you. Thank you so much for giving me an opportunity to present here. आपण इंटेन्सिव्ह केअरबद्दल गेले 2 ते 3 दिवस डिस्कस करतोय. पण इंटेन्सिव्ह केअरच्या नंतर काय होतं ह्याच्याकडे लक्ष जरा कमीच असतं. आणि आय एम हॅपी दॅट फॉर वन्स द इंटेन्सिव्ह केअर चॅप्टर अँड द कॉन्फरन्स हॅज लुक्ड ॲट what happens after the intensive care and given me this topic about post-intensive care syndrome in children. How do we understand, identify and manage this syndrome? The theme for the conference is PICU. Time is life, absolutely true, but that time is not only the time on the ventilator or in the intensive care, because at times we tend to look too technically ki माझं एवढंच काम आहे. As long as the person goes out alive, the child goes out alive, things are fine. But as neonatologists are recognizing, it's not only about survival, but it's about intact survival. Similarly, about post-PICU care also, we have to realize the importance of the quality of life of the child thereafter. And we have to understand that so many advancements in pediatric intensive care have increased the survival rates of critically ill children, and that has brought in long-term consequences, which is called as a post-intensive care syndrome in children, which is now a very emerging concern because you are able to save more lives. So obviously there are more long-term consequences. And this is defined as a constellation of symptoms that arise following an ICU stay, and it may not necessarily be a long stay, it can even be a short stay, which affects patients physically. Oops. Yeah. Okay, slides move nahi bagta ka? Yeah, thank you so much. Thanks, Preeta. So, symptoms that arise following even a short ICU stay, definitely following a long stay, affecting patients physically, cognitively, and psychologically. And these are the 3 terms that's all that we need to remember. And this includes the long-term consequences experienced by children. And I have also highlighted their families after critical illness and intensive care. So on one hand, you have the physical, the cognitive and the mental health problems in the survivor and the child, but please let's not forget the family members who also have significant mental health problems as part of their child's journey. A significant proportion of children are now experiencing some form, lots and lots of studies coming up, and you will see between 25 to 35% children from a PICU stay have cognitive impairment, whereas 15 to 20%, 25% children have some physical and psychological symptoms. Let's look at how much time we even give to this fact. 25 to 30% of our children, after they go out alive, have a problem like this, but we generally fail to recognize what is to be done about it, as you can see here. Let's look at some risk factors that will help you prioritize those children who are more likely to have a syndrome. And the three very important risk factors are the length of stay in the ICU, because obviously the longer the child stays, it perhaps means that the child needs to stay that long, but it also shows more exposure to stressors, invasive procedures, and of course immobilization in the ICU. Because the diurnal clock, as you all know, gets completely upset. Mechanical ventilation is connected to physical and cognitive impairments, as we all know. It's the sedation, it's the muscle deconditioning while the child is on the ventilator. We generally take care of the lungs, but we fail to take care of it. At the most, it can be just a passive care. And of course, there are potential hypoxic events. Sedation and analgesia is something all intensivists want so that the medical care can go on. But it has its own problems of withdrawal symptoms causing delirium, and even a long-term neurocognitive dysfunction can occur. Severity of illness, there are various severity scores that I'm sure all of you are used to. And the higher the severity, it has been correlated with the worst outcomes. Children who already have a neurological condition before or a developmental disorder, children with HIE, children with cerebral palsy, children with autism, children with intellectual disability, they have a worst outcome after ICU. And the younger the child, and of course that's where you know about the neonatal period, as well as those at critical stages of neurodevelopment in the first 1,000 days of life, as you say. It's not just the 1 month of the neonatal period, it's the first 1,000 days of life, that these stages are more critical to the entire story thereafter. If you look at the three parts that I've spoken about, physical effects, cognitive and psychological. Physical effects are both short-term as well as long-term. One is of course muscle weakness and mobility issues because of prolonged immobilization and muscle disuse in the ICU. But there is also a fact that some of these children have a difficulty in regaining the previous levels of physical activity. You may have seen a child who gets discharged after a long struggle. We rightly need to pat ourselves on our back. Everybody in the ICU in the hospital needs to pat themselves on their back for having ensured a survival. But often the parents will come back saying that my child is not as active physically as he was, and there is some impact. He's not able to do his brushing every morning correctly, he doesn't get ready in time, I have to be after him, so on and so forth. And very important that the child does complain of chronic pain, fatigue, and there is a delayed recovery. Now today you know how important school life is, and everybody is obsessed with that. If the child is missing school or going to school but is fatigued, it won't help. And of course, as you know, even the entire thing about post-ventilation and swallowing, I don't know how much attention and priority we are giving it. Refer to speech therapist. This doesn't mean that the problem is going to be solved. आणि हे करून घेणं हे आपली जबाबदारी आहे असं म्हणायला हरकत नाही. At the same time, it leads to a nutritional growth deficiency, physical developmental problems, stunting may be the result later, and increased susceptibility to infections and other health issues. So it's not only the infection that happens, nosocomial infections that everybody talks 3 days about in a conference. But nobody is looking at the nutritional deficiency and the suppressed immunity thereafter. Looking at the cognitive effects, very frequently, it's not rarely, it's observed that there is some problem with memory loss, retention, paying attention in the classroom, and this impacts the academic performance and everyday functioning. Similarly, the children who have challenges in school requiring special education service, they need to have some special individualized learning plans. And especially the worry, and I've seen so many in our child development center, where the normal developmental trajectory is disturbed. The child was developing on normal milestones for the first 2.5 years of life, then suddenly he had a pneumonia or a sepsis and he's gone into the NICU, in the IPCU, has a stormy care course, comes out intact, but his development is never the same. You will have children with speech problems, children will have memory problems, children will have behavioral problems which will come to now going ahead. And that we need to remember that even anxiety and depression, not only adults. We might be thinking all this happens in adults. No, it's being proved that traumatic experience of being in the ICU, the stress of recovery can persist long after discharge. And I don't know how many of us as intensivists are even aware about this term, about post-traumatic stress disorder. अरे वो तो आप किधर, you get stuck in some riot or in an earthquake or in a tsunami or in a car accident, उधर होता है पोस्ट ट्रॉमॅटिक स्ट्रेस डिसऑर्डर. इधर तो मुलाचं आयुष्य आम्ही वाचवतोय, ऑफकोर्स वाचवत आहे, ह्याच्यात काहीच उसके दो राय नाही आहे. पण त्याच्यानंतर हा पण एक ट्रोमा आहे मुलासाठी. त्या मुलाला कुठे कळते की त्याला तुम्ही इथे एवढे ट्यूब्स का लावलेत आणि का हे सर्व फिडिंग करताय. सो इट इज लाईक अ चाइल्ड हॅज बीन इन अ traumatic situation, and this may include flashbacks, nightmares, hyper arousal. You will get complaint की ते बाळ झोपत नाही आहे, चिडचिडं खूप झालेलं आहे, अरे होईल काय काही दिवसात बरं. This is not something that we can afford to do. And behavioral changes like irritability, aggression, withdrawal, and please understand this affects the entire dynamics of the family. The other sibling gets affected. As it is, he's been ignored for the last 2 months because parents were focusing on this child in the ICU. Now this child is irritable, parents need to take more care. It affects the entire family dynamics, and hence I put up this picture that the caregiver stress that affects family dynamics is never ever prioritized or even thought about. So, I mean, Preeta is here, and I remember there was a pediatrician from the neighboring state, and his child had some complication and had come down, and for 1 month he was with you, Dr. Preeta, at Ambani, and undergoing rehab. But it was such a traumatic experience for the family, and both parents were pediatricians with big hospitals in a good city in a neighboring state. By the time 8-9 months had passed, they were bankrupt because both of them couldn't do their practice. Whole day they had to be looking after this child, and I mean, because you are there, I just remembered that child, how you had helped them. Parents and caregivers have to cope with the long-term consequences of child's critical illness. It is not only those 8.5 days that he was in the ICU. 8.5 days में ICU से निकाला इसको. Very good, fantastic. I mean, it's next to God. But what happens after that? The financial burden of ongoing medical care. It's not only the bills that they have paid, the bills for rehabilitation, and the loss of income while the child is inside the hospital. And this gives rise to significant stress, anxiety, depression. It affects intermarital relationships, the family dynamics. One of the grandparents who required medical care is perhaps being ignored, and hence the messages. Early identification of a post-infectious intensive care syndrome is very important by all of us in the ICU. How will we intervene timely to see that even the post-ICU recovery is improved and has better outcomes? And hence, when we take the rounds, it's not only the TPR and the blood pressure and the dopamine dosage or whatever else, then the ventilatory settings, which I can't talk at all about, that all of you are looking at so eagerly, and I heard since morning all the time how you are monitoring each and every drop of fluid, and less is more. I heard all that. It's very important to be aware what is it that I can do to prevent physical, cognitive and psychological impairments in this child post-discharge. And for early identification, I use this word which a friend of mine who's an American CEO uses, calendarize. मतलब ओके हां, नंतर फॉलोअपला या तुम्ही कधी या 1 महिन्यानंतर. आता 1 महिन्यात 30 दिवस असतात, नेमका कुठल्या दिवशी यायचं. पण तुम्ही असं 1 महिन्यानंतर या जेव्हा म्हणता ना, तेव्हा ते असं जनरल वाटतं. 1 महिन्यानंतर या म्हणजे असं चहापणाला या आपण म्हणतो तसं सोलापूरला आल्यावर या कधी घरी. तुम्ही 15 तारखेला सकाळच्या ओपीडीमध्ये या बरं का. पेरेंटला अचानक वाटतं नाही, नेमकं डॉक्टरने तारीख दिलेली आहे, म्हणजे काहीतरी इम्पॉर्टंट असणार. तुम्ही वॅक्सिनला म्हणता का या जरा 1.5-2 महिन्यानंतर, तारखा देता ना तुम्ही. तारीख दिल्यानंतर त्याचं सिरियसनेस राहतं की नाही त्या दिवशीच जायला पाहिजे. 2 दिवस उशिरा वॅक्सिन दिलं तर काय बिघडतं. पण आपण असं म्हणतो का या 2-4 दिवसानंतर नाही, आपल्याला त्याच दिवशी पाहिजे. ते इम्पॉर्टंट आपल्याला वाटतं, म्हणून दॅट इम्पॉर्टन्स इज कन्वेड टू द फॅमिली. यू हॅव टू कॅलेंडराईज, त्यांना लिहून द्या. त्या सांगा टू डू लिस्ट काढा तुमच्या. प्रत्येकाकडे स्मार्टफोन आहे, कॅलेंडर ओपन करा, गुगल कॅलेंडरमध्ये डेट टाका. से इफ यू वॉन्ट अ फॉलोअप ऑन द फर्स्ट वेनसडे, तुमची जनरल ओपीडी तुमची पण फर्स्ट वेनसडेला आहे ऑफ एव्हरी मंथ. त्यांना सांगा फर्स्ट वेनसडेला टाका आणि कॅलेंडराईज करा फॉर द नेक्स्ट 6 months. मी 3 मिनटं ह्याच्यावर घालवली का, कारण हे केल्याशिवाय रेग्युलर फॉलोअप आणि कॉम्प्रिहेन्सिव्ह असेसमेंट हे फक्त मोठे मोठे शब्द आहेत जे अमेरिकन्स त्यांच्या थिअरीमध्ये यूज करतात. आपण ऐकतो, टाळ्या वाजवतो आणि विसरून जातो. तसं करू नका. आणि देर आर सम स्क्रीनिंग टूल्स. आय एम नॉट गोइंग टू टॉक अबाउट इट बिकॉज मला कोणीतरी सांगितलं द मोस्ट इम्पॉर्टंट स्क्रीनिंग टूल इन न्यूरो डेव्हलपमेंटल प्रॅक्टिस ऑफ वॉट माय लाईफ इज बिटवीन द 2 years. दिस इज द मोस्ट इम्पॉर्टंट टूल. आणि त्याच्यासाठी तुम्ही कुठलंही ह्याच्यातलं टूल वापरा. तुम्ही बेली स्केल करून घ्या, वेस्लर स्केल करून घ्या, पण ते त्याच्या अगोदर मुलाला बघून त्या मुलाचं बिहेवियर तुम्हाला कसं दिसतंय, आई वडिलांबरोबरचं त्याचं अटॅचमेंट कसं दिसतंय, हे तुमच्या त्या 2 कानाच्या मधलं जे टूल आहे ना तेच पिकअप करू शकतं. जस्ट अ शो केस स्टडी. 7-year-old चाइल्ड, प्रिव्हियसली हेल्दी, I've mentioned that, was admitted to the ICU with severe pneumonia, sepsis, mechanical ventilation for 2 weeks. Fantastic job done by all of you, including the nurses, staff. But following discharge, mother said, mulala chaltana tras hoto. He required some physiotherapy to regain strength and mobility. Teachers reported decreased attention span, laksha det nahi vargat, homework complete hot nahi. And he had nightmares at home, woke up in the middle of the night, अरे परत मला हॉस्पिटलला नेणार नाही ना, आई परत टोचणार नाही ना सारखं सारखं मला. So look at the 3 boxes. It's the same 3 things. Just remember these 3 things. Physical problems, cognitive problems and psychological problems. करायचं काय? Multidisciplinary approach. But that approach multidisciplinary म्हटल्यावर माझी जबाबदारी संपली, त्या थेरपिस्टकडे पाठवून टाका असं अजिबात करायचं नाही. कारण जबाबदारी तुमचीच आहे. Because you have to organize this entire care, whether it is physical rehabilitation, physiotherapy service sessions, to improve muscle strength and mobility, cognitive support, educational support, psychological support for the entire anxiety, the emotional disturbance, all this has to be coordinated. So quickly, if you want, you can take a picture. म्हणून मी ते बनवून असं बनवलं की what are the different roles. Pediatricianचा सर्वात पहिला रोल काय लिहिलाय? रेफरल नाही लिहिलंय. पाठवा आणि जबाबदारी संपली असं नाही. ओव्हरसी रेफर कोणाकडे करताय, तो काय प्लॅन बनवतोय फिजिओथेरपीचा, ऑक्युपेशनल थेरपीचा प्लॅन काय आणि त्याचे आउटकम काय येत आहेत मंथ ऑन मंथ. इज द चाइल्ड्स मोटर मुवमेंट गेटिंग बेटर, इज इज फटीग गेटिंग लेसर, इज इज पेन गेटिंग लेसर, आर इज नाईटमेअर्स गेटिंग बेटर. हे सर्व आपल्याला कोऑर्डिनेट आणि मॉनिटर करायचं आहे. नर्सेसचं इन द वॉर्ड असताना माझे बाबा, म्हणजे मला ते बोलायचं नव्हतं, पण ही हॅड अ व्हेरी टफ टाईम अबाउट 4 years बॅक ॲट द बिगिनिंग ऑफ कोविड. इज फाईन नाव, बट ही इज 90+ and he is so intelligent that he takes my case every time I discuss with him. So I have no match for his intellect even today. But such an intelligent man, when he goes in the ICU, suddenly 2 days later, he starts getting psychotic. ते ओळखत नाही कोणाला. It's just like psychosis. And I was shocked की such an intelligent man, ह्याला काय झालं? आणि म्हणजे आपल्याला जाम भीती वाटते. आणि मला सांगितलं इंटेन्सिव्हिस्टने की डॉक्टर अन्सारी ॲट नानावटी की अरे दिस इज व्हेरी कॉमन, बिकॉज त्यांना दिवस रात्र कळत नाही. आणि इंटेलिजंट मॅन इज अवेअर अबाउट एव्हरीथिंग दॅट हॅपन्स इन हिज एन्व्हायरमेंट. When that environment is cut away, it's like his life support is cut away. So suddenly he goes into psychosis. I had to hold him down in the side room after he was shifted from the ICU all night. कारण he was catheterized, he would get up, आरडाओरडा करायचे. And it is so traumatic for me to see my hero, somebody who's 10 times more intelligent than me, who runs my life today. I have to do this with him. Suddenly in 2 days he has become like this. So this is very, very overwhelming for people. So all of this is very important for the doctor to be aware of, the intensivist. Of course, physiotherapy to improve physical functioning, mobility, not just for lungs and for infection. And occupational therapy for activities of daily living. घरी गेल्यावर ते मूल आपल्या रोजच्या गोष्टी करू शकते की नाही. मला एक मुद्दा सांगायचा आहे. सध्या एक फॅशन झालेली आहे. मुलाला स्पीच प्रॉब्लेम असेल तर स्पीच थेरपिस्टकडे पाठवा, बिहेवियरल प्रॉब्लेम असेल तर ऑक्युपेशनल थेरपिस्टकडे पाठवा. आता असं झालेलं आहे की कोणाला 40-year-old person gets a stroke and he has no speech, त्याला स्पीच थेरपिस्ट मुंबईमध्ये मिळत नाही. कारण ऑल द स्पीच थेरपिस्ट आर बिझी विथ चिल्ड्रन विथ ऑटिझम सेइंग मम्मा बोलो, मम्मा बोलो, मम्मा बोलो, मम्मा बोलो, till he says mama without understanding mama. That is not their role. And I have been very critical about it. But this is their role and this is where they are needed. And probably you are not sending it to them. That's why they are taking something which they don't have to do. What do they do with children with autism? Shape sorting, color mapping, solving puzzles. त्याचं जीवनात काय करायचं आहे. आणि तुम्ही बरेच वेळा ऐकलं असेल माझ्या ऑटिझमच्या लेक्चरमध्ये, आय एम व्हेरी क्रिटिकल अबाउट व्हॉट दे डू, बट दिस इज व्हॉट दे नीड टू डू. परहॅप्स यू आर नॉट रिकग्नाइजिंग इट एज इंटेन्सिव्हिस्ट. Perhaps you are not utilizing their service, because this is where their excellence, their magic is really important, because they are the ones who can really help you with these children, whether it is activities of daily living by an occupational therapist, emotional well-being, counseling the family, the educational special educator for academic needs in these children. But be careful, like I said, because this was an article in the Wire, Dr. Vinay, that there is an article that everybody in India has become an influencer or a therapist. And if you go on Instagram, you will have so many posts. आणि बऱ्याच वेळा मी सायकॉलॉजिस्टना भेटतो आणि त्यांना काही प्रश्न विचारल्यावर ते उत्तर देतात. मला आठवतं परवा रात्री ते परवा व्हायरल होत होतं ते इंस्टाग्रामवर. पीपल हॅव स्टार्टेड लुकिंग ॲट इंस्टाग्राम ॲज देअर सोर्स ऑफ लर्निंग. आणि दे आर सो इन्फ्लुएन्शियल, 2 lakh फॉलोअर्स, 3 lakh फॉलोअर्स. पेरेंट्सनं वाटतं हेच खरे सायकॉलॉजिस्ट आहेत. त्यांना काही कळत नसतं, त्यांना काही डिग्री नसते, त्यांना काही माहीत नसतं. बी अवेअर कोणाकडे ते जात आहेत. सो व्हॉट आर द 4 key responsibilities? अगेन आय जस्ट वॉन्टेड टू मेक अ रेडीमेड थिंग फॉर ऑल ऑफ यू. You have a crucial role. First, let's understand that in not only identification, management, but the golden word is long-term monitoring. मॉनिटर करून घेणं तुमचं काम. तुम्ही ICUमध्ये रात्री 2-2 वाजता फोन करून विचारता त्या मुलाचे व्हेंटिलेटरी सेटिंग्स काय आहेत, त्याचं मला व्हायटल सांगा, डोपामिन, तुम्ही 2-2 वाजता करता आणि एकदा ते मूल सर्वाइव्ह होऊन गेलं त्याच्यानंतर अरे बरं आहे ना, तो आलेला ओपीडीला चालताना दिसला मला, म्हणजे जिवंत आहे, झालं खूप. असं नका करू, कारण तुम्ही हाफ गॉड का होत आहे, तुम्ही फुल गॉड व्हा, पूर्ण ह्या गोष्टी बघा. सो रेकग्नाइज ड्युरिंग फॉलोअप विजिट्स, मेक अ प्लॅन, रिफर, coordinate this care between different specialties. Family support is very, very important to make them understand की हे मूल असं का वागतंय. आणि advocacy and education for increased awareness, educate other professionals. Very important support systems. Just 2 types. हॉस्पिटलमध्ये पण बरेच सोशल वर्कर असतात, बऱ्याच फॅसिलिटीज आहेत. एखादी नर्स असते ती जास्त एम्पॅथेटिक असते, तिला इन्व्हॉल्व करा या फॅमिलीकडे. शी मे नॉट हॅव बीन ऑल द टाइम ऑन ड्युटी विथ दिस स्टाफ. आणि तुमच्याकडे आता आपण सोलापूरला, कोल्हापूरला लहान लहान हॉस्पिटल असतात, पण ती एखादी नर्स असते, तिला माहीत असतं त्या पेशंटचा एक टच असतो. Even if she is not there during that patient's care, she may be on a leave. आल्यानंतर तिला कनेक्ट करून द्या की ह्या ताई आहेत ना, ह्या तुमचं लक्ष ठेवतील, त्यांना भेटत राहा, पण रेग्युलर. अँड सिमिलरली आपण फक्त त्या मुलाकडे आणि त्याच्या आईवडिलांकडे लक्ष असतं, कारण बिल तेच देणार असतात. पण मी नेहमी ऑटिझममध्ये पण म्हणत असतो किंवा न्यूरो डेव्हलपमेंटमध्ये, भारताने अमेरिकेला इंटेन्सिव्ह केअरमध्ये कदाचित फॉलो करावं, कारण त्यांचं रिसर्च तेवढं असतं. पण समाजात कसं वागायचं ते अमेरिकन कोण सांगतात आपल्याला. त्या अमेरिकनला काकी, मामी, मावशी आणि आत्या ह्या चौघींना फक्त तो आंटी म्हणतो. किती केळसवाणी आहे. काकी आपली वेगळी, मावशी वेगळी, आत्या वेगळी, मामी वेगळी. एखादी काकी कुसकी असते, एखादी मावशी प्रेमळ असते. आपण प्रत्येकाकडे जाऊन शिकत असतो. हे अमेरिकनना कळणारच नाही, तर त्यांचे ह्याच्यावर एव्हिडन्स ते क्रिएटच करू शकत नाही. ह्याला एव्हिडन्स आपण केलं पाहिजे. आणि म्हणूनच कम्युनिटी इन्व्हॉल्व करणं, त्याची काकी आहे, मावशी आहे. सोलापुरात तुम्ही प्रत्येक फॅमिलीतल्या प्रत्येक मेंबरला ओळखता, त्यांना सर्वांना बोलून इन्व्हॉल्व करणं जरुरी आहे. आणि म्हणूनच लॉंग टर्म मॉनिटरिंग, अगेन आय सेड अबाउट कॅलेंडराइज, या जस्ट 2 minutes, ओके. Check the time, check the child's entire development, look at the academic support, but parental support is equally important and you cannot minimize that. Again, what we can look at, preventive strategies in the ICU management, minimizing sedation. You all know how to do that. Early mobilization as soon as possible. Prevent delirium by optimizing the sleep timing of the child, reducing the noise in the ICU. And family-centered care, of course, you can take up, just this is to remind you, याच्यातलं तुम्हाला काहीही येत नाही असं एकही गोष्ट नसेल, सर्व येते, फक्त लक्ष ठेवून ते करून घ्या. आणि इफ यू डू दॅट, दिस इज हाऊ यू आर सपोज टू बी विथ द चाइल्ड इन द ICU ड्युरिंग द स्टेप डाउन as well as at discharge to reduce the psychological burden. So what are the challenges going beyond the medical aspects during the ICU stay and the step down care and post discharge? Creating awareness in your hospital, in your circles. Recognize the importance of stress that families face. Involve kaka, kaki, mami, atya, azoba, shezari, etc. 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 तिकडचा कोण स्पिरिच्युअल लीडर असतो, कोण रिलीजियस, सर्वांना इन्व्हॉल्व करा फायनान्शियल बर्डनमध्ये. सकाळपासून बऱ्याच लोकांनी सांगितलं आणि मिनाजभाई सारखे बोलत होते, लेस इज मोर, लेस इज मोर, लेस इज मोर. एकदम बरोबर. ते कशात? मेडिकल केअरमध्ये जास्त फ्लुइड देऊ नका. पण मॅनेजमेंट ऑफ पोस्ट इंटेन्सिव्ह केअर सिंड्रोममध्ये मोर इज बेटर. जेवढं जास्त तुम्ही कराल, जेवढं जास्त प्रेम द्याल, जेवढं जास्त अफेक्शन दाखवाल, जेवढं जास्त सहानुभूतीचा हात द्याल, दॅट इज बेटर. सो नीड फॉर इंडियन डेटा युझिंग काकी, मावशीज रोल इन द ICU विच अमेरिका कॅनॉट शो. अवेअरनेस अँड ॲडव्होकसी. अँड फायनली वन लास्ट क्वेश्चन. Besides the child in the ICU, who else has PICS? Who else has post-intensive care? Only 2 people have raised their hands. Hence, don't forget that you are also a victim of intensive care syndrome. Don't ignore this. And are you paying enough attention to your own health needs and your children's needs, your family's needs? त्यांना किती स्ट्रेस होतोय. तुम्ही रात्री 2-2 वाजता जाता, कोणाचं बाळ 4 वर्षाचं असेल, कोणाचं 5 वर्षाचं असेल, कोण 10वीच्या परीक्षेला बसत असेल. ही नीड्स यू अराउंड. आई उठून किंवा बाबा उठून हॉस्पिटलला जातात. Look at that. So if you want to be a pediatric intensivist, first learn to look after yourself. So I would like all of you to give a big round of applause to all that you do. Give a big round of applause to yourself. But keep looking after your own health. So the conclusion, this is complex, multifaceted, comprehensive, multidisciplinary approach. Pediatricians play a pivotal role in prevention of this syndrome. They can improve the long-term outcomes and quality of life of children. And research and collaboration is essential. This is just a book that IAP has come out with, Developmental Behavioral Pediatrics. If you are interested, some of the chapters are covered here. And the most important message is, we can succeed only if we are multidisciplinary with the entire team of therapists, psychologists, special educators, physiotherapists, occupational therapists. Thank you very much. Thank you, sir. Thank you, sir.
Thank you, Dr. Sameer Dalwai.
Thank you, sir.
Sedation and analgesia are often underused or overused in PICU. The next session will give more insight on their optimal use. I kindly invite Dr. Dayanand Nakate sir on stage.
Good afternoon, everybody. So, I'm going to talk on sedation and analgesia. So, whenever we are in the PICU or any time, pain is very important factor and which is day-to-day life. समजा आपल्याला नुसतं जात जात दरवाजा जर लागला म्हणतो आपण. So, it is a sensation or it is an important feeling that everyone gets, and when the patient is in pediatrician's clinic, even for consultation also, patients are agonic, panic, and they are ill patients, and we have to take care of this. And pain is the very important factor, and if you neglect that, it has got its own implications. So, pain can be due to disease process and interventions, but especially in ICU, we do so many things, from putting an IV line, putting an oxygen cannula, putting an hood like that. So, most important, whenever the patient comes, if the patient is alert for you in OPD, the anxiety is very important, then distress. And emotional distress, as Sir has rightly said, that psychological and emotional impacts of the PICU as well as day-to-day medical procedures is long-term. And whenever sometimes, whenever the child is ill, and when the child is at the age of 2 to 3 years, suppose he gets pain prick, or sometimes IV cannulation is out and there is so much of pain. But if the patient comes for the OPD for next follow-up, he'll be scared to come to the OPD because there is some psychological trauma in his mind that whenever he will be visiting that particular hospital, a particular doctor, or even a doctor's name can cause pain to him or trauma to his mind. So this is the impact of pain. So it is defined as an unpleasant and emotional experience associated with the actual and potential tissue damage. So it may not be necessarily the tissue damage, but it can be emotional also. So it is again subject to experience. Somebody has a little pain threshold, somebody has very good tolerance as well as threshold. So it may vary, but it will not be common for each and every person. So managing this pain threshold or pain, it is an important phenomenon, and for that we have to tolerate we have to adjust the doses accordingly. So depending upon the pain threshold, the drug doses has to be adjusted. So in general, common principles, most studies are performed using the healthy adults and the pediatric studies are not available. So it is very difficult to treat the patients for this particular thing. So whenever we are treating, so the absorption of the drug and its pharmacokinetics is very important for this, again for the relief of the pain. So absorption, when we are giving the doses in the form of orally as well as parenterally, the absorption and its pharmacokinetics is totally different. So whenever the patient is in PICU, most of times they are on the multiple lines. Thank you, sir. Got it. Yeah, thank you. Whenever the patient is in ICU, for pain management, oral doses and OPD visit is fine. But when the patient is in the ICU, they have got multiple lines, and the most of times the per oral route is not a good choice. So this absorption effects, and because of its own illness, GI effects, and the particular whatever the drug absorption will be there, and the effect will be expected, it will not be same in patients who are on the OPD as well as in the PICU. So we have to take care when you are administering the doses, you have to take care of the absorption as well as pharmacodynamics of the drug. So this absorption is increase in hepatic blood flow and decrease in the hepatic flow. So whenever the patient is having hypercapnia, the increase in the hepatic absorption. So similarly, acute hepatitis, food intake, beta-agonist phenobarbital and enzymes, these are the factors that increase the hepatic absorption, and there are other conditions, that is when the patient is on ventilator, when the patient is having intermittent positive pressure ventilation, hypopnea, hypoxia, alpha simulation and beta blockers, they affect the hepatic blood flow. So, as I mentioned initially, the absorption differs in the oral management as well as parenteral management. So, in PICU, the most of times the parenteral route is the best choice, and either in the form of IV or IM. So, this I mentioned, this distribution, drug distribution is again important. Wherever the after absorption, we want to take the particular action to that particular level. That's why this distribution is very important. Again, metabolism, elimination, that all again depends upon the plasma half-life of the drug, and again we have to continuous, if you are having want to go for the continuous sedation or continuous analgesia, this it has to be maintenance doses, because sometimes bolus doses may not be working, and the duration of action may vary depending upon the absorption. So it has to be in the preferable choice will be in the form of giving bolus, initial boluses followed by maintenance doses in the form of infusions. So how do you assess this? There are different scales. That is, one is the flax scale. It has got grades, that is 0, 1, 2, and this is the emotional, that is looking at the patient's face. You can see that whether the patient is having what kind of pain or disturbance is there. So depending on the looking at the face, there are no particular expressions of the face. There are occasional grimaces or some painful frowning is there, and there is frequent frowning, then it grades to 2. So another is the leg, normal position, relaxed movements and restless kicking like that. So it is grading into 2. Activity, child is calm and quiet, but this cannot be taken as a normal, but sometimes serious patients can be calm and quiet because of their hypoxia or because of their delirium state, so that you should not take this. So this has got its own limitations for this scale. So 0 means it is relaxed and comfortable, 1 to 3 is discomfort, 3 to 4 to 6 is moderate pain, and 7 to 10 is severe discomfort. Another scale is the state behavioral scale, SBS. Again, it has got scales from the -3 to +2. Again, this is a very complicated chart, but you can refer this for an analysis of the sedation. This is score. Another is the SAS score, that is Richmond Agitation Sedation Scale. So it has got -5 to +4. So when it is 0, it means child is alert and calm, and when you go to the plus stages, the child has become aggressive more and more, motility or the mobility components are more, but in case of -2, the child is getting sedated. So this is important for the assessment as well as using the level of sedation. So this is the most commonly accepted and followed sedation chart, that is the Richmond Agitation Score. It is not useful whenever the patient is having neuromuscular blocking agents are used, it is not useful. And it almost titrates all the patients with score of -2 to +4. Another is the SA score. SA score has got range from the 1 to 7, and lowest is the unarousable. So it is again when the patient is in deep sedation, and agitation and everything is the dangerous, or it is graded as a 7. So coming to the analgesics, as I mentioned, whenever there is pain, it has to be relieved. So there are different analyses that we are using on day-to-day practices. Commonly used are the NSAIDs. First and foremost is the paracetamol. Second is the NSAIDs. That these belong to the non-opioid medications. So paracetamol, we will have comparison between paracetamol and ibuprofen. Paracetamol is orally, per orally, intramuscular as well as IV as well as per rectally. NSAID in the form of ibuprofen, that is used as a per oral as well as IV. Dose for the paracetamol is 20 milligram per kg per day, and get to divide in 3 to 4 doses. And for brufen, it is 5 to 10 milligram. Maximum dose should not exceed 40 milligram. Mainly, though the paracetamol is better tolerated, but it has got its own limitation in the form of hepatic and renal injuries. And for the ibuprofen, it has got many side effects, especially in the ICU cases. But paracetamol has having more of an antipyretic action rather than the analgesic action. Analgesic it is little less as compared to the ibuprofen. So there was one heat trial, and it shows that there was intravenous paracetamol given for the, as a placebo to some patients and paracetamol given. So there is no any difference between the analgesic effect of paracetamol in this trial. Important is the side effects of the NSAIDs, especially in the ibuprofen. This is very important as far as PICU management is concerned when you are using ibuprofen as an analgesic agent. So mainly the bleeding, GI bleed, renal involvement in renal toxicity, hyperkalemia is the most common problem we can face when you are using ibuprofen. CNS has got dizziness, serious fluid retention is and edema, hypertension, then hematological thrombocytopenia is more common. Now coming to the opioid analgesics, these are the most commonly used and preferred analgesics. It's mainly the mechanism is at the different receptors, that is mu receptors, delta and kappa receptors. So there are three effects. One, the clinical effect is the analgesia, and another is the decrease the colonic transit time, and there is central analgesia as well as visceral nociceptive relations. So opioid analgesics may be one pure opioid that mainly acting on the mu receptors, and it can be the mixed agonist may be acting at the mu as well as the delta receptors. So but the commonly used are the analgesics that are used on the mu receptors. The common examples are the morphine, fentanyl, and a molecule of morphine is hydromorphine. So action is on the mostly on the mu receptors. Morphine is used as the most common drug. It is used as the IM as well as IV. Dosage is 0.1 to 0.2 milligram per kg per dose, and it can be used for both ventilated patients as well as non-ventilated patients. Another important is the fentanyl. It is acting on the mixed receptors. Its dose is 0.5 to 1 microgram per kg, and it is the infusion in the form of 1 to 4 microgram. And for this hydromorphine, it acts on the mu receptors, but its action is very fast. It is quick acting. The quick effect is within 5 minutes, and action lasts for 30 to 60 minutes. This is because of the plasma half-life is very short. Then adverse effects are for both morphine and this same are same. Especially the respiratory depression, increased sphincter tone, and it is what is shown that is limitation in the form of tolerance. But in case of fentanyl, the most common side effect is the chest wall rigidity, then glottic rigidity. This can compromise the airway situations when the patient is in the on the ventilator. So common side effects with the opioid analgesics are the pruritus, nausea, vomiting, and mainly the sphincter problems in the form of urinary retention. So when the patient is not catheterized, then you may find problems of getting retention of urine. So amongst all these, the fentanyl is the most commonly used and preferred choice of analgesic in opioid analgesics. So other fentanyl groups or the analogs are the sufentanil, alfentanil, and this is basically mainly the action is more, it is more 10 times more potent, and alfentanil is 5 to 10 times more potent. And then is the remifentanil, it is again 15 to 30 times more onset of rapid action. Now coming to sedation. Again, as I mentioned, when patient is in the ICU, again patient is irritable because of his own problems, then tachycardia is there. Again, if you don't sedate the patient, you have again hypoxia. So sedation is very important when we are managing the patients. So sedation is the depression of the patient's awareness to the environment and reduction of his or her responsiveness to the external stimulation. So medications that lead to a sense of calmness, it reduces the anxiety, fear, helplessness, and lack of sleep. So sedation is required for prolonged periods. From time to time, patients with ARDS, mechanical ventilation, traumatic brain injury. So sedation is very important part in patients with ICU. So depth has to be decided. If you don't decide the depth or you cannot assess the depth of the sedation, then you can your drugs or your sedation can itself land up into the problems. So minimal sedation, it helps only for anxiolysis. So moderate sedation, it is responsive to the minimum stimuli. Patient is little awake, we can respond to the stimulations, but and airway and ventilation is very maintained in patients with moderate sedation. But in deep sedation, response to the painful stimuli is lost, airway and ventilation is not maintained, they are compromised. And next is the general anesthesia. It is a state of unconsciousness and profound unresponsiveness. And last one is the dissociation, preventing higher center from the receiving the sensory stimuli totally. So in this situation, you will be in the trouble, patient will be at risk of life. So how do we use it? Whenever you are using sedation, patient allows you for tolerate the painful stimuli or procedures, especially even putting an IV cannula is a painful procedure. So most of the times we are neglecting, just put an IV line, patient is irritable, we are going similarly. So for that you have to reduce anxiety, you can explain that process, you can use all these things, and local anesthesia will be the spreading of the local anesthesia will be better for this putting an IV lines. So after that sedation can be given. Then you can, by using this sedation, you can reduce the oxygen consumption, especially it's very important as far as sepsis is concerned. And it reduces the helps to decrease the intracranial pressure. And again, agitation is a very important component. With sedation, you can reduce the agitation and patient will be a little more cooperative for your procedures. So sedating drugs are the mainly we know, that is diazepam. This is mainly the benzodiazepines, and they act at the different levels at the GABA receptors. And with comparison of all these main three drugs, diazepam, lorazepam and midazolam, I will go into the details for the comparative drug doses. These benzodiazepines are mainly acting on the alpha 2 gamma receptors. Then ketamine, it is again acting at the pencyclidine and ketamine are useful at the glycine level. Then these are the PCDX and haloperidol, they block the D2 receptors and blocks the H1 as well as M1 receptors. Then these are the next sedating agents, that is morphine, fentanyl. Again this comparison I will show in the chart form. So coming to the benzodiazepines, so diazepam, midazolam and lorazepam. Dose for the diazepam is 0.1 to 0.4 milligram per kg IV, and its action is within 5 to 10 minutes, and duration of action is for longer time because its half-life is more. So, but nowadays nobody is preferring, but because most important is the respiratory depression for these side effects. Then nowadays preferred is the lorazepam, which is short acting, it is very fast acting, and the action duration of action is for only 2 to 6 hours, 1 to 2 hours. And again, when you want longer duration of sedation, midazolam is the preferred drug of choice, and the dose for midazolam is 0.1 to 0.0 milligram per kg, and it can be given multiple routes, that is IV, then nasal, oral as well as, and infusion rate is 1 to 2 micrograms, and you can increase to around 5 micrograms also. So coming to the barbiturates, these are neither anxiolytics nor analgesics. So in the barbiturate group, the most important is the phenobarbital and pentobarbital drugs. So the important drug that is used as a sedation is the propofol. It has got very ultra short acting and sedative action. It is associated with amnesia and activity. It has got no analgesic properties, and action of onset of action is within minutes, and it lasts for only hardly 5 to 10 minutes. And once the drug is stopped, patient effect is being within 15 minutes. But it has got its limitations. It has got side effects in the form of hypotension and bradycardia, and propofol infusion syndrome, which is associated with metabolic acidosis, and high doses of in combination they are given with the catecholamines, and associated with metabolic acidosis is the hyperbilirubinemia, hyperkalemia and rhabdomyolysis, and that can cause cardiac complications and hypotension, and again it can precipitate the shock. So dose for propofol is the 2 to 3 milligram per kg. And important information while using the propofol, once the propofol vial is opened, you cannot use for the second time, because it is very, infection is very common when you are using the propofol. So next is the ketamine. Ketamine is the best drug again, but it is useful for very limited situations. It causes both sedation, amnesia and analgesia. It has got all the three effects. It is metabolized by the liver and kidney. And mainly the tolerance is present, but there are no any side effects in the form of no withdrawal or dependence. And for this ketamine, the side effects are the mainly salivation, laryngospasm, agitation, and it lowers the seizure threshold. And it is helpful for reducing the intracranial pressure also. So dose for ketamine in the form of analgesia and sedation is 1 to 2 milligram per kg. It can be given IM also, and infusion is at that is 1 to 4 micrograms per kg per hour. So other analgesic and combined action is the dexmedetomidine. It provides sedation as well as analgesia. It is preferred in as everything. It is preferred in PICUs for using sedation, analgesia, hemodynamic management, and airway management ICU. So there are once sedation trials for non-sedation trials, that is no sedation or light sedation in critically ill patient with a mechanical ventilation patients. So sedation during mechanical ventilation improves patient comfort and may help ventilator synchronization. So however, prolonged and deep sedation has significant side effects, including increased duration of mechanical ventilation impaired to the neuromuscular function. So this was a non-sedation trial, and this shows in the sedation group, only sedation after non-pharmacological analgesic has failed, but in sedation group, routine sedation and propofol and midazolam aimed for the, but ultimate result was no significant difference between no sedation and light sedation. So these are the results. Another trial for this sedation was taken as a SPICE-3 trials. In this, it was use of dexmedetomidine as the primary sedative agent compared to the usual sedating agents effect, and its long-term mortality after 90 days mortality. So it was again a RCT trial. So there was again the outcome, the final outcome was there was no difference between the dexmedetomidine versus the usual daycare mortality for 90 days. And for this adverse effects, just 1 minute. Adverse effects, as usual care others, mainly the bradycardia and hypotension were the most commonest side effects. 1 minute.
Thank you, Dr. Dayanand Nakate. Another phenomenon that is seldom thought of in intensive care is macrophage activation syndrome. I call upon the master, Dr. Vijay Vishwanathan, to help us master this condition.
There is one announcement. There will be after the validatory function, Dr. Hiren Panwala is going to talk an extempore talk on neuroimaging in pediatrics. So those who are interested can attend after this. Over to you, Doctor.
I thought you were going to say that you are allowed 3 minutes lesser than what you normally exceed. You are on time. Good to know that. Where's my talk? So I thank IIP Solapur for calling me in this nice weather from Mumbai, and the topic was HLH, and I'm like, what does HLH, what's there to be learnt from, and why me? Then I realized HLH can actually stand for hardly working. The hardly working guy comes and talks to hard working guys, the pediatricians and intensivists. So I like this quote because I think all of us start our Monday morning OPD with this kind of a principle in life, that jo bhi main karega, it's more of an art, and the science part is probably not so important. At least when it comes to our immune system, we can be reasonably sure that, whatever come what may, this will take care of most of the bad bugs that enter our body. At least this was the story till before COVID, where we all believed in, free hugs. Incidentally, last Saturday was International Free Hugs Day. And yesterday was International Rum Day. I don't know why Google sends me reminders, which explains why quite a few seats are empty, I think. And we've got used to these friendly hugs all throughout, and life was moving towards prosperity. But sometimes, off late, post-COVID and very recently, there are some hugs which causes a lot of grief to some people. That's where we are coming from. A happy macrophage just becomes an activated macrophage and creates havoc. And while we talk about the only time when the hardly working rheumatologist becomes activated is when you're dealing with these circumstances. And the next 3 months, I'm sure all of you, whether you are a student, whether you are a generalist, whether you are an intensivist, are going to see these kids, because June, July, August is the only time I enter ICU more than normal. And this was 2 kids who was admitted in Jupiter ICU last year. Any prizes for guessing which one survived? One kid did not make it. The kid on the left of my screen is a 6-year-old girl who has encephalopathy following fever for 8 days, test positive for dengue, and the reports are as given, CRP 200, cytopenias, dengue positive, and the label given was dengue associated hepatitis. The ferritin was 3,500 and the SGPTs 80, then 350, then 800, then 2,200, and deranged clotting profile. And then the diagnosis was this because was not fitting criteria. And the other one was quite, it was a known patient of mine who also had dengue and a Vidal which was done which was positive. So dual hit on a background hit. Reports are very, very similar, and this time the ferritin is 15,000. SGOT, PT 3,500, 200, just mark the ESR not done. So all of you will start sending ESRs if you haven't yet. And then all these labels were given by the intensive care: hepatic enceph, query HLH, MODS, SIRS, septic shock. Which one survived, do you think? This one survived? Well, ferritin is 15,000, no? Because I am throwing a googly and you guys know how to bat. So why do you think I have shown you this? We'll revisit this slide if time permits in the end, or even otherwise we'll talk about it. So let's go. So why the need for a lecture on HLH and MAS? Most of us know what it is, right? So the issue starts with nomenclature. So from today onwards, you will not see if you can give it a name, but how do you give it a name when you don't have relevant criteria which fulfills it? And many a times, MAS and HLH is an evolving diagnosis, and how rapidly it will evolve and do you have time before it progresses and worsens is anybody's guess. There are specific time points. Dr. Dalwai highlighted the point about not just saving the life, but it always starts with saving the life when it comes to these situations. And then you really know that maximum benefit depends on timely intervention. And so I thought what we should I should be sharing with you is this new guidelines which has come. The European League Against Rheumatism and the American College of Rheumatology Association has come with a set of guidelines for picking up early cases of MAS. So what's HLH and what's MAS? MAS is any HLH which probably has a secondary cause. You don't need to think beyond that, right? Because most of the clinical features and lab features do overlap. And this is a very nice art document which came out, and it had 14 rheumatologists and 3 intensivists in the people in the committee which proposed this, and these were called not guidelines but points to consider. And one thing I like about it is, barring 1 or 2 points, all of them have 5C, 5D level evidence. Means not only us, the whole world has lots of experience but hardly any evidence, how to manage these kids. So I thought let's start with this. So first of all, cytokine storm syndromes. What unifies HLH and MAS is the term cytokine storm. We are all more than familiar since COVID, and we started listening to all these terms, SJI, MAS, you have a familial HLH, you have COVID causing MIACs, you have malignancies coming and creating similar problems. And then if you ask any rheumatologist, he will probably say that what we actually are bothering about is a tip of the iceberg. And most of the rheumatology people feel that all these other words, MODS, SIRS, culture negative, septic shock, etc., are some variants of the same pathological process. So in an ideal world, you will probably not bother about calling them a name and start thinking about what is to be done. If it was in my hands, I would have called it HLH bhi nahi, MAS bhi nahi, usko Hamas bolte hain. That's the flavor of the season. But then thankfully I was not in the committee, so they decided to put an end to the controversy and label it HLH MAS, right? So, and they defined this term HLH MAS as a condition which incorporates all the recognizable clinical and lab patterns which are associated with all these conditions that the ICU will throw at us. The next term they introduced was this SH. So I want all of you to remember this word, systemic hyperinflammation, which is a state of excess immune activation predisposing a child to any of these things. And the third thing, they went on to say that these are probably the three main etiologies which can trigger off a systemic hyperinflammation and eventually an HLH mass-like story. And then, recognizing this urgency in diagnosing and managing, they came up with these 6 overarching principles. So, what are the clinical patterns that you will start thinking to label a SH versus HLH MAS? So, systemic inflammation is getting reflected by fever, a very high CRP and high LDH, hyperferritinemia, cytopenias, so low platelet count, we are all aware of low hemoglobin, low counts, DIC, so coagulopathy, deranged PT, INR and a low fibrinogen, liver dysfunction in the form of hepatomegaly and transaminitis, splenomegaly, and most importantly, a lot of stress has been given on CNS dysfunction. So I'm sure all of you would be seeing a lot of children coming with encephalopathy. So any unexplained occurrence of all of this or any of this, remember HLH, remember HCH, that's an easy way. H for hepato, C for CNS, H for hemato. If you get these three with inflamed markers, start thinking in terms of a systemic hyperinflammation, potentially leading to a MAS-like situation. So what they said was, individually, each one of them looks very non-specific, but when you collate all of them together, then you start making sense that you may be dealing with a long-term inflammatory process. SH and HLH MAS associated with predisposing conditions warrant a high index of suspicion. So if you are treating a child of a dengue or a mycoplasma or a rickettsia in Solapur, if the child is not getting better in 6-7 days and the fever is actually going up, start thinking, am I dealing with an inflammatory complication of a known infection, right? And then obviously there is, you have to treat them while investigating urgently, because saving the life is important, but at the same time, you probably should not be compromising on the adverse effects of either the diagnosis or hiding a potential malignancy, etc. So, bottom line was, be proactive, not reactive, right? So, do all the tests. So, this is the points to consider, right? So, once you start recognizing them, only then can you screen and treat. So it's kind of a repetition of the same thing. When you have an unusual, unexpected, severe co-occurring, clinical and labs. So the clinical I told you, HCH, persistent fever, CNS dysfunction, splenomegaly, cytopenias, and rising ferritin with hepatic dysfunction. So the guideline says that when you are suspecting this, please get a ferritin checked, which we always do. The problem is, if your first ferritin comes a bit borderline and your index of suspicion is high, please repeat it, because it is going to go up. Because the kid who died on the first slide, the first ferritin was 3,500, and when I got to see the child with a SGPT of 2,200, I just repeated a ferritin. The कॉन्टेस्टिंग इश्यू वॉज कालच केला आहे ना, 3,500च आहे, आता किती झालं असेल मला करून बघा, 35,000 आला, राईट? सो इट इज अ डायनॅमिक प्रोसेस अँड यू नीड टू बी स्लाइटली प्रोएक्टिव when it comes to treating these kids, correct? And then when you send the blood test for HLH, I always keep stressing that please send everything at the same time, not the time for cost cutting. So when you have an MAS, HLH scenario, CBC, SR, CRP, SGPT, creatinine, LDH, triglycerides, ferritin, fibrinogen, stick it in front of the mirror on the washroom while brushing the teeth is what I teach my students. This has to be done at the same time. What happens is ferritin gets sent, फिर परसों का ferritin, आज का सब्जी, आने वाले कल का rice. Doesn't make sense. HLH MAS is a dynamic process. You have to figure out, like your renal tubular acidosis workup, एक साथ सब भेजो. That makes sense. Where is the future headed? We now know that the problem in HLH is macrophage is getting activated and CD10 lymphocytes and your natural killer cells are faulty. So you started monitoring interleukin-2 receptor alpha, which reflects your T lymphocytes. You started checking for chemokines and interleukin-18, which are quite reflective of the process that's happening inside, right? So this is in the pipeline. I'll move quickly because we've taught a message. A lot of criteria for measuring, we keep on upgrading the criteria again and again. And then, lots of each of these criteria, like the clinical features, are very good for individual diseases, but across the context, it doesn't hold good. So what do I rely upon is only this. So this is the only picture you need to take home, and just rely on a simple ferritin ESR ratio. A dropping ESR is going to be suggestive of a falling fibrinogen. So a ferritin to ESR ratio of 21.5, these are across various studies, is almost 80% specific that you may be looking at a potential systemic hyperinflammation. There is a lot of emphasis in the guidelines for CNS involvement, and one of the poor prognostic markers in this is encephalopathy. I remember long time back, someone had presented a macrophage activation syndrome or HLH by doing a brain biopsy. It was a neurologist, but if you ask any rheumatologist, it's a no-brainer because your fixed monocytes or your fixed macrophages can be the glial cells, can be mesangial cells, can be Kupffer cells, can be alveolar macrophages, so they are omnipresent. So I won't be surprised why you needed to do a brain biopsy to document an HLH, correct? So encephalopathy can possibly mean that this child has got, so you will have this 105 fevers, 104 fevers in your ICU, and mostly central fevers, and nothing else is happening. I remember seeing a child who was having fever for 15 days with headache, and that was the week when I visited that ICU 4 times, and I didn't get to see this child. And the 15th day, I'm wondering why this fever and headache is in the ICU. I get a call from the pediatrician, how many times have you sent a ferritin in a headache? I said, why do you ask? No, the kid on the first bed actually died. I said, before dying, we collected a ferritin, and that ferritin came 5,000. So anything which is unexplained, all it needs is just send a ferritin. You may not act on it, but it is a marker of CNS involvement, right? Underlying malignancy is always a problem because don't just rely on a peripheral smear, please do a bone marrow and or a PET CT scan because lymphomas do not come up on the marrows, especially if you are planning to pulse this kid, right? So CNS is an important prognostic marker, but having said that, it doesn't mean that you should be delaying any immunomodulatory therapy. The most important is how do I treat these kids? So when do I start thinking of treating? If there is persistent, severe worsening MAS or HLH, the choice has to balance progression versus avoiding missing a malignancy or an active infection. Initial empirical immunomodulatory therapy, lots of published data throws its weight behind giving steroids. And I'll talk about another drug. And supportive care, obviously all the intensivists are always there to help us. So your IV fluids and plasmas and vitamin K and antimicrobials, etc. Right? And this is just in a nutshell. We have a viral infection triggering it or a systemic GI triggering HLH. By virtue of the disease, all the cytokines are activated. Important is the IL-1 and IL-18 family. You have a CD8 and natural killer cells. These are supposed to work in synchrony with the macrophages like we know. But due to some defects in perforin, granzyme that we've known of, these two things become useless. So while they promise to get in a lot, they are not functioning to their optimal. Without realizing, they keep getting a lot of other useless CD8 and NK cells, and all it does is increases the cytokines and activation of macrophage. This is a nice slide to understand what exactly happens. You have a macrophage which is left activated without getting help from this, and these cytokines keep exaggerating the inflammatory milieu. So not surprisingly, these are the targets where the drugs could potentially act. So for starters, yeah, rheumatology है तो steroids तो देना ही है. So the idea is first you suspect SH, document HLH MAS, rule out or work up for infections, ruling out malignancies should happen in the first 2 to 3 days maximum. And then you have to be proactive in giving steroids. You have to be proactive in giving drugs called anakinra. So I'll talk to you about anakinra in a while. But steroid is probably, the story. And then the usual question is, I'm glad that there are no hematologists here because DEXA versus MPS has always been a headache. Most rheumatologists will believe in MPS or methylprednisolone, whereas the hemats will always start with DEXA. How do we decide? So all of you would probably take this again because this, especially PGs, you should not attend the exam without knowing the iron. In pharmacology they used to say iron pade bina pharma ka exam mat dena, steroids ke bina you will at least not set into practice. This is an equivalent conversion doses. So 0.75 of DEXA equals 4 of methylpred equals 5. So methylpred pred deflazacort is easy, 4, 5, 6 and 0.75 of DEXA. Now DEXA versus methylpred, between the two how do I choose, right? So remember it all boils down to the half-life. DEXA is long acting but takes a while to work, half-life 72 hours. Methylpred, medium acting, rapidly gets in, rapidly gets out. So in a situation of HLH-MS, you will probably err on the side of MPS. Not because I told you, because of science behind it, right? अब 2 से की 10 से की 30 से is another headache since COVID, right? अब 2 से देने का, so it is not about the numbers, it is about the rapidity. If you calculate actual 2 mg versus 10 mg and 30 mg, it is more than 2 mg per kg oral prednisolone dose. The 2 mg per kg of methylpred. So where I come from is the methylpred pulse acts through the non-genomic mechanism. So it works at a membrane level, it gets in fast, starts the action starts within minutes. Whereas the genomic conventional, the steroid enters the nucleus, transcription increases protein, takes a while. So genomic is low dose. You can use it in general rheumatology or some asthma-like illness. When it calls for urgency of HLH and MS, you will definitely go ahead with the non-genomic pulse, and that is 10 to 30 mg, at least a 10 mg per kg till you get your infection and malignancies sorted. Almost done, 3-4 slides. This is a drug that I want to sell to intensivists because unless intensivists start using anakinra, how many of you have heard of anakinra? I am surprised. How many of you are using it? You are? Of course. But it's so unless the intensivists start using anakinra, गरीब बेचारा pediatric rheumatologist को ये नहीं मिलता. It's not available freely. You have to get it imported, and a 100 mg vial or a PFS will probably cost you about 8 to 15,000 depending on which city you live. Why am I trying to be? This is giving me a bit of palpitations. Hey, timer kada na. So anakinra, the actual work on anakinra started in 2015-16, where lots of reports, people started digging out retrospective papers, and this was the earliest paper in 2020, where they studied 44 children with secondary HLH, and the pre-treatment ferritin levels from 33,000 started dropping to 14,435. And they found in the process that post-rheumatic diseases, HLH or MAS, does better than infection, which does better than a malignancy. So at least in the post-infectious group, if the intensive care starts using it, somewhere the hospitals would probably be in a position to stock it for an emergency use. And the dosing is so varied, 2 mg to 10 mg per kg, and it's a wonder drug because all the studies say that it is efficacious and it is good, it scores good on safety profile also. The key is, however, to start early. So if I have steroids and anakinra, like in Kawasaki use IVIG and steroids, probably you might be able to save more lives. How many of you have seen this movie? If not, you go and see this movie, the Lazarus effect. How many of you know what this Lazarus effect is? It's about bringing life to a dead person. Jesus had brought Lazarus up to life. Why am I showing you this? There's a nice paper which was called Lazarus effect. So I'll tell you the paper first. This was a 9-year-old girl who had non-familial HLH with sepsis and pancytopenia with total WBCs 880, platelets 27,000, CRP 188 and ESR 1, right? And obviously sick child with LDH 6,900, ferritin was 1,92,000. This child was pulsed methylprednisolone and Mero, Tico, IVIG, whatever you can throw the potential kitchen sink. She started growing a fungus. And then the rheumatologist said, start anakinra, right? And then she was started with 12 mg per kg. The starting dose is 2 mg per kg. And then she kept on worsening. Despite anakinra, they switched to Dexa because she had a seizure, and then MRI was bang normal, interestingly, but not surprisingly, right? She had fixed dilated pupils and a flat EEG. And they were almost discussing withdrawal of support. And we'll say, Gaya. But then something struck them and they gave anakinra. If she has to die, let's jack up the dose and see what happens. And this inspiration came from the neurologists who use anakinra in a condition called FIRES, febrile inflammation induced encephalopathy, and they found that, and even subarachnoid hemorrhages, to reduce the inflammation across the meninges, IL-1 blockers help. And they just jacked it up to 48 mg per kg per day, and within 36 hours there was a chamatkar. 36 hours she showed a recovery, and they could taper anakinra over 4 weeks. All she had was mild global volume loss on MRI, which is, I think, the PICU ISI mudra. But she recovered full cognition, which is sound. And the movie is simple. This boy and girl, they create a potent serum to get the dead alive. And in the process, this girl gets electrocuted and she dies. This man gets her alive with using the same medicine. And then she comes back to life. And then she comes back with even more energy. She becomes nasty. She says she had gone to hell. She remembers all that she had done. She set a building on fire, etc., etc. So that's a Marathi movie, where that man can start hearing what's happening around, something like that. But the idea is simple. The paper caught my eye. This looks difficult to be believed, but then it's in Lancet. So I don't know how many of you believe in Lancet, but the same group actually published another series of cases on anakinra, further series, and all of them pointed to definite safety, albeit a lot of case reports. But the only thing is, in rheumatology, definitely I know when to use it, but I can't because it's not available. And 10,000 rupees is for one PFS. And the condition is you have to import 30 at one shot. So if I have an ICU guy who's using it, I could do a 1/2 manchav soup and something like that, and I think we could save a lot more lives. So give it a thought, and if you need anything about anakinra, let me know. Perfect. Last 2 slides are on the future. We knew that interferon gamma is a major player. Again, not available in the country, but extremely good results in emapalumab, which is an interferon gamma binding protein. I'll skip this for want of time. It's been approved for recurrent, worsening and refractory HLH. There are drugs which are in the pipeline. Interleukin blockade has also been tried. And the last is obviously, this is a drug which I don't think is available, but we have other tofacitinib and other JAK inhibitors. So some other day we'll keep the JAK inhibition for a different talk. So along with steroids and anakinra are the only 2 things I want you to take home. But the key message is simple. You have to suspect SH, diagnose HLH MAS, assess using all of them at the same time, investigate to rule out infection and malignancy, support And then while you are awaiting the malignancy and infection, start treating and hitting hard with glucocorticoids with some luxury, anakinra hopefully sooner. And then you keep monitoring regularly. There are, if you go through the guidelines, there are some tests you do daily, some tests once in 3-4 days, with reasonable clarity they have given. And then obviously once you zero in on the diagnosis, the rheumatic MAS goes on to steroids and anakinra. The post EBV will probably go on to a CD20 blocker like a rituximab. A primary HLH still continues to be treated like the original HLH 2004 protocol. Malignancies is a different ball game. Get the oncologists involved because generally they are not great to have. And infection is the commonest situation which I think all of you would be facing in the next 3-4 months. Potentially dengue, etc. So think about it. I promise, last slide. I have 2-3 more, but this is the take home message. HLH hai ki leukemia hai ki mass hai is not your headache. The easiest way I remember is, remember H for HLH, H for hemat. So anything which starts with an H probably starts from the bone marrow. So every time you will think of an HLH, I think some people are very blessed in life. Cancer starting count is 5,000 asto. So leukemia ka 5,000 becoming 2,000 is easy. Unfortunate human beings like us who have WBCs of 25,000 and 30,000 to begin with, by the time it satisfies the criteria, it becomes a problem. So you have to really think hard and don't rely on a PS alone to diagnose a leukemia, number one, and don't rely on a marrow to diagnose macrophage activation. The marrow will be 100% positive in all HLH because the disease starts in the marrow. My diseases can start in the brain, liver, spleen. So if the marrow is normal but the index of suspicion is high, please don't rely on a marrow. You can do a brain biopsy if you have a McDreamy around you. How many of you are followers of Grey's Anatomy? Only one, no? All of them are generation X or nanos. This is your homework, post-test. I'm sure many of you have seen this slide. It's an old slide. This is a child who's running fever for 7 days. HB10, 25,000, platelets, 7 lakhs. And he comes, how many of you are, this gets subjected to usual blood culture, CBC, VBC, antibiotic shuru ho gaya. Fever persists and the patient from Dr. Ashutosh comes to Dr. Atul. I can take his name because he just walked out of the room. Right? And then this patient doesn't get better with him also, and then he ends up here. How many of you are happy to have this child? How many of you are happy to have this child? This one, no? Why do you say so? So just remember, in rheumatology, everything going in one direction, you should be happy. For the time being, I generally ignore that most Indians are going to be anemic for whatever reasons. White cell counts, platelets going in one direction, I am happy. How do you think we can solve this gutti? You can answer, you heard me 100 times, no? 2 tests which will help me sort out this mystery. You stop giving me a residency of Solapur, no? Both sikha diya. You know, life is so sorted with these 3 tests, you know. सगळं वाढत चाललंय, ESR, CRP पण वाढलंय, म्हणजे systemic inflammation. You are probably dealing with a systemic JIA or a vasculitis or a Kawasaki, probably. So, you know, the problem is this, because many of you will inherit this situation, which looks seemingly normal at the first glance. But when you look here, this is a 50% drop. This is a significant drop. ESR has dropped. CRP is more or less same. But then the child is not better. If your ESR is dropping, child is better, we are happy. This child is getting sicker. And then obviously this is a situation where you don't want to reach. So this in rheumatology, is called as a inflammatory phase or occult macrophage activation. Means if you do a marrow, you may find kana koprayat macrophages activating, but not very, you know, on the face. This is a bit tricky, you know, where there is progression of the disease and it is more than kana koprayat, and you are inviting trouble if you don't pay attention to it, because it will give you signs, but you will take a while to understand what it's telling you. This is probably you have missed the bus because this is the last stage. So if it looks right but feels wrong, this looks okay but kuch to gadbad hai na, start thinking about it. Sorry, last. This is again an exam for you because this is your next 3 months. 5-year-old girl who has dengue, 9-year-old girl who has increasing fever gets proven to be enteric, and this is Solapur special, rickettsia. All the 3 have proven diagnosis but not getting better. What will you do? हर बार थोड़ी होता है बाबा, भेजेगा, but then the working diagnosis is ESR and CRP is because you want to rule out HLH, because a dengue can go to HLH, rickettsia can go to HLH, and enteric obviously we can go to HLH. So how do you act, right? So the dengue obviously you will wait and watch for divine intervention. Enteric you may add azithromycin. The rickettsia you will send a PCR and probably Vilfelix and or doxycycline, right? What is more important from my perspective is send the full mass workup. While you decide to wait, add azithro or doxy, send the whole workup. Most likely, wait and watch will help, azithro will work, doxy will work, 48 hours, fever and ferritin gone, you are happy. But at least I am proving that, this is like, I use the example of POK. Patient gela, POK la, ani paratala. That's self-recovering post-infectious MAS. Most of these infections would recover on their own or with intensify, like nephrotic. Treat the infection, proteinuria better, right? But then a few of them definitely will keep on worsening. Instead of falling, fever will continue, ferritin will continue. This is an indication for intensifying and using steroids. So the message here is send everything and then don't do anything. It's not that Vijay hai to steroid do. At least I have done the basic workup because you don't want a surprise in the end. And just remember that when you are managing MAS or HLH, fever and ferritin comes down fastest. The others like fibrinogen, triglycerides will go up and then come down at their own speed. So if my fever and ferritin is coming down and the child is clinically better, you have succeeded. This is just a list of what are the infections which most of us are aware of. And post-infectious, treat the infection, do the workup, wait and watch is the message. The best example was this kid where intensivist and the pediatrician and the rheumatologist can work together to save a life. This kid actually was shifted from Nasik by a pediatrician who I normally address as antigen presenting cells. Parmanand, I address him as a toll-like receptor. So the antigen presenting cell comes and hits the intensivist. He gets a call कि ऐसा सब है, BNP 25,000, ferritin 2,000. Parmanand rings me up and says, shock मध्ये आहे, क्या करना है? दे दो methylpred, दे दो, बुला लो Jupiter. And she had systemic hyperinflammation written all over her face. And this was during the best example of this early HLH that I keep talking about was a condition called MISC. All of us are familiar with MISC and other than hardly everything was MISC in those days, right? So see the difference. By the time she reached Jupiter with one pulse, she was stable. We gave her IVIG and this was her course. And she responded within 10 days and this is magic. And the idea of being slightly proactive and, forget the infections. You are not forgetting it, you are just covering the infections and this is the magic which can happen in just 1 week, right? So this girl shares her birthday with me, as it turns out, interestingly. Perfect. So HLH ki MAS, let's call it HLH MAS. The key word is systemic hyperinflammation, early recognition of clinical patterns, less reliance on criteria, start treatment while initiating workup, address contributors, rule out malignancies. Importantly, steroids still work if used early and in a proper dose. In rheumatology, there is scope of cyclosporin, but anakinra should probably be the way forward. And it's more about being proactive than reactive. This is just a tribute to Parmanand, who's been a dear friend and has had a loss. This is for the PGs. जिसको मैंने जो बोला कुछ भी नहीं समझा, if you can make sense of this slide. This explains the pathophysiology of MAS. Who can explain it to me? I know I'm 3 minutes over. See, this is a virus. If the macrophage T lymphocyte NK cells would have decided amongst themselves and planned an attack, this systemic inflammation would not have happened. I'm referring to the last scene of Sholay. I have seen Sholay 25 times with the only hope that Amitabh Bachchan gets some help or some extra bullets and he gets saved from what happened eventually. But so the story is, this guy Bichara gets trapped in this scenario where he's hoping that these lymphocytes and NK cells come, because they promise to come with a lot of ammunitions and etc. But for some reason this is a useless T cell. This is more busy chasing Hema Malini or the coin, whatever. So all it keeps on doing is cytokine, aggression, 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 and the rest we all know. In the process, he loses his life. So Jay losing his life makes Vijay very unhappy. So that's the story. For me, SH in Sholay only means this. So after this, I have to go and get my share of SH, which is Nasle Bandhu Shenga Chutney. It's a paradox, no? Nasle is definitely Asle in Solapur. So rheumatology does exist in day-to-day practice. Just keep an eye and an ear to things happening around you. I'm so sorry for taking so long, but
Thank you for the excellent talk, Dr. Vijay Vishwanathan. I request chairpersons Dr. D.S. Thite, Dr. Honmane, and speakers Dr. Dayanand Nakate, Dr. Sameer Dalwai, and Dr. Vijay Vishwanathan to proceed for the felicitation. Managing critically ill children is very stressful. We need a friend to rely on at any time for anything and anywhere. Ultrasound is one such reliable friend. It bails you out provided you understand it well. Ladies and gentlemen, POCUS has become a necessity in PICU and is here to stay. For a case-based session, please welcome Dr. Vikram Hirakarur as the moderator, along with panelists Dr. Preeta Joshi, Dr. Vinay Joshi, and Dr. Neil Castellino.
Good afternoon, everyone, and I promise to be on time. So I welcome my star-studded panelists who have wealth of experience and knowledge and are working in very high-level tertiary care centers and are the best persons to give justice to this topic. Before I start, this is the word of caution that I would mention to you all, that before doing a POCUS, you should ask yourself a question: what answers do you want from the ultrasound study? This is a must, not a blind ultrasound study. This is our usual ICU scene with lot of tubes and lines in place, lots of monitors, and how in the world are you going to assess his heart, his lungs, his brain in this situation? These are our usual options, and you all know its limitations. So the quickest and the easiest way and the dependable one is the ultrasound machine. And what are the clinical scenarios that we often face? An infant presenting with CNS dysfunction, a patient with respiratory failure, for example, bronchiolitis or pneumonia, who is not responding to your usual line of treatment, a patient with circulatory failure who has not responded to your usual fluid management, a patient with dengue shock who is resuscitated, fluid overloaded, and is now referred to you for management. You are giving CPR and your patient is not responding in spite of correct measures, and you are ventilating a patient and you find that the patient was okay, but now as you are treating the patient along, the patient is deteriorating. And in high centers, it is also useful in post-cardiac surgery to diagnose low cardiac output states, but that what I won't be discussing. So let me discuss with you the routine scenarios that we face in our situation. So these are patients with CNS dysfunction, patients with respiratory distress in ICU, patients who are with hemodynamic instability, and patients, the common ones, pulmonary artery hypertension and PDA in NSU. So let me tell you how an image is formed on ultrasound. Ultrasound beam is projected inside the body, and depending on the structure's density, the ultrasound waves are either absorbed or reflected, and the machine interprets, or with its software, it will display this image on the screen. And these are the three important structures. This is the anechoic structure, which will be black in color. So always remember, anechoic will be black in color. On the opposite side, hyperechogenic will be white in color. And what are these structures? Fat, bone, and air. They are white in color, whereas urine, bile, cyst, blood, and CSF will be black in color. And in between will be the other different shades of the gray depending on the density of the organ. So this is the basic that I want all of you to follow to understand the future images. Then the images which are there in the top of the screen, they are superficial images. For example, liver in this case, you can see where I have placed the probe. And structures which are at the bottom of the screen, for example, here vertebra will be the posterior images. So let me start with a few case scenarios. So first will be a cranial ultrasound, and I would address this question to Dr. Preetha. So here I am having a full-term child, appropriate for gestational age, has suffered severe perinatal asphyxia, has HIE, convulsions, is on phenobarbital, phenytoin, levetiracetam, is on ventilator, has no spontaneous activity, though is hemodynamically stable, and a cranial ultrasound was done. And what do you expect in this study? So before I place the question to you, I want you to understand what is a normal sagittal view. So this is a normal sagittal view exactly in the center, and what we see here is a corpus callosum, the septum pellucidum, third ventricle, which will be black in color because it has fluid, the aqueduct of Sylvius, the fourth ventricle, and the cerebellum. So these are the simple structures that you should identify. Similarly, in the coronal view, in the midline will be corpus callosum. This is a trail track sign. The lateral horns of the ventricles, which are black in color. The sylvian feature, which is Y-shaped. Basal ganglia area near the, just in the paramedian area, where there will be a caudate nucleus, putamen, globus pallidus, and thalamus. Third ventricle, exactly in the midline, a dark line, which is black in color. This is the third ventricle. And you have a cerebellum, and above that is the tentorium cerebelli. So these are the simple structures on basis of which we will identify certain images. So this was the image of our patient, Dr. Preetha.
So before we start, I wanted to say first thing is that the modality of choice in hypoxic ischemic encephalopathy for neuroimaging is MRI. But of course, we would be not always, MRI might not be easily available, and therefore you have to go ahead and do an ultrasound. Here we can see there is some loss of gray-white differentiation, and there is also the sulci which are not that prominent. Secondly, there is the thalamus. If you can probably show it on the, the thalamus, which is looking little hypoechoic. So here I would be worried that, especially with the history, so like we said, put everything together with the history. With that history, I am now a little concerned, obviously, that we are seeing changes at thalamus level, so there is acute asphyxial changes. And I would, as soon as possible, get an MRI for this child.
So, but what are the findings in your this?
Again, we are seeing the basal ganglia involved in this as the coronal view as well. You can see the hypodense, hypoechoic areas, which are the caudate and the putamen. So we are seeing those areas involved. So this is again showing acute.
Yes. So our case, what we are dealing with is his brain is not normal, and there is edematous brain. You can see the hypoechoic areas here. Somewhere there is hypoechoic, somewhere there is hyperechoic. The gray matter, white matter differentiation is lost. You cannot define the areas of the capsulogangliar region, caudate nucleus, putamen, globus pallidus. These are the regions that you should normally see, and the ventricles are totally kinked. So these are the usual features of cerebral edema, and you know that what you are dealing with, and you can counsel the patient accordingly. So
And
these are the
sometimes-
simple signs of cerebral edema.
And sometimes in perineal asphyxia, you can see hemorrhages as well.
Yes.
And if there are significant hemorrhages, that you can easily pick up on sonography. I
Yes,
think
correct.
that one should look for.
So this was the next case. This is a NSU graduate, 27 weekers, SGA baby, was discharged and now presents at 5 weeks of age with lethargy, has not been feeding well since 4 days. Heart rate, respiratory rate are normal, is lethargic and blood sugar level is 24, there are no convulsions, and a cranial ultrasound was done.
So this child seems to have been presented with sepsis, but what I am seeing on the sonography is, again, if you can just point out, we are seeing areas of cystic involvement in the periventricular areas. This is typical of cystic periventricular leukomalacia, or we call it cystic PVL, and this can be appreciated in the sagittal view as well. And there is also an irregular shadow which is not typically like choroid plexus in the ventricle as well. So this could be there was an old hemorrhage which is now, since the child has come post discharge.
So that message is that even if you are discharging the child, make sure that you take a cranial ultrasound at 1 month of age, because you don't want to miss out on these things. Dr. Vinay, a full-term appropriate gestation was operated on day 3 for meningomyelocele repair, presents at 4 weeks of age with fever, has convulsions 1 hour before admission. Heart rate is, and yes, tachypneic, but heart rate is normal, capillary filling time is 1 second. AF is slightly bulging, lethargic, but relatives want to know what has happened to our child.
See, I think if you look at the history, the way the child has presented, the child has all the signs of infection and meningitis leading to raised intracranial pressure. You have slightly bulging fontanelle, child is lethargic, child had convulsions. So what you could be seeing is something related to the intracranial pathology where the pressures have gone up. And if you, so you have to always correlate your clinical findings with your sonography findings. Don't read sonographic findings separated from the clinic. So don't forget the patient when you are doing the sonography. So if you look at the images, what you see there, basically dilated ventricles, okay, and as you see, both the entry horns are hugely dilated, where there is debris inside, and then there is cyst within the cyst kind of picture, all right, and then all the ventricles, like both the anterior and posterior horns, and even the third ventricle is dilated.
So yes. So your impression of raised intracranial tension was justified, and a patient with fever. So this is what has happened. There was probably a shunt infection, and you can see the exudates inside the ventricles as well. So this was, now this shunt has got infected, and there is meningitis and ventriculitis in this space. So this has gone into now complications. But such patients coming at an odd time, you are not expecting at all. So that is how ultrasound helps you immediately in the diagnosis. Now quick for the audience. Can you see something here? I told you hyperechogenic. So this should be the third lateral ventricle area, and this is the hyperechogenic area in the. So this, yes, it is an intraventricular hemorrhage. This is a grade 1 hemorrhage. Similarly, this is also grade 1 hemorrhage. This is grade 3 hemorrhage with ventricular dilatation. There is dilatation as well, no? So there is dilatation of the ventricles as well. This one, this is echogenicity is here, so this is a parenchymal bleed. So this is a grade 4 hemorrhage. So even at admission, you can identify what situation you are in. This is a patient who is 4 weeks old, 4 months old, and has come with convulsions and fever. Can you identify something? So you can see that there is a gross midline shift, and you can see some echogenicities here. A patient 4-month-old coming with such symptoms is pale. What you should suspect is, pardon? Yeah, intracranial hemorrhage, but because of what? Yes? HDN, yes, late HDN or a vitamin K deficient coagulopathy. This is a child who had come with fever on day 2 or day 3 of life, had convulsions with left-sided focal seizures. Fever since 2 to 3 days. And this was the stark point, as pointed out, is there is a pallor and patient is drowsy and left focal seizures are there. That is what we had thought. So actually that was an infarct which was seen as in the ultrasound also. There was a echogenicity in the same area and we did a MRI and that was an infarct. So this was a stroke in this particular patient. That video is not running. Okay, so let us move ahead to the lung now. So that was CNS dysfunction. Now patient in respiratory distress. So this is a newborn child, operated case of esophageal atresia with TO fistula, and the surgeon has operated. There was a pneumothorax. He adjusted the ICD and then he sent the child up, and this is the picture. So you are happy with the X-ray? Yes? Okay. But this is the child. We are happy with the X-ray, but this is the child. Pardon? Yes, there is dyspnea, but we are not happy with the child. So we decided to do lung ultrasound, and just to brief you up, so this is the sonoanatomy. You can see that there is on skin, pectoralis major, ribs, intercostal spaces. And how do they look at on the ultrasound? You can see that this is a skin and soft tissue area. This hypoechoic area is the muscle. This black is the rib, and in between that you can see a white line, that is the pleural line, that is the pleura. So this is how we identify the structures on ultrasound. See the lung sliding. Can you appreciate the parietal pleura, vesical pleura sliding? There is a shimmering motion. You can identify this? Yes. And if you do an M mode, then what you see is the seashores. It is a sea and this is the sand. So this is a seashore sign. This is a normal lung. And it has got a negative. If you see these pictures, then it is a almost 100% that there is no pneumothorax. Now this is our child. So first our normal side was left side. So I will do on the left side first. You can see the lung sliding. You can appreciate the B lines. Now I will do on the opposite side. Can you see the lung sliding? You cannot see the lung sliding at all. Compare with the normal one. And there are no B lines. So this is a highly suggestive of pneumothorax. So we convinced the surgeon that you have to do something. This is still there is pneumothorax and our patient is symptomatic. So he said, okay, there must be some tissue which is obliterating the holes there inside the tube. So I will just put a bigger size tube. And he put the bigger size tube. Now you compare the two sides. So now you are seeing the lung sliding beautifully. And there is B lines as well. So that was a pneumothorax. And now see our patient. So always you have to correlate what you are seeing clinically. And another classical sign of pneumothorax is a stratosphere sign. Dr. Neil, this is for you. A 5-year-old child with fever since 7 days, breathlessness 2 days, there is lethargy, there is fever, heart rate of 120 per minute, respiratory rate of 56 per minute, breath sounds are reduced on the left side. There is a dull note on the left side and there is a bronchial breathing in the left interscapular area. This is the X-ray and an enthusiastic sonologist has done, and this is the ultrasound picture. So can you just explain?
So looking at that X-ray, we were first thinking, is it only a pneumonia, given that clinically we are having reduced breath sounds on the left side, bronchial breathing. So we're thinking an effusion in addition to a pneumonia, mixed findings. So we're doing a USG, looking at this, someone might think about directly putting a tube, etc., which may not be the best thing to do. When you look at doing a USG, we look at this, if you can point out, that crumpled tissue paper appearance, which seems to be there, which are looking like those small white pellets which are studded across. So that is something which is significant for a pneumonia. We cannot see any we remember fluid is anechoic, so we cannot see any significant area of anechoic collections superficially. So at least in this view, there doesn't look to be too much of an effusion.
Right. So what the white lines we see here are similar to the air bronchogram that we see in this X-ray. So this is a sonologic air bronchogram. This is another patient. This was also a patient of pneumonia. Can you see some findings here? So these are the white lines that are coming in and going, white spots that are coming in and going out. So these are labeled as a dynamic air bronchogram. So air bronchogram can be static, it can be dynamic. Here the surrounding lung has become inflamed, is consolidated, but the air is coming in and going out. So that is why you are seeing the air coming in and going out. This is a dynamic air bronchogram, which is another hallmark of pneumonia. Any other signs, Dr. Neil?
Like we remember in second year pathology, there is a stage of red hepatization, grey hepatization. So if you look at comparing, at least in basal pneumonias, etc., if how the lung looks like how the liver would look, as in it is a grey solid kind of a structure, then that is what we call hepatization. So that is a correlate of a lobar consolidation rather than a bronchopneumonic consolidation.
And another important sign, this red sign, where you can easily demarcate this line, which is the broken line, hyperechogenic, and is a division between the normal and the abnormal lung. So this was a simple pneumonia. Now this is another patient of pneumonia. Here what you can see is that there is a tissue-like sign, what Dr. Neil has said, but in addition to that, this is a black line now. Instead of the white line, this is a black line, and this is a fluid bronchogram. Instead of air, there is now fluid inside the airways, so this is called a fluid bronchogram, and you can see that this tissue is not homogeneous as there was in the previous. There are areas of hypoechoicness and echogenic areas both. So this tissue there is much destruction of the tissue here. So this is called a necrotizing pneumonia. Dr. Neil, what about pleural effusion? What are the classical signs of pleural effusion?
So one, we would look at it depending on how small or large it is. A small effusion is usually going to first start collecting posteriorly near the lung bases. So either way you look at using a simple IVC view, subcostal view, transverse, in which we'll be able to screen, and if you can point out on the screen over there, there is a bright line which is there off the diaphragm. The liver is there below that. Just above that you can see an anechoic collection. That is when the initial pleural effusion will first start collecting, and then there's a lung which is there beyond that. So if you screen both the lung bases, that is when you're going to pick up small amounts of effusions. If you look at putting a probe on the chest wall, as in doing a lung USG, you will look at this kind of a thing in which you can see the collapsed lung with an anechoic structure on top of that, which is floating or seems to be floating in the fluid. So that is an effusion.
And sometimes in a very large one, you can even identify the fissures as well. What about complicated pneumonias? Is it useful in complicated pneumonias?
You will start looking at some amount of what are fibrin strands which are going across that black anechoic collection. So this essentially tells you that it is a high cellular or a high protein containing fluid which is unlikely to be a transudate, and you should start thinking of an exudative effusion.
So whether your pneumonia is a simple pneumonia as in the previous case, whether it is associated with effusion, whether it is associated with empyema, and what line of management you should take at the outset, upfront, is what is ultrasound is going to tell you. So coming on to the next case, this case was 4, 5, 6 month old which presented with a classical case of pneumonia, was treated as pneumonia and did not improve as expected. And this was the ultrasound image. Just look at the look at the pointer where I have said probe I have kept. It is at the junction of the chest and abdomen, the lower back. So the marker is here, green. So just opposite the green marker there will be lung, and at the caudal end will be the liver, and in between somewhere will be the diaphragm. Okay. This is what we are going to identify. And now see what structures we are seeing. Dr. Pritha? Yeah, no, I think it is off. Take the other one.
As you can just see here on the left side, what you can see is the lung on this image. And then you can see the liver. Now what I see in that area is, as you can see, it's looking very heterogeneous.
Yes. The usual signs, lung signs we are not seeing.
Yeah, we are not seeing the usual B lines, now the A lines, we're seeing nothing of that sort. So here I am concerned, though the X-ray looked like probably there's a pneumonia and a pleural effusion or empyema, but here I am seeing a mass-like structure.
Yes. So it is very reassuring if you do the lung ultrasound. In the first case, it was simple pneumonia, and this is a similar case, but this is totally opposite diagnosis, which is very scary. This was a high-frequency probe that I had used, and you can see that the mass is consisting of lobules. This was a neuroblastoma, which we had referred ahead. Dr. Vinay, 34 equal respiratory distress treated as HMD. Surfactant was given at outside hospital. The respiratory distress persisted, so the referring pediatrician sent to us and for further care. This was the X-ray after one dose of surfactant.
I think what you can see, obviously, there is something in the right lower zone, and both lung volumes are significantly reduced, and that shadow is quite opaque. So I think we need to start thinking in terms of something. It doesn't look like hyaline membrane disease in the first place.
Correct. That is what the first thing that you should strike us. And just to let you know that how the lung zones are divided between the parasternal line, anterior axillary line and posterior axillary line into zone 1, zone 2, zone 3, zone 4, zone 5 and zone 6. Zone 5, zone 6 being posteriorly. So then why I am saying this? Because I have placed my probe in particular area. So this is RZ1 means right side zone 1, which is anterior. Now let us see what we find here. Dr. Vinay?
I can see some mass there.
And what about the lung sliding and B lines?
The lung slide is there.
So, but classical lung slide is not the shimmering motion. Lung sliding is that is not there. Yes, something some problem is there. So then I did a M mode, and now what you can see, the seashore sign is not seen, so it is replaced by
stratosphere sign.
Yeah, it is replaced by a stratosphere sign. So there is a pneumothorax up in the anterior region. Patient is lying down, and the air is going to come up. So there is a pneumothorax. But this is not the end of the story. So that was anteriorly. Then I went on the side, zone 3, zone 4. Now
again, what you see here is, there is a mass kind of thing which is floating, right? And there is a cystic lesion, what I see more of a shredding.
So this black is fluid. Yeah. Black is fluid. Whether it is cyst or not cyst, it is difficult to say on this ultrasound. But you can see can you see the air bronchogram here that I had shown? So there is a pneumonia.
See, it looks like more of a complicated pneumonia.
Yes, so this is a complicated pneumonia in a problem in the newborn. But beside this classical pneumonia, air bronchogram is still seen. And these airways are very close together as apart from these airways which are apart. So see, 2-3 pathologies are there in this case. Simple case that we thought was probably just pneumonia and probably thought was just an HMD. So we just
like
put
more of a consolidated, when we say the stage of consolidation, where you have, of course, it is complicated with empyema or the fluid around it, but the airways are completely, the surrounding parenchyma is completely collapsed.
Yes.
Some air bronchogram
is there. So part of the lung is collapsed, as you said, part of it is consolidated, there is fluid. So our surgeon said just I will tap to see what it is, and we could take out a very sticky fluid, gelatinous sticky fluid, not like the usual pleural effusion. So he said that probably this was a lung cyst which has now ruptured and giving to all complicated picture. This was case for Dr. Neil. This was a child, 5-year-old, who had injury on the right upper arm. He had an injury to the right upper arm, and after that the orthopedician took an X-ray of the right upper limb, and he said that he is absolutely all right, and he sent him home. But on day 3 he comes with fever and tachypnea now. Injury is on the right side, and this is the X-ray. So what is your initial impression on this X-ray?
So one thing which you're worried about post-trivial trauma is whether there is some kind of an infection which is flared up because of that, is one possibility. The second possibility is we always should be going back to the mechanism of injury. Whether the child fall only on that hand or was the entire torso impacted, to decide whether there could be something else like a bleed in the lung because of the trauma, some kind of, it was not very obvious, doesn't look very obvious in terms of rib fractures, but things like parenchymal hemorrhages, contusions, etc. is something which we should look out for to differentiate. Now this child also has got fever and tachypnea. So between both of those, the way we would want to look out is going back to history, where and how was the impact of the fall. Was it only on the hand or was the torso also affected, and then start looking from there.
Yes. So this is the opacity that you are seeing here. You say that it could be contusion or it could be pneumonia. It could be either. Great. So this child was admitted for fever and was being treated as for pneumonia, and this is the lung ultrasound. One is on the right lung, the other is on the left lung. I have put the zones also. Now what is your impression? See, right side was normal on X-ray.
So given how the density is on the X-ray, it doesn't seem to be matching with what our sonologic findings are over here. There is some areas of anechoic breakdown kind of a thing which is there, which tells us that there is likely to be some liquid content over there, rather than you cannot really appreciate a very good aeration of that part of the lung. So something in which potentially this is not looking like a very typical pneumonia pattern as well. Yes. So between both those differentials, I would think that this is looking a little more like a bleed or a contusion into the lung, rather than an infection.
Yes. So this patient we did not treat as pneumonia, we just gave him symptomatic treatment and sent him. So this was a simple lung contusion, but this was a coup and contricoup injury of the lung, which we were not expecting at all. Truthfully, this was the first case, and I was also baffled why I am seeing signs on the right side. So Dr. Pritha, this is a 3-year-old boy, fever, cough since 15 days, was again treated as pneumonia. There was no improvement thereafter in spite of good coverage of usual community acquired pneumonia organisms, and an ultrasound was done here. Mike.
Aware that something is not following the typical pneumonia pattern, so that again makes your tools more effective if you realize that you are looking for something. So then once you do the sonography, you are seeing this area which looks like a fluid filled cavity within the, this is a lung ultrasound, so you are seeing it within the lung. So you are worried here that you are dealing with either a lung, probably a lung abscess, or an infected cyst which was there already.
So this is not the usual pneumonia that I was expecting to see here. So this is a hypoechoic area, black in color, so there is fluid, and in between there are echogenic areas, so there are some flakes there. So this lung abscess was what we suspected, that Dr. Pritha said, and which was confirmed on the CT scan as well. So then our mode of line changed and we explained to the relatives and everything was okay. Dr. Vinay, this was a 7-year-old presented as upper respiratory tract infection, but has increasing respiratory distress on day 3 of starting antibiotics, required increasing oxygen by nasal prongs, and this was the chest X-ray.
I think by now it has developed into full-blown ARDS probably, and child may require intubation.
So what will be the classical features of ARDS?
You see all the signs, what you are seeing here, basically there is a pneumonia on the this thing, loss of, there is a lot of pleural thickening, there is subpleural pneumonia as you are seeing, and the most important finding what you see is there a collapsed consolidated lung below the pleura and multiple B lines. Now being as a part of the ARDS, you will see there is a lot of interstitial and pulmonary edema, and it will be reflected when you do the sonography, and according to you can tailor your fluid therapy, according to you tailor your ventilation, your PEEP strategies, etc.
And there will be multiple B lines. These are the vertical B lines. More the amount of fluid in the lungs, more will be the B lines. Now coming to hemodynamic assessment in shock. Dr. Neil, this is 1-year-old child, will go a little fast. The 1-year-old child with fever, diarrhea, warm extremities, hypovolemic shock, was treated as hypovolemia. 2 fluid boluses were given and it looks sick and tachypneic. How much fluids to give now? He has already received 2 boluses.
So clinically over here, I would be worried because fever and diarrhea both should make me fluid responsive and I should not hesitate to give fluids. But with giving boluses, I've already given boluses. I am still having a sick looking tachypneic child. So is the fluid leaking into the lung? Is there some issue over there? And the second thing is that the extremities are warm. So it may not be a simple diarrhea in which I expect a little bit more of cold extremities. There may be something else like a gram-negative thing going on in addition to just a simple diarrhea. So fluid may not be on a simple hypovolemic shock. I need to look for something else. So maybe sonography could help me there.
Yes, great evaluation, Dr. Neil. This is not a simple thing. So before gluing fluid, I want to see the IVC. So this is a normal patient. See the probe where I have placed. And this is the IVC. During inspiration, it collapses, and expiration, it distends. In inspiration, it collapses. Expiration, it distends. You can appreciate, all of you? Yeah. So now let us see what is happening in our patient. So what is your comment on IVC here?
Where is the IVC?
Yeah, so the IVC is totally collapsed. So this is the red marker that I have placed here. So the anterior and posterior walls of the IVC have come together, this casting a white line. And now this is 18 minutes after giving fluids. You can see check the timing also. These are real cases that I am showing you. And at odd hours, our brains don't work as fast as we would like them to. But this is how ultrasound helps us. So we did not hesitate to give more fluids. So IVC is now beginning to open up. And can you comment on the cardiac contractility?
Obviously this tachycardia is pretty obvious, and you can see this is what we call a parasternal long axis view. You can see that the free walls of the ventricles seem to be almost touching each other during systole. So you usually would have an ejection fraction of around 60%, and you should not have so much of fluid depletion that the walls seem to be touching each other. So that is suggestive of a severe intravascular fluid depletion.
Then we had a similar child with, but this is this presentation. So you can see the puffy face of this child and see this IVC. This I am showing you only for comparison. This IVC is full and there is no difference between inspiration and expiration. So this is a fully dilated IVC. So what is the interpretation? When there is a respiratory variation is increased, that means CVP is low. When the respiratory variation is decreased, that means the CVP is adequate and high, then you should not give fluids. But there is, again, this is not a sacrosanct equation. There will be the size of the IVC is an interplay between the external compressive intra-abdominal pressure and the internal distending venous pressure, right ventricular function and intrathoracic pressure relative to IVC. So all these things will matter. In general, small IVC may mean vasodilatory states and large IVC will mean a obstructive state. Then fluid responsiveness, whatever studies have been done until now have been done on mechanically ventilated patients with no spontaneous breathing, whereas our patients are spontaneously breathing. They are sedated patients in normal sinus rhythm, and we are having tachycardia here, and they have done all these studies on a tidal volume of 10 ml per kg. But in general, it is very easy and useful way to assess fluid, and trends are useful. And these are all limitations. So whenever you are assessing the IVC, you must take care of all this. So this is another case for Dr. Preetha, 4-month-old, previously healthy, received vaccination at day prior, was absolutely healthy. Just day prior received vaccination, there was fever, breathlessness and lethargy. But he was pulseless when he came to admission, heart rate of 160, cold extremities, liver of 4 centimeters, and relatives are not happy with your colleague because they gave vaccination only yesterday. So this is the child. You can see how sick it is. Now what would you like to do? Can you comment on the IVC?
Yeah, I would like you to just go back once onto the history slide. So, like we always say, put a lot of emphasis on this. First thought is of course shock, but here we are not dealing with, whilst you can see the liver is 4 centimeters within a day of presentation. So we are dealing with something cardiac. So then when we look at a sonography, we look at that. Now you're looking at the heart and the IVC with that in mind. So as you can see here, there's no respiratory variation which we had been seeing, right? The IVC looks full and this child has not received fluids. So
yes, not received fluids, right. Yes, cardiac CCF. So what is the reason we were given vaccination yesterday? No, our problem is that he is is not happy with my colleague, who is a good pediatrician. So this is what we do. Now can you?
Yeah, so as you can see here, again we showed earlier an echo which was the kissing ventricle, where there was not enough volume. Here the ventricles look very huge and dilated. So here we are concerned the other way, that the heart is not pumping enough, because this is a pulseless child. So what are we dealing with? We are dealing with cardiac dysfunction acutely coming up. We are dealing with probably myocarditis and cardiogenic shock.
So this is a normal patient.
Yeah, so this is a parasternal long axis view.
Yes, that was the parasternal long axis view.
And the short, and then
this was the apical 4-chamber view. See how the is pumping well. And this is the parasternal short axis view. Yeah. And this is our patient. This is the apical 4-chamber view. See the hugely dilated left ventricle.
And the other thing to note is the ventricle walls are hardly coming close.
Yes.
I mean, there's hardly any output.
Yes, correct. That is what, this is a very important point, simple point that I want everyone to understand. And this is a parasternal short axis view. So this patient has landed in cardiomyopathy. So cardiomyopathy is just chance that he has received vaccination. I explained everything to this patient and then he got settled down. So this sometimes can happen. This was just a कावळा बसायला फांदी मोडायला जे आपण म्हणतो that was what had happened, and the relatives then settled down.
If you do the lung ultrasound of this child, probably there will be a lot of B lines.
Yes, coming to that.
Okay, I think so then that's how we should go. It's not always.
If you can, yes, correct.
Just the cardiac ultrasound.
Next case is
heart
that.
and lung ultrasound.
Yeah. So now this is what the cardiologist would like to do, but even without doing all these calculations, we have come to a diagnosis. And this is what Dr. Vinay was saying. Now see this IVC. This is neither very full nor a collapsed one. So it is something in between. Dr. Pritha would.
Yeah. So in this is for the same child or someone?
This is a different child.
Okay.
If the IVC in another patient.
Right. Okay. So in this again, if the decision is about whether to give volume, this IVC is not extremely fully distended like the previous one. There is some collapsibility happening. So we call this a stage of fluid tolerance. So you have to here with very much caution use your fluids if you want to, or maybe directly go on to inotropes.
Yeah. Yeah, so we'll just let me complete the panel and then I would come back to your questions, please. Yeah. So what Dr. Pritha was saying is the lungs. So do you understand that what is lung for a hemodynamic assessment is the lung interstitium. So fluid will normally accumulate inside the interstitium, but because of the hydrostatic pressure and the osmotic pressure, there will be net gain of fluid in the interstitium which will be taken up by the lymphatics. When this doesn't work, means hydrostatic pressure increases or osmotic pressure reduces, then fluid starts accumulating here, and initially it will be if it is a minimal amount of fluid, then it is an interstitial edema, and when it is more fluid from the interstitium, it will go into the alveolar, that will be alveolar edema. Now can you comment on these two?
Yeah, so again in the first one you can see the regular A lines that we see in the A lines are horizontal lines, and on the right side you are seeing vertical lines. So when they are vertical lines, they are B lines and they are very confluent here. So again that means there's a lot of fluid in the alveoli as well. So here I am more worried to give fluids.
Right. So this is what I want to convey. When you are seeing this number of B lines, then be careful with the fluids. A patient in heart failure will still require fluids. We do not know that. But then in that case, we will give very small boluses, either 2 ml, 3 ml per. So this brings to the question, to the concept of fluid responsiveness. Means when you give fluids, there will be a rise in cardiac output and a fluid overload, which means that there will be accumulation of fluid. But in between is a stage of fluid tolerance, which means that when you give fluid, the patient should not have any organ dysfunction. In that case, the patient will be fluid tolerant. And which organ dysfunction are you worried about? See, liver will enlarge 4 centimeters only later on. So before that only you should pick up these children, and that is what the lung ultrasound will help you in this case by evidence of increase in the B lines. Of course, there will be clinical markers, and we can pick up these patients by doing IVC assessments, seeing the B lines, and if the fluid is still more, than patient will land in pleural effusion as well.
Can I say one sentence for this? If you have a completely collapsed IVC, please go ahead and give fluid, looking at your heart contractility. If IVC is fully distended, as in your case, don't give the fluid.
Yeah.
I think at least this we should know. And if there is in between, then probably you look at the lungs, look at the cardiac contractility, and maybe you give the fluid challenge.
Yes, we'll go a little bit very fast now. 7-month-old bronchiolitis usual case, but failing to improve to our usual line of treatment is having tachycardia and hepatomegaly now. What would you do? Yes.
I'll do the sonography. As I said, I will do heart and lung ultrasound.
This was absolutely unexpected. So what is this?
What you can see, a lot of unechoic area around the heart there.
Yes.
Yep. Can you see properly?
This is a pericardial effusion. Not only effusion, there is a tamponade. We were not at all expecting this in this particular patient. We immediately tapped then and there. Means I myself tapped it, didn't wait for the cardiologist to come around and do it. So we'll have various stages of pericardial effusion. See, this is a simple pericardial effusion, but there is no tamponade. And again, this is the same patient in a different view. You can see that fluid gravitates and will be settling in the posterior part. And you can also have fluid in the around the pericardium as well as around the lungs. So this is a pericardial fluid as well as pleural fluid. Both is there, and when there are echogenic areas here, this was a case of pyopericardium. So really different stages of pericardial effusion can be. So this is the last few slides. So this was a patient of ARDS with PEEP of 12 and low blood pressure, and this was the X-ray. And classical signs of ARDS. So before that, so now what is the reason for this low BP? Very quickly, Dr.
So every time we stuck with the diagnosis ARDS and we keep on fiddling around with the ventilator, we have to remember that there's always going to be heart-lung interactions. Whatever you give as oxygenation ultimately has to go back to the heart and has to get pumped out over there. If you have overdone your ventilation to some extent, that will affect heart function, and ultimately you are worried about tissue oxygenation, which is going to get hampered just because of the heart-lung interaction. So if this child's blood pressure, as you keep on changing your ventilator settings, is not very good, it's a good idea to look at the heart and look at whether over distension or increased afterload on the right side because of overzealous ventilation is contributing to low BP in this kid.
So here in this case, you will see that the right side of the heart is more in size than the left side. Normal left side of the heart should be bigger in size than the right side. This is completely opposite. This is just simple eyeballing, no measurements, nothing. So this is when you should suspect that there is about this. Dr.
Yeah, so normally this is a parasternal short axis view. We should be looking at what the structure below, which is going in and out, is the left ventricle, and the right ventricle is above that. Now the right ventricle should be D-shaped and the left ventricle should be looking like a nice circle. But here it seems like the right ventricle is much bigger. The interventricular septum, which is the white line you can see in between both those cavities, seems to be flattened. Right? So that tells you that the pulmonary pressures are quite elevated.
So that means the pressure on the right side is so high that it is pushing the septum now, and this is the extreme case. So this is that was just a D, and this is a crescent. So here the pressure is much more than the previous case. So these are the simple things that no need for any measurement. So you just see this and then you start acting. Maybe drop your, assist the patient with inotropes and try to drop your PEEP. And this is how pulmonary hypertension is measured, and this is what the cardiologist report you will get by measuring the TR jet. And finally, this is a simple case of PDA, Dr. Preetha. This is a single patient on the only patient on day 2.
Yeah, so we can see.
It is 2.8 mm.
Yeah, so you can see the PDA, and when you see a PDA, you don't treat the PDA immediately. That is the first message. You see whether that PDA is hemodynamically significant. So for that, there are measurements that we do, which is the ALA-AO ratio, which you can do in the parasternal long axis view. And as you can see on the right side upper diagram, you can see that. And also the other thing you look at is hemodynamic significance in the form of steel.
Yes. So here this is a simple, I have put a Doppler here and you can see the velocities. So the systolic velocity and the diastolic velocity, there is lot of difference between the systolic and diastolic velocity. Now just see the second one. The same patient on day 2. As you see that the difference between the systolic velocities and the diastolic velocities is coming down. So difference between the two velocities is coming. As the PDA is getting narrower, the velocity will increase or decrease. The orifice is getting narrower, so velocity will increase. So that is what has happened. See the velocity here, 201, and this is the days 4. Now see what is the velocity, is 320, and the PDA size is now coming down and down. So first day 2.8, people say 1.5 to 2 you should start closing. So we did not do anything for this. We just saw that, as Dr. Pritha pointed out, that LAO ratio was normal. So we just waited for day 2, day 3, day 4, and gradually on day 5 the PDA closed completely. So systemic hypoperfusion, PDA with systemic hypoperfusion, how can we assess this?
As I rightly said, no, every PDA shouldn't be treated unless there is, there is a steal. And if that, what you mean by steal is, as you see in this anterior cerebral artery Doppler, there is.
This is a normal Doppler where you can see
systolic and both systolic and diastolic flow, as you can see. But in the above diagram, what you see is that there is no diastolic flow. So there is a diastolic steal happening.
Yes, so all organs in our body are perfused in diastole. So therefore diastolic flow is extremely important. This is the inset that I have shown you. So this is a diastolic flow here, but here the diastolic flow is totally absent. And even if the PDA is 2.3 mm, which is less than the size of our previous patient, which was 2.8 mm, we will still close this PDA. Any other organ which you will see the diastolic flow?
No, this is the mesenteric.
Mesenteric.
Yeah.
So this was the end of the presentation. So case-based discussions were on the cranial ultrasound, where our patient had CNS dysfunction, our patient had simple pneumonia or a simple respiratory distress, simple bronchiolitis which we were not responded to the usual treatment, how to give fluids, when to give fluids, how much to give, whether our patient will tolerate those fluids or not, and the usual how to identify pulmonary hypertension and when to close the PDA and when to let it alone. That was the summary of these presentations. So in a patient, if you are CPR and patient is not responding, what you should suspect is diagnose a pneumothorax. Patient with shock, with fluid refractory or catecholamine resistant shock, you should take care of how the contractility is there. Patient on ventilators is in circulatory shock and is desaturating. A respiratory case, your X-ray is not conclusive, not correlating with your clinical findings. You are able to directly see what is happening inside the lungs. A RTA patient that I have not covered here, but is unstable, is having abdominal injury, is having rupture of the liver or the spleen, will have fluid inside the abdomen. In the NSU, you are taking rounds, but an unexpectedly patient lands in heart failure or an unexplained hypoxemia, or a patient develops a CNS dysfunction. These are our usual cases. What is the impact of focus in PICU? We will have a quick diagnosis under pressure. In PICU, we are always under pressure, but we get a quick diagnosis in a critically ill child. We are doing a speedy diagnosis, and therefore we are able to initiate the treatment in a speedy way, and it also helps us in doing prompt and safe invasive procedures. And the most important point that I have experienced is upfront I am able to tell the relatives what has happened to your patient and what will be your next line of treatment, and calming down the patients on admission, letting them assured what has happened is the most important advantage of ultrasound that I have found. And why we should do it? Because now there are PCPNDT acts, people will not come to you for radiologists, cardiologists will be handicapped to come to you. The small dedicated pediatric hospitals, availability 24/7 is not possible. Similar to the Friday night ventilation, as Dr. Mohit Mohite talked to yesterday, we are on our own. And so decision making will become difficult in NSU and PSU. So the only way to go is become self-reliant on ourselves. That is Atmanirbhar PICU. So, but again, I would leave with a word of caution that before doing POCUS, always clinically assess the patient. Few important points that our esteemed panelists have already told you all this. Thanks for patient listening. If you have any questions, you can please contact any of us after the session. Thank you so much.
Thank you, Dr. Vikram Hirekaru, Dr. Preetha Joshi, Dr. Vinay Joshi, and Dr. Neil Castellino. Please proceed for felicitation. Poisoning and envenomation are a perplexing problem in PICU. I invite moderator Dr. Abhijit Chaudhary and panelist Dr. Ajay Valimbe, Dr. Sancheti Suryavanshi, Dr. Kaustubh Prabhu Desai, Dr. Annasaheb Lokhande.
लेके आए थे?
या मैं लेके आया अगर बैकअप में, क्योंकि वो मैक था ना, मैक से यहाँ में कोई गड़बड़ नहीं आनी।
ठीक है, यही
या गुड आफ्टरनून। Pointer.
Yes.
I'm Dr. Abhijit Chaudhary. Currently, I'm working as Associate Professor in AIIMS Nagpur. And I welcome all my panelists, Dr. Ajay Valimbe sir, Dr. Sancheti Patil, Dr. Kaustup Prabhu Desai, and Dr. Anna Lokhande. I know it is 2 o'clock, but I'll be discussing only 5 and 6 cases. And I assure that in every case, there will be 1 or 2 learning points. I'll be quick, so I'll right away start my session. So the objectives are brief overview of snake and scorpio envenomation and a brief overview of some common poisons. So let's start with the first case. So a common case scenario, typically we see in the emergency around 8 o'clock, 9 o'clock, 10-year-old boy, he presented with at 8 a.m. in pediatric emergency with pain in abdomen of 5 hours, vomiting of 5 hours and breathing difficulty of 3 hours. He had started with pain in abdomen, he had inability to talk, he had breathing difficulty, and child was in the circumstantial history here, he was sleeping on floor with the parents. There was no history of fever, seizures, no history of animal bite, and in the past history is not significant. So when he was first examined, his airway was open but it was unstable. He had bradypnea with a respiratory rate of 14 per minute, decreased efforts, hypoxemia, saturation of 88%, hemodynamically stable, but he had a GCS of 6/15, pupils 3 millimeter not reacting to light, flaccid with a hyperglycemia. So basically he was in respiratory failure and he needs resuscitation. So considering the history and the physiological instability, Dr. Lokhande, what you would do next?
Sir, considering the history and the scenario, as a respiratory failure, patient is in respiratory failure. First, in any emergency, we should look for ABC, airway, breathing, circulation. Then we will take the general measures. Considering the baby GCS, I would like to take RSI steps, and I will intubate the baby and put baby on mechanical ventilation, give the supportive care in the form of IV fluids, head and elevation, NG tube, catheterization, iPad. And I will look for the underlying cause. As the course is very acute, we can consider here as a brainstem encephalitis or snake envenomation.
Yeah.
Though
so
the history of animal bite is not clear there.
Okay. So rightly said. Yes. It's a yes. But whatever the etiology, we first start treating the physiological derangements first. So airway, breathing, circulation is one of the most important thing, and he was rightly intubated, mechanically ventilated, IV fluids were started, and as sir also said, snake envenomation is a strong possibility. On examination, he had pallor, he had ptosis, there were no fang marks. And CNS examination, he had a GCS of E1, M4, VT, pupils 3 millimeter not reacting to light, he was flaccid. Power was more than 1/5 and DTRs were just elicitable. So as rightly said, in his respiratory system and CVS was not contributory. So rightly said, the diagnosis is neuroparalytic snake envenomation here. So when we talk about snake envenomation, we know usually snake envenomation, a 4-pronged syndromic approach is there. So Dr. Kaustup, can you throw some light on that?
Yeah, so 4 syndromic approaches. First is progressive painful swelling. Second is neuroparalytic stroke, which is usually caused by cobras and crets. Cobras will cause it much earlier. The 5 Ds about neuroparalysis are dyspnea, dysphonia, dysarthria, dysphagia, and diplopia, double vision. And there are 2 Ps, one is pallor and second is ptosis. So these are very telltale signs of neuroparalytic envenomation. Then the hematotoxic, the bleeding can be from anywhere. There can be a subconjunctival bleed, there can be just petechiae or purpuric rashes, a mucosal bleed, or a frank bleeding, which is usually caused by the vipers. And the myotoxic is usually caused by the sea snakes. So that is rarely seen.
Yes.
And there is another entity called as occult envenomation, like in this case, the person sleeping on the floor suddenly comes with neuroparalytic manifestations or just comes like an upper abdominal pain to begin with, and then develops a progressive paralysis where you may misdiagnose it as appendicitis to any other causes. These are kind of occult manifestations of snake envenomation.
Yes, correctly said. So, mind you, from the case scenario, it looks easy, but when we are working in pediatric emergency, I had done my residency in Chandigarh, years and years, crate bite used to come, and PHC doctors, they used to miss, in spite of the fact that there was so much of awareness. Because typically the symptoms start in the early morning, pain, abdomen, and as such we won't get a local swelling or a fang marks. So, still, it's a difficult task to suspect snake envenomation, and once you suspect, you have to do a very important thing in pediatric emergency, a bedside easy thing in pediatric emergency. We were taught as a residents, but I hope every pediatrician follows that, and to differentiate between neuroparalytic and hematotoxic. Can we do something apart from the clinical history? Dr. Sancheti?
So there is this bedside test which is the most easily available, feasible, and has to be done by each and every clinician who's for a patient which is suspected to be a snake bite. So this is this 20-minute whole blood clotting test. For this we need a dry, clean and a new glass tube. In this we collect a 2 ml of venous sample and around 2 to 3 ml of sample, stick it on the wall and observe for 20 minutes. Post 20 minutes we tilt the tube and see whether the blood has clotted or not. If the blood is still flowing, that means there is hypofibrinogenemia, which points towards a hemotoxic snake bite, that is viper. And if the blood is not flowing, it says that the test is negative, most probably it is a neuroparalytic snake bite. Also this test, if it is positive, we give ASV, and it also helps like post ASV 6 hours, if we repeat the blood test again, and it might help in further whether we need to give an ASV second dose or not. That also helps in with the help of 20-minute whole blood clotting time.
Yeah, so this is one important learning point I want everybody to take from this session, whole blood clotting time. Whenever you suspect snake envenomation, take a glass bottle, put blood 2 ml and keep it for 20 minutes and see. It tells a lot of information. And if you have not taken a glass bottle, it can come falsely negative, or if you have washed that glass bottle with a detergent and that detergent is not completely wiped off, it can come falsely positive. So yes, in the case we did whole blood clotting time and it was negative. We were dealing with a neuroparalytic snake envenomation. So Ajay sir, now what other test apart from whole blood clotting time you would send in such patients?
So for hematologically, we look for BT, CT, PT, PTTK, and if you have provision for fibrinogen D-dimer, you can do that. That can you can assess prognosis depending on that. Then for hemolysis, simple bed test is urine. You do dipstick. If it is positive, you can send urine to lab, and they will differentiate you. They will tell you regarding myoglobinuria or hemoglobinuria. And for renal failure, always we rely on creatinine and urea, but urine microscopy will show changes earlier. Then for hepatotoxicity, you do LFTs, mainly SGPT. Cardiotoxicity, for you do bedside echo or CPK-MB. Myotoxin, you can do CPK for this thing. And if you are suspecting infection, you will start antibiotic and collect blood sample for blood culture or CRP procal, whatever is available with you.
Okay. So in our case, we did whole blood clotting time, we send a laboratory test, and now comes the time of treatment, which has to be initiated at urgency. So that is anti-snake envenomations. So now these are the very important things. What are the indications of anti-snake venom? Asa nahi ki saap chawla ASV there. This is not the thing. I hope you can recognize the celebrity here. And is pre-medication needed for anti-snake envenomation? And how do we administer it? These are three very important things here. So Ajay sir, Anna sir, can you throw some light on this?
Sir, indications for anti-snake venom. Clearly ASV is a very specific antidote for snake venom. So we need to know whether it is required or not, because most of the snake, they are non-poisonous snake. So
Yes.
reassurance and counseling of the patient is very much essential. Whenever we diagnose it as envenomation, we should have, there are systemic indications and local indications. Systemic indications are in neurotoxic, we can have ptosis, neurological symptoms. In hematological abnormalities like coagulopathy, 20-minute W whole blood clotting test. Then again, if the cardiovascular abnormalities are there, hypotension, shock, myocardial affection is there, so abnormal EEG. Acute kidney failure, so renal failure is common, as sir said, we need to investigate the patient. Hemoglobinuria, myoglobinuria, we need to check the urine for that. And these are the indications, systemic indications where we should act very promptly and as early as we should start. Local illumination, local swelling, if it is a very small and restricting swelling, we should not go for the ASV, but it is a increasing swelling, progressive swelling, definitely we have to give the ASV. So purely local swelling or history of bite, even if accompanied by the bite mark, is not indications, because as I said, there are many cases of non-poisonous snake. And in pre-medications, it is very important, there are no prophylactic drugs regime available. The only thing is we should ready with our emergency tray. That is most important, is the epinephrine, we should load it and it should be available in the emergency room.
Yes. To summarize, 2 important points. If your child is symptomatic, neurologically, hematologically, or any other organ dysfunction is there, ASV, द्यायचंच आहे, no doubt in it. In local envenomation, if there is a rapidly increasing swelling or if the limb is more than 50% involved, it becomes an indication of ASV. फक्त साप चावला, there is no swelling, you can very well observe the child. From what Dr. Anna said, even in poisonous bites, to 40% to 80% of the bites are dry bites. Means the venomous snake injects, but he is not able to inject the venom. Okay, so no pre-medication, but you have to load the epinephrine. You have to keep the epinephrine ready. Now, another important thing is administration. This is a very important thing. How do you administer anti-snake venom in these children? Dr. Ajay sir?
The dose is, initial dose is 10 vial. It's same for children and adult. You have to dilute it in 100 to 200 ml of NS, and you can give over half an hour to 1 hour. Fastest you can give. Just look for any anaphylactic reaction, and anaphylaxis reaction, if they occur, you have to give adrenaline, but still you have to continue ASV, because that is the only chemical antidote. Okay, so for neuroparalytic snake bite, you administer that and wait for 1 hour. If he is showing signs of improvement, there is no need of giving ASV again. But if there are no signs of improvement, you have to give ASV again. Generally generally they require 20 vials. For hematotoxic envenomation, you have to repeat that 20 minutes WBCT after 6 hours. If it is negative, stop ASV, but you have to continue ASV till it becomes negative.
Yes. So, like a very important thing, do you know all that why 10 vials was chosen as the drug? Because my pediatric mind says, whatever drug we have to give, it should be mg per kg. But sapacha mind, pediatric mind nahi hai. When he injects venom, irrespective of the adult or children, his dose will be same. So it has been found in studies that to neutralize the venom, which is usually injected in the one bite, you usually need 10 vials. So from that, the first 10 vials dose has come. So irrespective, your child is 6 months old, 1 year old, or 18-year-old, or a 24-year-old adult, your initial dose is 10 vials of ASV. Now, very important. Now, the second takeaway from this case, I want everybody to take, like the whole blood clotting time, repeat second dose. So, whenever in neuroparalytic snake envenomation, at the end of 1 hour, there is no improvement, repeat the dose. Whereas in hematotoxic snake envenomation, when there is, you monitor whole blood clotting time or you monitor coagulogram in those cases. And in those cases, suppose if there is no improvement, either we go for low dose infusion therapy or a high dose. Just understand that we have to repeat the dose of ASV, maximum 30 to 35 vials of ASV can be given. But in few cases, they have given ASV 6 hourly or 8 hourly for few days also. So how to repeat the second dose of ASV is a very important thing. Last, so what is the role of atropine and neostigmine in these cases?
So atropine and neostigmine have a role in neuroparalytic snake bite. So atropine and neostigmine are given together atropine at a dose of 0.05 mg per kg and neostigmine at a dose of 0.04 mg per kg. And the doses are repeated every 30 minutes for a total of 5 doses. The subsequent doses of neostigmine is reduced to 0.01 mg per kg. So thereafter the doses are tapered and repeated as 1, 2, 6 and 12 hours. So what do you understand by a positive AN challenge test is that there is a 50% recovery in ptosis post 1 hour of giving atropine and neostigmine, and this indicates that this is a neuroparalytic snake bite. So in neuroparalytic, sometimes there is no response in this 3 doses of AN's challenge test, and that time we might suspect it can be a crate bite. Crate bite can actually crate bite is a neuroparalytic snake bite, but it acts on the presynaptic fibers, which has calcium ion as a neurotransmitter. In that case, we can give calcium gluconate 6 hourly if your AN challenge test is negative and you're suspecting a crate bite.
Yes. So neuroparalytic snake envenomation, start atropine neostigmine challenge test. It is helpful in cobra bite, not in crate bite. But at the time of presentation, it's difficult to say it's crate or cobra, though there are some differences. So it should be done. So now we move to the second case, and this is a real life case. Envenomation, I diagnosed. See, at that time, we don't know it's a crate bite or a cobra bite. Basically, neuroparalytic snake envenomation, we give 5 doses and we see if there is a response or not. If there is an improvement in 50% of the doses, there is a response, and then we continue it and we taper it at 1 hour, 2 hours, 6 hours and 12 hours. Suppose if there is no response, we just leave it.
I'd like to add on.
Yes, it definitely. I had said that there is some differences. Usually crate won't have mark, in cobra there will be mark, but still, irrespective of that, you have to give 5 doses. If no response, this is what the guidelines also say. Don't give further. It doesn't rule out crate bite. And we are we want to know ki it's a crate or cobra, but our management is always same for neuroparalytic snake envenomation. Yes, crate bites are painless, they are more in the night, they will not have fang marks, correctly said.
I'd like to add on, sir. If at all you're in a center where even ASV is not available and you have a strong suspicion of neuroparalytic snake bite, you're transferring the patient to higher center. Meanwhile, you give a dose of atropine and neostigmine, and by that time, the child is transferred, because there is high risk of death while transporting the child. So this will at least help in meanwhile. Yes. Airway is important, but if you're transferring, by that time you can give a dose of atropine, neostigmine, and then we can transfer.
Yes, that's a very important point. So now this is a second case. I was a junior resident. At that time I had managed this case. A 7-year-old boy was going with a grandmother to basically a temple, and he started crying. He had vomiting, he had excessive sweating, and he was becoming slightly unconscious, and he presented to emergency in the night with a lot of irritability. We were not knowing what he is saying, and he was pointing towards his leg, and he was ice cold. And his blood pressure, usually in ice cold, we expect hypotension, but his blood pressure was like, he was hypertensive. And you must have, he also had priapism. So now you must have all known that mostly we are dealing with scorpio bite. So in scorpio bite, what are the 3 important things in the treatment we do? Dr. Ajay sir?
So first, looking at this case, this is systemic envenomation. Then the first priority is pain. You have to treat the pain with say simple paracetamol, ibuprofen, or you can, if there is local pain, only local pain, you can give lignocaine, 2% lignocaine, but that should be without adrenaline.
Yes.
And for this symptomatic kid with scorpion sting, with sympathetic storm, the chemical antidote is prazosin. So you have to give prazosin 30 microgram per kg every 6 hourly till his extremities, you feel the pulses and the extremities are warm. It can cause first pass side effect. So if the child is lying down, you have to don't make the child sit up immediately. So you have to give make the child lie down for at least 1 hour or so, and you have obviously he's sweating so much, you have to take care of his hydration also. And now there is anti-scorpion venom which is available, but it is not freely available. Those who are using it, I have never used it. We manage on prazosin and painkillers. So for that anti-scorpion venom, you have to give within 4 to 6 hours, and that is polyvalent, but that is not easily available. For us, the main treatment is prazosin, that is not a sustained release tablet. It should be a plain prazosin. You have to crush it and you have to give it sometimes.
Yes. So basically, to summarize, it's pain, analgesic, prazosin, and thanks to Maharashtrian who had played a very vital role in bringing this drug for the treatment of scorpion envenomation. We all know him. And anti-scorpion venom. So lots of studies are from JIPMER, Pondicherry. Dr. Mahadevan sir had did studies on this. But it's important that if you give anti-venom for scorpion, it should be given before 6 to 8 hours. Then only it will be effective. After that, it won't be effective. And I don't know about the availability. In our center also, it doesn't get. Probably in southern part of the India, it's available. So, other critical care issues in the scorpion envenomation is myocardial dysfunctions. So it is very important, like I told you, our child was hypertensive. So these are in autonomic storm. So first there is a parasympathetic storm when there is a hypertension, and then there is a sympathetic storm. So your child may have hypotension afterwards. So dobutamine, if there is a pulmonary edema associated with nitroglycerin plus minus adrenaline, and obviously respiratory support plays a very important role in saving these children. So now we come towards poisoning in children. We all know when to suspect poisoning. If we get a child of MOTS, respiratory compromise, unexplained metabolic acidosis, or a very puzzling clinical picture, many times we get a history of poisoning, no doubt in it. Now, are children different? Yes. Because they are curious, they have an exploratory nature, they don't know what is safe, what is unsafe, and the poisonings may be intentional, unintentional, iatrogenic. What is important that in children there is an increased dermal absorption, there is an increased absorption by inhalation. In children there is a higher metabolic rate and decreased reserve. There is a vulnerability to hypoglycemia, limited cardiovascular reserve, and altered drug metabolism. So all these things makes children very notorious for to have very side effects of poisoning. So now can you, Dr. Anna, can you name few of the toxidromes which we should all know while seeing a case of poisoning?
Yes, sir. As you said, the children are vulnerable for these toxins. So toxidromes these are the group of symptoms or syndromes which are caused by overdose of toxins in the body. So these are the cholinergic, anticholinergics, opiates, and sedative. We have divided in these groups. So there are limitations. Limitations of toxidromes are useful when single drug or poison exposure is there. Overlapping features are there, so we can't exactly diagnose which toxidrome is there. Anticholinergics such as dry skin, sympathomimetic drugs, diphoric, findings affected by individual variety, comorbid conditions are equally important to consider.
Yes. So toxidromes does help, but there are limitations, especially when children take the cocktail of poisons. It's very difficult, then they don't present in a particular way. And somehow this toxidrome reminded me of a case where we were also posted in emergency, and 15 children belonging to the laborers who were working near the railway track had come with dhatura poisoning. So many times it's like treating poisoning is like, it's a very good thing in an emergency. So irrespective of anything, in poisoning also the first thing is A, B, C, D, E. Airway, breathing, circulation, and elimination. Now, two important points, gastric lavage and activated charcoal. These are two very important points. Dr. Anna?
Gastric lavage is, as know, everybody is very fond of gastric lavage, but there are certain indications and certain contraindications that we should know. Indicated, it is indicated when the patient arrives within 1 hour of, that is golden rule or golden hour, and when there is a life-threatening or massive situation of the substances that are ingestion. Then we are also having the another charcoal activated. So substances that don't bind to the activated charcoal, we have to give the gastric lavage. So gastric lavage is contraindicated in basically corrosive poisonings, and for the prevention and reduction of the absorption, we have to use the activated charcoal, universal antidote. There are certain risks with activated charcoal also, vomiting in 25%, aspiration pneumonitis, poor acceptability by children, and contraindications like obtunded patients, unprotected airways, ileus, interstitial obstruction, peritonitis. Also this activated charcoal, there are some toxins which are poorly bound. These are cyanides, hydrocarbons, ethanols, metals. And very importantly, I would like to stress, whenever we are doing gastric lavage, we need to have airway protection, and we need to take care of airway. That is very important.
Yes. So gastric lavage, most effective time period is within 1 hour. Activated charcoal, it's a universal antidote. In both cases, you have to protect your airway. That is a very important thing. So, after gastric lavage and activated charcoal, we'll come to case scenarios. So, a 2.5-year-old girl was brought to pediatric emergency with the ingestion of drainage cleaning powder. She developed a burning sensation in mouth and frothing. She vomited 4 to 4 times. She was conscious, irritable on arrival, and a nasogastric tube was inserted immediately in the ER. So Dr. Kaustubh, before we go to the case scenario, we now know we have a picture also. Probably we are dealing with a corrosive poisoning. Can you just enlighten us, what are corrosives and what is the difference between alkali ingestion and acid ingestion?
So corrosives are usually the substances which are broadly divided into two parts. One is acid group and another is alkali group. We all know that the pH below 7 are acids, pH above 7 are usually alkalis. But the pH of substances which are below 3 or above 11 are highly corrosive. Especially when they come in human contacts, they can have its effects. Acid versus alkali, the way the usual site of injury is right from the mouth till the most of the times upper gastric mucosa. The strong acids and alkali actually affect differently. The acids usually cause coagulative necrosis. That's why it actually affects the superficial portion or the mucosal layer, and if not muscularis mucosa of the food pipe, and it can usually injure stomach more than esophagus. On the other hand, alkalis actually are more toxic than acids. They cause liquefaction and the saponification, which causes the disruption of cell membranes, and that's why it can cause more chances of perforation going ahead.
Correct. So, a good example of alkali is button battery. Button battery is a alkali. It will penetrate your esophagus and can roam anywhere in the mediastinum. Acids are harmful, not that. It always depends on acid or alkali will be more harmful, depends on the dose, what substance they have taken. But they both have different mechanisms of causing injury. And alkalis are known to cause deep penetrative injuries. So now, suppose a child takes acid or alkali, Dr. Sancheti, things which comes to my mind, what should be the initial management?
So initial management is always, first is the airway, breathing and circulation. We see the patient manage ABC first. Best is to, first and foremost is keep the child NBM. Once you have managed the airway, breathing and circulation. However, there is one thing has to be kept in mind is 4 no's, that is there should be no decontamination, no gastric lavage, no activated charcoal and no bowel irrigation. And that's a total no of blind placement of NGT. We always have a habit that once the child of poisoning comes, the second thing that the JR1 does is put an NGT and give a gastric lavage and all. But there should be no placement, no blind placement of NGT. It should be always be done endoscopically with the help of gastroenterologist, and it should be avoided because there is high risk of perforation in this.
Yes. So lots of no's in here. no decontamination, no lavage, no activated charcoal, no bowel irrigation. A very important learning point. In the case I had told, in the emergency only we usually, many a times, we don't put NG tube proactively, but somehow in this case it was put. So whenever there is a suspicion of corrosive ingestion, don't put NG tube, because it has to be put endoscopically and at a certain time. So, Dr. Kaustup, after this initial management, somehow my mind is curious, if a child injects acid, can't I neutralize it with an alkali? Can't I give an alkali, or can't I dilute it?
Ideally, the dilution and neutralization techniques the benefits are not clearly shown, but in cases of button batteries, honey ingestion every 10 minutes around of 10 ml up to 6 times is kind of recommended till the child goes towards higher center where the gastroenterologist is available. Sometimes after acid ingestion, immediately if somebody gives a water at home, that can be done, and the irrigation of the oropharynx or up to the esophagus with the ingestion of water is possible. But there are many buts. The child should be conscious, child should be able to swallow the water well, and should be able to speak clearly. If there is any suspicion of airway compromise or any hyperemia of the lips or oral mucosa, one should not attempt this. So there is a big no for that.
Yeah, very good point. Now this brings, so now I told that NG should not be placed, and we have to do an endoscopy. So obviously there is a role of endoscopy. So in toto, how do we manage these children? Their whole management, and regarding what is the timing of endoscopy in these children?
This may take a minute extra. So the management initially, we'll go to the scopy. Initially the management, as Dr. Sancheti said, is management of airway, breathing, circulation, and waiting and watching, keeping the child NBM and giving the support with the IV fluids to the child. The timing of endoscopy and the role of gastroenterologist is extremely vital here. In the first 6 hours, we don't attempt endoscopy.
Yes.
We can attempt endoscopy after 6 hours till approximately 48 hours. If we don't have facility to do an endoscopy until 48 hours, we should wait for a late endoscopy, which is at 3 weeks. So in between first and third week, usually the endoscopy is not attempted. The reason for that is basically the necrosis is ongoing, and the necrosis can actually cause more chances of perforation if the endoscopy is attempted between first and third week. So usually after 48 hours till the end of third week, endoscopy is avoided. The contraindications of endoscopy are clear. If there are signs of perforation or mediastinitis, there is a airway edema, or there is hemodynamic instability or shock. There is a classification called as Zager classification. The grades are actually easy. We can see here the picture A is normal. Picture B is stage 1 where there is a hyperemia and edema. Picture B is hyperemia edema. We can go to the next slide. Yeah. Picture C is basically, it has started a blister formation. Picture D is around circumferential bleeding. There are ulcers, and there is a little bit of an exudate, which is picture D. Picture E, there are focal necrosis. So this is 3A. So picture E and F are third grade, where there is a focal necrosis, and last one was the generalized necrosis.
Okay, thank you very much. So endoscopy, we should know when we have to time it, and NG should not be put blindly. Okay, so move to the next case. A 26-year-old female and her 2-year daughter were admitted with a suspected poisoning, and she had the chief complaints of excessive salivation, constricted pupil, bradycardia, muscle twitching, and altered consciousness. And her airway was not maintainable. The child was having a respirator of 20 per minute, hypoxemia, hemodynamically he was compromised, and he was in altered sensorium also. So with this, Dr. Sancheti, what would be the emergency management we would be doing in this child?
So as you can see that this is an obvious case of suspected OP poisoning, seeing the toxidrome, but the patient is in impending respiratory failure. So first and foremost is start with your ABC, stabilizing your airway, breathing and circulation. Since it is a suspected organophosphorus poisoning, we intubate the child. We intubate it by rapid sequence intubation. While intubating, it has been advisable to avoid succinylcholine during rapid sequence intubation, because succinylcholine acts on the cholinesterase receptors, and using this has been seen to prolong paralysis. if the shock has to be managed by giving IV fluid boluses, if needed vasopressors, and then further comes your evaluating the child further by proper history and examination.
Yes.
Now coming to organophosphorus, we have this muscarinic symptoms and nicotinic symptoms. As we all know, muscarinic symptoms go by the mnemonic dumbbells and sludge, and nicotinic symptoms are usually fasciculations followed by paralysis, where we can see hypertension, tachycardia and mydriasis as well.
So, to summarize, muscarinic म्हणजे शरीरातनं सगळीकडनं पाणी जातं. Nicotinic is more related with the muscles. So, coming to the now specific management, we all know we have to do this. Dr. Anna, can you highlight about the decontamination which needs to be done in these children?
Decontamination is needed, so to avoid the secondary contamination, remove the patient's clothing, wash with soap and water to prevent the contamination of resources that are present. If the eyes has been there involved, we have to clean. Gastrointestinal decontamination, there are limited benefits because of it is highly lipid soluble, rapidly absorbed. Activated charcoal has a limited role if the absorption has already occurred.
Yes. And now quickly we'll see what is we all know that we have to atropinize the child. But Dr. Sancheti, in just 1 minute, can you tell us about the role of atropine and pralidoxime? Less than 1 minute.
So atropine is a mainstay of therapy in OP poisoning. It acts on the acetylcholine receptors, and it acts on the only the muscarinic receptors. So it relieves the muscarinic side effects. It is given at a dosage of 0.05 mg per kg, repeated every 5 to 10 minutes till atropinization. So now what you understand by atropinization is your pupils are no longer pinpoint, your axilla is dry and you don't have bronchoria. So oppose that, you need not stop atropine. Because stopping atropine has been shown to cause intermediate syndrome. So what we do is we calculate the cumulative dose which has caused atropinization. We use the 20% of that dose and give it over as an infusion over the next 24 to 48 hours. The other mainstay of treatment is your oximes, that is pralidoxime. Pralidoxime is given at a dose of 25 to 50 mg per kg over 30 minutes. It can be repeated as 1 to 2 hours, and there is another way of giving it as a continuous infusion at 10 to 20 mg per kg per hour. But pralidoxime doesn't act is of no use in carbamate poisoning. So there has been studies whether to give a bolus or a continuous infusion of pralidoxime, but few studies have shown that continuous infusion have required less dosage of atropine. There is a better recovery of paralysis of the patient. So it's your call, but continuous infusion is any time better as compared to bolus.
Yes, 3 things. Atropinization, the end point of atropinization is clear chest, after which 20% of the dose which is needed for atropinization we give as a continuous infusion next 24 to 48 hours. Pralidoxime, not helpful in carbamates, but in cholinergic symptoms, initially we start pralidoxime till the time we don't know what is the component. So quickly, Ajay sir, what is intermediate syndrome and what is organophosphorus induced delayed polyneuropathy?
So intermediate syndrome is new onset of weakness or recurrence of the weakness, mainly of bulbar and respiratory muscle, and generally proximal muscles are involved. It happens in 1 to 4 days. The main treatment is ventilatory assistance. Organophosphorus induced delayed peripheral neuropathy seen after 2 to 3 weeks, generally present with distal limb weakness, and recovery is within 6 to 8 months. The most important is physiotherapy.
Yeah. So my encounter with intermediate syndrome was a child. We managed in emergency, pediatric emergency BZ, OP poisoning, not getting bed in PICU, extubated the child. After 36 hours, suddenly went in respiratory arrest and we had to intubate the child. Basically, one of the cause postulated for intermediate syndrome is inadequate atropinization. Not the first atropinization. After that, what you give as a continuous infusion, if that is not given, the chances of intermediate syndrome are more. Now we come to the last case. A 9-year-old boy, 8 kg febrile infant, was brought by mother who was admitted 5 ml of crocin drops. Very common scenario, means we hear instead of crocin syrup 3 times since last evening. So Dr. Anna, Is it a toxic dose?
Yes, sir, paracetamol is a very common drug that is used in for fever management. So this is definitely more than 200 milligram per kg. Usually we use 15 milligram per kg as a routine dose. Up to 90 milligram per kg is acceptable dose. And beyond that, there are certain symptoms. They are present in the form of stages 1, 2, 3, 4. First stage occurs in within 24, very non-specific vomiting is there. In 24 to 70 hours, abdominal pain, vomiting, patient comes. On third day, patient presents with symptoms like acute failure. And within 96 to 2 weeks, the patient will survive. If the multisystem organ is involvement is there, then there are little less chance of survival of the patient.
So important message in this slide is patients la follow up ठेवा hospital मध्ये for the next 24 to 48 hours, because in the first 24 hours there may be just nausea. The liver injury may happen in the next 48 hours. So it's a very important thing. Yeah, just last 2 minutes. Yeah, clicked. So Dr. Kaustup, I clicked okay. So no. So Dr. Kaustup, quickly, can you enlighten us about the treatment which now we have to give?
So the time since the ingestion is actually important. How early or late the patient presents to you. If the patient presents within 1 hour of the consumption of the paracetamol, the lavage can still be tried. Within 4 hours, the activated charcoal can be tried. At 4 hours, ideal scenario, we should take the paracetamol levels and we should get the reports as soon as possible and plot them on what is called as Rumack-Matthew plot. The graph shows 2 lines over there. There is one called as treatment and one is Rumack-Matthew line. The treatment line is at around 150 milligram per liter of total consumption. It starts at 150. The RM line actually starts way up about 200. But then the studies have suggested that the toxicity happens 25% lower dose, so not at 200 but at 150 only. So at if the concentration at the time of paracetamol levels crosses that 150, we should immediately start an acetylcysteine infusion. In the situations like in our settings where the paracetamol levels are not easily available or they come 2 days later, we should straight away start with the NAC infusion if the dose is toxic. There are sustained release tablets which can be sometimes ingested. In those cases, we should wait for 8 hours to send the paracetamol levels.
Yes. So important thing, if available paracetamol levels, do it at 4 hours, not before. And if suppose there is a toxic dose ingested by the child and you can't do the levels, start NAC. That would be the best thing. And please follow this Rumack-Matthew line. Now,
dose, so around 300 mg in 21 hours, you give it as 150 bolus or 200 mg per kg over first 4 hours. Sometimes we give 150 bolus, 50 over next 3 hours and then 100 to continue. So that's the dose.
Yeah, now a very important thing, whenever we are in problem, we call this National Poison Information Center. Everybody should know it. It is basically in AIIMS Delhi. I am not aware about CMC. Vellore is also running the poison center, but 24 hours, 365 days, you will get whatever queries you have about the poison, you will get the answer of it. So it would be very helpful. You can take a snapshot also of this. So take home messages. Syndromic approach for diagnosis of snake bite is helpful in absence of history of bite. Anti-snake venom should be given at earliest. No role of pre-medications. Atropine neostigmine challenge test should be done in all patients with neuroparalytic snake envenomation. In scorpion envenomation, recognize the clinical presentation. Autonomic storm is the clue. Circumstantial history and a high index of suspicion is very important. Very few children will come, mala scorpion chavla, mala vichu chavla. Timely treatment. Prazosin is very important. For poisoning, acute poisoning is a common emergency in children, an important cause of morbidity and mortality. Cardiorespiratory stabilization must precede any diagnostic step. Focused examination is necessary to identify syndromes. Routine toxicological screen seldom adds any information. Basic supportive care saves more lives than antidotes put together. Poison prevention education should be an integral part of all well child visits as well as in schools, and prevention is better than cure. Thank you.
Thank you.
Thank you, Dr. Abhijit Chaudhary, and the panelists Dr. Ajay Warimbe, Dr. Sancheti Suryavanshi, Dr. Kaustup Prabhudesai, and Dr. Annasahab Lokhande.
Yes, number?
Please proceed for felicitation. We are coming to the end of this brilliant academic festival, but not before having a discussion on life-saving vaccines in PICU. Please welcome Dr. Ganesh Kulkarni for his talk on as early as 9 months against invasive meningococcal disease. And to chair this session, I invite Dr. Nivedita Patil, Head of Pediatric Department at D.Y. Patil College, Kolhapur, and Dr. Shilpa Kurdukar Dadge, Associate Professor, MIMSR Medical College, Latur.
When you talk about meningococcal disease, how many of you have seen meningococcal disease in your practice? Only 2? So that means even it is a rarity, right? Now, how many of you really know that this is one dreadful of an illness? Everyone knows about it. So this is the beauty of this particular disease. You know, we have not seen it, but we know much more about it, that this is something which we need to be wary about. Okay, so let's try to, it's not working. Oh, sorry. So this is the disclaimer, this is a sponsored talk, and this is the overview. I'm not going to enumerate all of them. If I get some 2 minutes more, I would try to enlighten you about some intensive care aspects about vaccinology if I get time. So this is an invasive meningococcal disease. Unlike pneumococcal disease, where you have a burden of disease is non-invasive and only a minuscule of disease pneumococcal is invasive, here meningococcal disease, maximum of meningococcal disease is invasive. So let us understand how this particular progresses. We all know that this particular disease comes up as just trivial symptoms with fever, headache, vomitings, neck stiffness, and it starts very abruptly. Almost when a child is exposed, 50% of those kids who are exposed have a possibility of getting this disease. So the disease, probability of getting this disease after exposure is almost more than 50%. That is first thing that I want to denote. Now second thing is, out of these 50% kids who actually get this meningococcal disease, 40% have a chance to get into the meningococcemia. That means the IMD part of it. Invasiveness of this particular disease is very high. And the third is, when you start with meningococcemia, we know that it starts like a catastrophe. It starts very abruptly. Fever, chills, vomitings, headache, all trivial symptoms like prodromal phase symptoms, like any other respiratory tract illness or any other flu-like illness. And then it progresses. Often it is seen that the characteristic features of meningococcal disease, which is actually hemorrhagic rashes or photophobia or fever, high-grade fever toxicity, doesn't come up for all of them. It comes only for 20 to 30% of cases. And sometimes it might come as late as possible as well. So to differentiate it from other flu-like illnesses, it becomes very difficult. That's the second thing about this particular. Third is, it has a very rapid progress. It is one of those diseases which has a very short incubation period, only 1 to 10 days. And the shortest incubation period that was encountered was just 3 days. So abrupt onset of symptoms and going to the death of the child, it takes almost just 3 days. How is it going to be possible for a clinician to really come to a diagnosis, manage it, so that to save this child from dying? That's not possible. So this is the hallmark, that rapidly progressive disease, even with antibiotic treatment, it's not going to give you some time to cherish. It has without even rapid treatment, fatality ratios is very high. Now, this is all a game of time. If you ask a Mumbai guy, what is the importance of a 12 baje ki local? Even if he gets 12 past 10 ka local, he would always feel that he was late for that day. Similar situation happens here. See, the non-specific symptomatology starts within 4 to 8 hours. It goes on to show you some characteristic features like hemorrhagic rash, neck stiffness, photophobia within 12 to 15 hours. And towards the late, like, 15 to 24 hours, it becomes almost late kind of thing. So almost the death, confusion, and multi-organ failure happens within 24 to 48 hours. This is what the speed with which this disease progresses. Now, there are challenges for a clinician. The first challenge is the challenge to diagnose this. What are those challenges? Why it is so difficult to diagnose this particular entity is the rapidity of symptoms. Second thing is the symptomatology is very trivial in the beginning, like any other flu-like illnesses. Because we don't see it much often, the clinicians aren't experienced what kind of this disease looks like. That's the clinician's problem. Then this disease has a very non-specific symptomatology like irritability, lethargy, commonly seen, which is very commonly seen in other aspects of infants and children. The classic feature of IMD is hemorrhagic rash and fever, which is not seen in all of them. And in many cases, this hemorrhagic rash comes very late. And these are all the challenges for a diagnosis of this particular entity. Now, there are again few challenges to treat this entity. Why? Again, the same thing, rapid progression. You don't get that time to treat it. Then you have younger patients who have a faster deterioration. You have invariably flu-like symptomatology which misleads the clinician. And last is not, but the most important is the fastidious organism. These organisms are very difficult to culture. They need special nutrients in the agar to cultivate. And that is where you won't get this isolated organisms from cultures. Now, coming to this invasive part, let us try to understand, is this so much rampant in our demography? Absolutely yes. I would say if you see this graph, see this picture, it is like yatra tatra sarvatra. You could see all across every part of this country, there is an outbreak. There are multiple outbreaks. This is a NCDC report which showed that, yes, it is very much there in our country, in almost all aspects, all corners of our country. This comes in a very outbreak-like epidemic coming up again and again. Every 7 to 14 years, we have epidemics coming up in every corner. And what was seen in our country was there are almost 13 serogroups which are prevalent. Out of these 13 serogroups, 5 serogroups are said to come up for almost 90% of your cases. And out of these 5 serotypes, India is said to be very specific for serogroup A. So all these cases as outbreaks, the serogroup which was isolated was serogroup A. So we are serogroup A specific geography, right? Now, if you see the burden of disease, this particular meningococcal disease is said to be the third most commonest cause of acute bacterial meningitis. We all know Streptococcus still tops on the list. Second is Haemophilus influenza, and this is the third one. And now, if you see, we think that now all the other diseases are showing a decline. It is exactly the other way around here. From 2005 to 2020, there is almost 39% increase in the incidence of cases. And if you look at the mortality part of it, from 2005 to 2020, there is almost 25% increase in the mortality. So we haven't done enough to control this particular entity. Now, see the case fatality rate. If you compare it with other communicable diseases like gonococcal, cholera, diphtheria, pertussis, and others, this particular disease has one feature: the disease incidence is very less. But look at the fatality; it is almost there, 42%. So something like a tiger, as I said, spotting a tiger is a rarity, but if you spot a tiger, encounter a tiger, you're for sure that you are dead. This is what this disease is all about. And that is the reason why we need to inoculate our kids against this particular entity. Before you realize the child is dead. And then, this is a bimodal peaks that we have. Indian continent is perhaps very prevalent for infants and children because of their relative immune immaturity and under-responsiveness to the polysaccharide. Because there are two types of vaccines. One is a polysaccharide vaccine and another a conjugate vaccine. 10 years before we used to use polysaccharide vaccines, now it is no more. But these polysaccharide vaccines didn't do a job because they were not effective below 2 years of age. And most of the disease burden from Indian subcontinent is in the infancy and the early or young children. Whereas in UK if you go or Europe you go, you have an adolescents which have a highest prevalence. because they have done enough on vaccination, so they could, epidemiological shift could happen in their country, and the disease which was prevalent in infants and children, it went up to go to adolescent or elder subs. So how do we counter both of them is by giving a wonderful vaccine. Now, why a pediatric population is so important for this disease per se is basically severe complications. This always lands up into septic shock, multi-organ failures. Below 5 years, the complication rate is much more. The progression is very rapid, and the only way forward is vaccination, right? Now, the long-term sequelae, yes, we all call it upon that this is a very acute illness, but it has been also seen that it can go up to 6 to 8 weeks. It has some chronic progression as well. Once it goes into a chronic progression, it has a skin scarring, eczema, it has something as Raynaud's phenomena, it has vasculitis coming up. Neurological, we know that blindness, hearing loss, psychologically anxiety and phobias. And this is one wonderful district-wide Israeli study which showed that if you compare about complications, if someone has an IMD, the rate of complication is much higher than as compared to any complications occurring out of other pediatric diseases, right? Now, it is highly imperative to control this high incidence and rapid outbreaks of invasive meningococcal disease nationally and globally. So what WHO said to us? WHO said that WHO set up a goal in 2021. So WHO always sets up a goal, and it has given us a goal to eliminate all bacterial meningitis by 2030. And how are we going to do it? There are some 5 pillars to it. The main pivotal pillar for it is again prevention and epidemic control. That's the one. The others is basically disease surveillance, diagnosis and treatment, support and care, and advocacy and engagement. By this, we are going to take this disease out of our geography. So now reviewing the scientific studies. Now what I'm talking about is talking about these vaccines. Now there are 2 different vaccines which are available. One is MenACYW, which is conjugated to diphtheria toxide, that is popularly known as Minectra. The second is MenACWY, which is conjugated to CRM protein, that is Menvio. Now let us try to analyze. This is a quadrivalent vaccine, as I said just now. This is conjugated vaccine, so it can be used below 2 years as well. Only problem is the Menvio does not have Indian studies, so it is not given the license to use below 2 years. So only vaccine that is left to be given below 2 years is Menactra, that is MenACYW diphtheria toxide conjugation. Now, see this here, this has been, we all want Indian studies. We don't want abroad studies to say that this vaccine is safe for our ethnicity, and this is what they have done a study over 500 cohort, a cohort of 500, and they have 2 studies between 2 to 55 years and 9 to 17 months, and it is proven beyond doubt. Let us try to see whether this study fits in. Now this is again a wonderful open label clinical trial, which is a single arm clinical trial, which was actually conducted to check whether safety, tolerability and efficacy of this particular vaccine in Indian scenario. And you could see here, there were 2 dosages given almost 3 months apart, and the pre-dose GMT titers, the SBA-HC, that is, this is serum bactericidal antibodies assay, which is in presence of human complement. And look at this GMT titers, it was 55.8, it was 5, 6, almost 5. So across all these 4 serotypes, the pre-vaccine dose GMT titers were almost negligible, and look at the GMT titers after giving 2 dosages, 4 weeks after, 2 to 4 weeks after. So after dose 2, 95.7 to 99.5% children have achieved seroprotection. And moreover, this particular vaccine, the Minectra part, has shown 97.8% seroprotection titers against A serotype, which is prevalent in Indian scenario. If you compare this vaccine against the other vaccine, they have not as much of serotiters against A, which is India specific. So that's perhaps this has an advantage over the other one. Now this is, that was about the age below 2 years, and this is about the age between 2 to 55 years. This vaccine is licensed to be given for 3 months or 6 months or 9 months onwards up to 55 years of age. And here you could see against ACYW, and see the titers here. So you could see here almost all have been way above the collateral of protection, and the collateral protection is just 8. So that's how 92 to 100% have achieved their seroprotection. Almost this main ACWY DT is immunogenic to all serogroups ACWY and against the geography, the ethnicity and the phenotypic or genotypic background. And here also it is wonderfully protecting your serogroup A, which is India specific, right? Now this is immunogenicity of the other one, the MENVO part, CRM. It has some problems, though it is much higher than the collateral of protection, but it is much lesser than as compared to the other one. So it is 75, 77 and 66. That's what 72, 95 and 94, that's Purple Book mentions about it. So I'm not going to say that one vaccine is better than the other, but there is slight edge of one over the other. So coming to the last part, and this is what experience about the safety profile. So this is real world evidence of vaccine efficacy. Now when we talk about real world efficacy, that means it is effectiveness. And when we talk about effectiveness, you could see here, see the prevalence here and the introduction of meningococcal vaccine at 2003, and you see the graph is going down, the prevalence has gone down. That means in the real world, these vaccine is working wonderfully. So pre-vaccination, high incidence in infants and preschool children. Post-vaccination, greatest reduction in preschool and school age children. That means these vaccines are helping out, right? Now, if you see this particular Menectra, main ACWY DT, is approved in 70 countries, indicated for the active immunization of individuals from 9 months to 55 years, and it is also WHO pre-qualified, right? These are the trust on this particular vaccine, given 3 lakhs dosages before, monitor well, and safety-wise absolutely wonderful. This is fully liquid as compared to the other one which comes in a lyophilized form. And when you have a lyophilized form of vaccine, you have to prepare it. When you prepare it, there is always a chance of error of administration, which is not seen in this particular vaccine. So this is what points for consideration while making an informed choice about which points you pointed upon to consider that this vaccine is to be. So in Indian scenario, a vaccine should be serogroup A protective, that's one thing. Broad spectrum of protection against other serogroups as well. Population centricity, age group coverage, and experience and safety profile. So these are the ones, and this is what Indian Academy of Pediatrics ACVIP recommends it 2 dosages, 9 months to 23 months, between a gap of 3 months, and after 2 years you are supposed to give only 1 shot up to 55 years age. This is your chart, and if you absolutely forget to vaccinate a child at this 9 month age, you always have another chance to give it at 12 to 15 months and third chance at 15 to 18 months. But try to give it as early as possible below 2 years of age, because the disease burden is much higher below 2 years of age. Otherwise giving it later wouldn't really help the kid, right? So, and what are the indications? This vaccine is not for all vaccine, right? This vaccine, ACVIP says, is a vaccine to be given for only high-risk babies. That's for public domain. When it is to be given into a government schedule, it is said to be given for high risk. But in private practice, everyone is high risk for all of us. You know, every kid is important. So on one-on-one basis, you can talk to them and you can always tell. But despite that, what are the indications for high risk? It is one which the children with terminal complement component deficiencies, the children with functional or anatomic asplenia or hyposplenia, children who have HIV, and those students who are trying to go abroad for their adolescent education, and then perhaps the epidemic or outbreak situation where you need to use these vaccines. So what is more important is, which we are lacking as a clinician, is surveillance. This is the 6 steps guideline: detect and report a case, collect the data, investigation and confirmation, analysis of interpretation and data, response linked to public health program, feedback and dissemination of results. So what is more important is, if we do not get ourselves into last 2 minutes. So this is all the key. Now I'll take just 2 more minutes to complete my role in this pediatric intensive critical care conference. They both are managing a critical baby in their ICU. One is saying that I have saved him, but I'm afraid to advise vaccination about this particular kid who was sick, serious, critical. Now what are the scenarios that I'll just check upon? Now vaccination of this is for all intensivists who, just now we were talking about, Vishwanathan was talking about giving steroids. So we have all those diseases which have to be given biologicals, which have to be given steroids, and other scenarios where you counter all critical babies. So these are few guidelines for all of you. One is, if a child is getting less than 2 milligram per kg of a steroid for a below 10 kg baby, or less than 20 milligram per kg per day of a steroid for about 10 kg baby, the child is not immunosuppressed, right? You can give all the vaccines, killed and live. But if the child is getting more than 2 milligram per kg for a child of below 10 kgs, or more than 20 milligram per day for about 10 kg babies, for less than 2 weeks, this child still is not under immunosuppression. This child will get all those vaccines live and killed. But the third scenario, the child is getting more than 2 milligram per kg for a less than 10 kg baby, and more than 20 milligram per kg for more than a 10 kg baby for more than 2 weeks. It is said to be an immunosuppressive dose, and in such scenario, you are not supposed to give your live vaccines, you are supposed to give only killed vaccines. If at all you want to give a live vaccine, you have to stop this steroid regime, wait for 4 weeks, and then give live vaccines. Now, no live vaccines till 1 month after stopping steroids. Second is, killed vaccines are safe, but they are less immunogenic. And the third is, if the patient is on alternate day steroids or on inhalational steroids, this child is not under immunosuppression, can get any live or killed vaccines, right? Now, the second scenario is, somebody was talking about rituximab. Now, this rituximab is again something which actually depletes all the memory cells. So if a child was on rituximab, you are supposed to give an age appropriate vaccines scheduled to be restarted. The child becomes immunologically naive, and then you have to restart all the vaccines that you have given him before. So after 3 months, you can start giving first dose of influenza vaccine, which is a killed vaccine. Second is, after 6 months, you can start giving other killed vaccines, and you have to wait for 1 year after the rituximab has been given for starting the live vaccines. Another aspect is biologicals. We were talking about other anakinra, we were talking about all Zumabs, we were talking about anti-IL-6. So sirolimus, everolimus and anti-TNF alpha. So these are the new drugs now. You people are going to use it. So if you are going to use it, so you need to be very careful. Live vaccine should not be administered at least 4 weeks before initiation of these biologicals. Second is, live vaccines are not contraindicated during the therapy, are contraindicated during the therapy. During the therapy, you are not supposed to give it. And you have to wait for 3 months after cessation of this biological treatment to give the live vaccines. So this is what you need to follow. Now, if a child is on a chemotherapy for acute lymphoblastic leukemia, let us see what recommendations. All household contacts should be fully immunized with age-appropriate vaccines. Somebody has a ALL in the family, you have to take care of the other household contacts. Give them all vaccines. Household contacts of immunocompromised child should not receive this transmissible vaccine, which is OPV. If a child has ALL in the family, the others should not, any one of the others should not receive OPV because it's a transmissible vaccine. And the third is, avoid direct contact with susceptible household contact. If someone has been given varicella and erupts some rash, you have to avoid contact with that particular. And the last is, if you have given rotavirus vaccine, the hand hygiene has to be maintained very properly. Otherwise, it is again a transmissible vaccine, right? Now, if a child is on maintenance therapy of ALL, how would we proceed? We would go ahead and, we can give vaccines only after the remission, 1 year after the remission of ALL. Second is, platelet count should be more than 1 lakh of absolute lymphocytic count should be more than 700. May need to stop chemotherapy for a week before and after giving this maintenance therapy. Now, coming to the completed chemotherapy, let us see, in general, if a child has completed his chemotherapy and he comes to you in your clinic, what are you going to advise him? You are going to advise that all age-related boosters have to be given to this particular child. Live vaccines are contraindicated during first 12 months after the end of chemotherapy. Non-live vaccines, all the killed vaccines, you can give it after 6 months of time. Annual flu vaccine can be given even during chemotherapy and soon after the chemotherapy. So this is how you would proceed if a child has already received a chemotherapy for any kind of malignancy. And this is about hematopoietic cell transplant And you could see here, all the recipients of HSCT are almost immunologically naive. They do not have a memory cell. So once this has been done, you have to restart the schedule of all the vaccines. So age-related boosters you need to give. This is what you can first start influenza vaccine after 3 months. You can start all other live killed vaccines after 12 months, and live vaccines after 2 years after this HSCT. But if you have encountered a GVHD, then probably all the vaccines have to be deferred still further. So this is what. And the last is planned splenectomy. Now how should we approach? Somebody is come to you for a planned splenectomy. If you have a chance to, you complete all the age appropriate live and killed vaccines 2 weeks prior to the planned splenectomy. If emergency splenectomy happens, you have to wait for 2 weeks and then you restart this. And probably you will cover up all the encapsulated organisms, vaccines against all the diseases which are caused by encapsulated. And this is a child with hemophilia, nothing to be done. Give a pressure, wait for 10 minutes and give it. Because if there is no such hemorrhage which is happening or bleeding which is happening, sustained pressure. And then where appropriate, you can use subcutaneous and vaccination after factor replacement therapy. And in platelet disorders, firm pressure have to be given. So this is all about some scenarios which you can come across in your PICU. Last but not the least is IV gamma, blood transfusions, all you have to give it again and again. In such situation also, there is a time frame you have to wait for giving a live vaccine, because after giving certain antibodies, you are not supposed to give live vaccine for a certain time. So there is a table given beautifully which you have to follow. See, roughly around, it depends upon the dose of antibody that you give it to the child. So thank you so much, friends. Thank you so much.
Thank you, Dr. Ganesh Kulkarni, Dr. Nivedita Patil, and Dr. Shilpa Kodukar Dagde. Kindly proceed for felicitation. Ladies and gentlemen, all good things should end, and so we have to say goodbye on behalf of the scientific committee team and the organizing team of Mahapedicriticon 2024 Solapur. Big thanks to all the delegates, especially those who stayed till the end. Have safe travels.
Dear delegates and faculties and those present here, I request you to remain in the hall itself for next 5 to 10 minutes for the valedictory function.
Good afternoon, everybody, and today we are coming to the end of the conference. I request all the organizing committee members of the Mahapedicriticon to become on the dais, please. Hardly will finish in 5 minutes. All the organizing committee members, please come on the dais. Dr. Nakate, Dr. Kundan, Dr. Anna Sahib, Dr. Keyur. Please be fast, please be fast. Dr. Vikram, Scientific Chair. Dr. Sunil Vaidya, Dr. Revankar, Dr. Chakre, Dr. Arkal, Dr. Samir Khan, Dr. Pratibha Patil, Dr. Chakre, Dr. Vikram, Dr. Boli, Dr. Dabde, Dr. Rajasri Meru, Dr. Manjusri Chavan, Dr. Nitin Rathi, Dr. Sandeep Khade, so this is just a valedictory function on behalf of the Maharashtra State IAP chapter. Before my 2-minute speech, I request Dr. Atul Kulkarni on behalf of Central IAP, not on behalf of local Solapur IAP. He will give the appraisals as well as the votes of the thanks from the Central IAP regarding conducting this mega event. Dr. Atul, please. and if suggestions. Atul.
Good afternoon, everybody. This is the end of the conference. Last 3 days we had a wonderful sessions. First day we had workshops. Then last 2 days we had a very good scientific sessions. Also, banquet was also going on for till 1 o'clock. So it was a wonderful conference. Actually this is a critical care conference, so definitely the student population were more in this conference, and it will be like this only because the younger generations are going to handle the more and more critical cases. What has happened to this critical care conference or subspecialty conference is it is becoming more and more regional because from the same region we are getting the delegates. And the faculty which are coming on from the bigger cities, and this will be there, and this is the fact probably, and the attendance will be around 200 to 300, and here we had a attendance of more than 200, so I think it's a good
220 and online
220. So it was a good response from this conference. I congratulate the central team, Maharashtra. Dr. Sanjay Ghorpade and Patki and entire team. Also, I would like to congratulate our own team. I am really proud. We had a very successful conference, president by Dr. Vaidya sir, then organizing chairperson Dr. Nakate, our 3 musketeers, our 3 organizing secretaries, Kundan Chopade, Keur and Samir Khan. Then our president, Anna Sahib, he has done a wonderful job. Also, his banquet was very excellent. Then another person who was behind the screen, never on the stage up till now, he is here. Dr. Nitin, he has done a wonderful job. A big round of applause for Nitin as a treasurer. He is doing for last so many years. Then the most important is the scientific committee, Dr. Vikram Herekirur, Rajeshri, Manisha, and entire team. They have done a wonderful job. Also, all the master of ceremonies, our students, they have done an excellent job. So, congratulations to all of them. This is the feedback. Thank you very much.
So I want only 2 feedback. First feedback will be from the postgraduate student, one of the postgraduate student, and we want a critical feedback because see, day by day we are improving to the science of the conference, whatever required for the pediatricians as well as the postgraduate. Anybody from the PG groups? Yes, come forward. One of the postgraduate resident. Anybody, you can talk freely. Just come ahead. Come forward and what the things you want in the subsequent conferences, and you can tell anything. Yes, please come forward.
सर्वप्रथम सगळ्या शिक्षकांचे, सगळ्या ऑर्गनायझिंग टीमचे अभिनंदन आणि आम्हाला छान शिकवल्याबद्दल सुद्धा अभिनंदन. I am a student of this college, Ashwini Solapur, and these are all my teachers and faculties. It was very great honor for me and others also to attend the conferences like Criticon in city of Solapur, and all the workshops are very wonderful. I have done the focus workshop. Vikram Herekirur sir has worked a lot for 1.5 months for smoothly undergoing this workshop, and this conference is also very good, and I have attended 2 to 3 conferences. It is one of the best conference till I have attended, so thank you all of them. As a improvement, we can conduct more hands-on in ventilation workshop and more live patient based like focus workshop. Focus workshop is totally hands-on. Actually, newborns are also there. So ventilation workshop is more hands-on and more patient based and more live. So it will be better for all of them. Thank you so much.
Yeah. Only thing actually, the important thing like feedback that is given. So from the next time, we will restrict the number of delegates for the workshop. No more, not more than 40, and as far as possible, workshop will be on hands-on training. One feedback from the pediatrician, Dr. Jai. We want a critical feedback too, because we don't want any appraisals. Huh?
Thank you, Sanjay. He's happened to be registered at Medicine and Pediatrics at VM Medical. Thanks for calling me here. First of all, my critical feedback, there's an excellent venue, excellent banquet, right? There's a part of conference, but I see थोडं चेंज केलं पाहिजे असं वाटतं मला. केस बेस व्हायला पाहिजे. एव्हरीथिंग मी थेरॉटिकल कमी करून रादर आय थिंक शुड बी, कारण बरेच जण म्हणते ठीक आहे देर आर PG स्टुडंट्स आर देअर. Suppose they are second year, third year student, they will understand about the cases. And all pediatricians are already working as a consultant, right? And what the workshop already said, workshop आज जे मी गंगारामाने ऑल इंडियाला एम्स जे अटेंड केले की त्यांचं बुकलेट अगोदर येतं म्हणजे कंटेंट, सो दॅट 1 month प्राय जर तुम्ही ते बुकलेट दिलं ते करता येईल. आणि आय डोंट नो इधर सायम्युलेशन लॅब इज नॉट अवेलेबल, बट सपोज वॉन्ट टू गिव्ह अ क्रिटिकल केअरची जर कॉन्फरन्स करायची असेल तर सायम्युलेशनचं वर्कशॉप पाहिजेच पाहिजे. आणि सगळ्या युनिव्हर्सिटीमध्ये ज्या ठिकाणी आहे, ज्या ठिकाणी इंटरनॅशनल युनिव्हर्सिटीमध्ये टायअप करतात त्यांच्या कंपल्सरी त्यांना सायम्युलेशन लॅब असणं त्या युनिव्हर्सिटीमध्ये का कॉलेजमध्ये गरजेचं आहे. सो आय कॉंग्रॅच्युलेट माय ओन टीम ॲज अ पार्ट ऑफ द क्विज मास्टर ॲज वेल एज अ डेलिकेट. आणि ऑलवेज आय फील टू कमिंग हिअर. मी ॲक्च्युली 5 दिवसापूर्वी फक्त रजिस्टर केलं आणि मी अचानक आलो, बट आय एन्जॉयड हिअर. तुम्हाला ते माझं घरच आहे इथं. आय वॉज माझं सगळे म्हणजे आय केम हिअर ॲज टू मीट द फ्रेंड, ग्रीट अँड एन्जॉय द वर्कशॉप अँड द कॉन्फरन्स. थँक्यू व्हेरी मच. धन्यवाद. And take this now critical, everything was fine. जे मला वाटलं की we got I think 2027 ची जी आहे रायगड IPL विल द होस्ट फॉर दिस महाकेटिकॉन, आणि तेव्हा सगळ्यांना यायचं. यावेळी महानियोकॉन आम्ही केली. वी गॉट 450 रजिस्ट्रेशन एज अ रेकॉर्ड ब्रेक इन द हिस्ट्री ऑफ महानियोकॉन. थँक्यू व्हेरी मच.
एक 2 मिनिट, 2 मिनिट थांब. हां, सो बिफोर एंडिंग दिस small valedictory function, on behalf of Mahapedicriticon, just the feedback given by the Jay was definitely considered. That means simulation lab is a new concept, and if possible that will next time we will include. And 1 month manual, that is actually a good idea, because at least those who are going for the workshop will read all the things. So friends, on behalf of this Maharashtra State Pediatric Critical Care chapter, we announce the next conference will be at Pune again in the month of June. That will be the 2 or 3 days event, and with the more and more advanced workshop, good science, and the team of the Pune IAP rather than Pune Critical Care chapter is hosting this conference. Last year we already realized that they have already done the Pedicriticon, and next year they are doing the Mahapedicriticon in the month of June, and from the January rather than December itself they will start working the process. So friends, on the behalf of the state, Maharashtra State Intensive Care chapter, we are very much thankful for the Solapur IAP, a team mentored by Dr. Atul Kulkarni, led by Dr. Nakate, Dr. Vaidya sir, Dr. Kundan, Dr. Anna Sahib, Dr. Keyur, and all the organizing committee members for this excellent conference, excellent venue, excellent banquet, and of course beyond imagination scientific program. See the authority faculty even today also, during the lunch the hall was full, and the variety of the topics they have covered, a pediatric subspecialty intensive care, including rheumatology, just counseling part, and what else, because really whenever we are learning in this National Pediatric Critical Care Conference, at par the science was going on since last 3 days with the 3-4 workshops with all the stalwart faculties. Definitely it is wonderful conference. A big round of applause for this IAP Solapur. Yeah, and organizing team. Hip hip Solapur IAP. Hip hip. Hip hip. Hip hip. Okay, thank you, and have a national anthem, and we will finish that agenda. So all the delegates come on this stage so that everybody will have a group photograph, and then we'll proceed for the national anthem. Thank you.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता।